Check one. Hello, check. Hey, one test. Hello, check. Check test. Podem मिटाय. Hello, check. तिकडून पण बंद आहे. Hey, one test. Hello, check.
Hello, hello, hello. Mic check. Hello, 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 hello. Mic check. Hello, hello, hello. Mic check. Hello, hello, hello. Mic check. Hello, hello, माइक चालू. हे माइक का आवडतो ना. ए रुक रुक डीके रुक. आ साउंड. हेलो, हेलो. माइक चेक. हेलो. आपको साउंड आ रहा है अंदर कैमरा में? हेलो, हेलो. माइक चेक. हेलो, 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 हेलो. माइक चेक. हेलो, हेलो. रेडी.
Hey, hello, check. Check test one. Hey, hello, hello, check one, one. Check one. Hey, hey, test. Check. Hey, hey, check one, one. Hey, hey, hello, check one, one. Hey, hello, check. आ रहा है ना? Check one. Hey, check one. Hey, hello, hey, check. Check one. Hey, hello, check test.
हैंड माइक है, हैंड माइक, हैंड माइक। I think we won't need a mic also. Thank you.
chairperson and speakers. Audience. स्टार्ट करते. हेलो हेलो. तो good morning all of you, and the first session. So we'll be talking about today on Hope Symposium. We'll be talking on various aspects of hypoglycemia. For our first talk, I'll be inviting Dr. Alka Gandhi, who is from Mumbai, founder director of Ayushi Diabetes Clinic, consulting diabetologist, Yamaha Hospitals, and also a speaker at various national conferences, RSSCI Diabetes India, and Dr. Alka will be talking on managing hypoglycemia in high risk group, that is elderly, steady, post disease. So over to you, Alka.
Thank you, Imran, and good morning, everyone. So we are going to discuss hypoglycemia. So we all know that hypoglycemia is a very important complication that we face. Slides. Classically, that means there is and symptom corrected by giving, and you demonstrate blood glucose levels diabetic. But if it's diabetic, you demonstrate because the signs and section that the having hypoglycemia. Classical trials which finds there are three levels of level 1 and the symptom is checking and it makes the doses. Second is and it for clinic international hyper and this may episode cardiac grade 3 and pessimic. Our aim help in healthcare. What if hypoglycemia? There is few hypoglycemia adherence affects daily affects the complication cost. So ultimately, their aim glycemic control have to also see that we have to avoid hypoglycemia. Hypoglycemia bad memory. There may be confusion, stress. Also, there is economic that there is a psychological and there is increase. That is why hypoglycemia, especially high risk group like elderly. When we see elderly, it adults 5 years of age, and classically type 2 diabetes, half of all the individuals elderly has a way underlying causes like sarcopenia. What happens is that because of age, there may be cognitive impairment and symptom management. There is a loss of daily activity and there is self-managed diabetes and respond to hypoglycemia. Patient is on polypharmacy more than 5 medications. Therefore, there are higher risk of drug interactions and especially is on beta blocker blunted out. Patient may also have renal and hepatic impairment and this alter the metabolism hypoglycemia. Along with that, if the having retinopathy and uh, impairment, all this will fall or there may inability to the blood glucose levels. Recent hospitalization again increases the risk of acute illnesses, medication changes and functional decline. Alcohol and exercise may also contribute to the unanticipated hypoglycemic episodes in this group. Uh, Dead in bed syndrome is also very common because of cardiac arrhythmias that is seen. So treatment-based targets recommend that time below range should be less than 1%. That is time below 70 milligrams should be less than 1%. So this is our aim to prevent hyperglycemia but also have less hypoglycemia in these patients. So the key roles which will be when the patient comes to you, that is the physician management, you must routinely inquire about hypoglycemia symptoms because patient may not complain, and especially if the patient is having any acute illness or any care transition, you should ask them about it. Again, optimize the medicines that the patient is taking, so check the OHAs or the insulin that the patient is taking and adjust the dose of the drugs which are causing hypoglycemia. Nutritional assessment of the patient. If the patient is not Many a times the patients are just given, ectrapid when the patient is discharged, even post bypass. There is just ectrapid on the discharge, and that too patient is it is written 888. If more than 200, make it 10. More than this, but that is not going to cover and give us good results. So that is why it is also important to educate the patient according to how to adjust the blood glucose levels according to the doses according to the blood glucose levels. The second and important aspect is hypoglycemia in patients with CKD. So again, we know that patients who are having diabetes and CKD are at increased risk of hypoglycemia, almost 8.5 times increased risk compared to those without diabetes and CKD. This happens because there is impaired renal gluconeogenesis, there is altered drug metabolism, there is malnutrition which causes reduced appetite, and there is blunted counter-regulatory hormones. So again, KDIGO has updated the management plan. Of course, physical activity and nutrition is the first part, and then if the depending on the EGFR, you reduce the dose of metformin. If it is less than 30, you can discontinue. SGLT2 inhibitor, again, if less than 30, do not initiate, and if the patient is on dialysis, discontinue. And again, all the other groups like GLP-1, DPP-4, or insulin SUs, depending on the patient preferences, presence of comorbidities, EGFR, and cost. So this is how you can adjust the medicines in patients with CKD. So overall, if we consider management of hypoglycemia, I am sure none of you in this crowd need this slide. So acute management, yes. You give this is 15-15 test. So 15 gram of fast acting carbohydrate, wait for 15 minutes, recheck the blood glucose levels again. If the patient is unconscious, again either glucagon injection or IV glucose if possible. And if the patient is having hypo due to sulfonylurea or long acting insulin, then the risk may persist for 24 to 36 hours, especially if the patient is having should prompt to reevaluate the treatment plan and assess the cognitive function of the patient so that we can adjust the dose and educate the caregivers also. Use of CGM is also recommended. The class A recommendation is there, and the classic management of hypoglycemia by giving glucose is what the ADA is also recommended. So to conclude, hypoglycemia in elderly CKD and post-discharge patient is common but underdetected. Even mild episodes can accelerate clarity, disability, and cognitive decline. So prevention outweighs benefit of tight glycemic control in this high risk groups, and therefore focus on day-to-day stability, individualize the A1C target, simplify the regimens, and prefer newer agents with low hypoglycemia risk. Regularly reassess and monitor, preferably with CGM or structured SMBG. Thank you.
Thank you, ma'am, for the insightful talk over the hypoglycemia in special situations. We will take question answer after the session. Now I invite our second speaker for the HOP symposium, Dr. Vinay Dandania, sir, and he will be talking on publication of 25 years of clinical practices. Sir, dice is yours.
Thank you. Thank you very much for that very kind introduction. Good morning, respected seniors, dear friends, my colleagues for this meeting. I acknowledge each and every one of you for being here, and I thank the organizers for giving this opportunity. Of preventing hypoglycemia is time below range, and as you heard from her, the class A recommendation by American Diabetic Association, especially in high age group. And we all know that if you need to be on target, HbA1c less than 7%, there is an inverse relationship. As you achieve the target, there is an increase in the chances of getting hypoglycemia. Both the DCCT and the UK PDS had a very, very similar outcome. It's very important that when you are actually nearing the target, someone you are treating at the age of 8% or 7.5%, you need to take care of hypoglycemia in each and every patient treating them to less than 7. So if you see, this is a very interesting cartoon. Your blood sugars are too high. At this age, we need to start some insulin. So the patient immediately will tell something like this. So is my diabetes really bad? Doesn't insulin cause weight gain and hypos? It's a very immediate reaction which we see in our clinics. Then it should be, it should bring your blood glucose down. But if it goes too low, that's a hypo. That could be dangerous. Always have some orange juice around. And make sure you don't miss a meal because that can cause hypo. So when you say something like this, patient keeps on eating. Dr. Kulkarni was sharing this. And I tell you, there is a impulsive snacking because of fear of getting hypoglycemia. Or if you exercise too much, then that can cause a hypo. So you are putting patients on a doldrum that if you do exercise, you are in a problem. Don't eat, you are in a problem. Take medicines, you are in a problem. So patient is when you leaves your clinic is in a distress. So, okay, so I need to eat to stop a hypo, and I should be careful about exercise. What's the best way is keep eating and don't do exercise. Both ways you will forget about hyperglycemia. So introduction to diabetes for a new type 1 patients. There are again two sides of coin. When a patient comes to your clinic, tell them you need to be on insulin. And the other side, you have glucagon for them. You need to keep glucagon as well because it's likely to cause hypoglycemia. So what I'm trying to stress upon is these are patients where you have to actually address hypoglycemia again and again. Someone comes to your clinic with a HbA1c of 6, we are very happy, you are doing excellent. But believe me, someone with an HbA1 of 6 may be having asymptomatic hypoglycemia which needs to be picked up. What is the bigger problem, hypoglycemia or the fear of hypoglycemia? This we need to understand. Why we need to understand is asymptomatic hypoglycemia is there even in normal population, and that is not a concern. A lot of people sitting out here having delay in meals may have sugar of 60 and 65 and 68, but it's not symptomatic. But patients who are on hypoglycemic agents like insulin or sulfonylureas always have fear of hypoglycemia, especially when we share with them. So hyperglycemia caused by fear, then hypoglycemia is bad. It can lead to hyperglycemia-induced chronic complications and poor quality of life. And hypoglycemia is bad. You heard dead in bed syndrome, cardiovascular mortality, and quality of life. So we need to balance this. This is what is important in our clinical practice. And this can only happen when we share with our patients that we are going to balance both the perspective in your treatment. What does hypoglycemia mean to our patients? When it's symptomatic, patients are in real big distress. Or patient can have an asymptomatic, low reports, sensor detected hypoglycemia. Like Alka said, it will send you alarm. So recently I put a sensor Libre 2 Plus to one of my patients, and it's supposed to give you notifications to your mobile phone. The patient came the very next day, Doctor Saab, next time don't put this sensor to me. The पूरे रात भर मेरे को इसने अलार्म करता रहा, मेरी नींद बिगड़ गई. पी 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 बजता रहा, मैं परेशान हो गया. And my wife also got scared. She was sitting beside me that something is really wrong. And let me tell you, there are good part of it, there are bad part of it. How do we address this? It's very, very important. So there's no purpose of getting a Freestyle Libre 2 Plus, isn't it? If you switch off the alarm, that's the basic advantage of that you are having a nocturnal hypoglycemia. Even the Libre 2 Plus has the facility of switching off the alarm. And at the same time, not to forget, even the doctors get the alarm on their dashboard if you are connected with them. Yeah. So that is another challenge when you're sitting, when you are connected with your patients. So in your clinic, where the glycemic pentad deserves a prominent position in the diabetes management in India, you need to have a good fasting and a postprandial. We tell them your fasting should be less than 110, your PP should be less than 180, your HbA1c should be less than 6.5 for younger patients, 7 for regular patients, and elderly even 7.5. Your quality of life should be good. Glycemic variability should be minimum. That is what we are actually targeting today as glycemic pentad. And glycemic variability is increasingly recognized as a critical factor in diabetes management. And we know that same HbA1c can have different glycemic variability. So the triangle of diabetes care revolves around decrease, reduce hypoglycemia, limit glycemic variability. This is what is called as better diabetes management. The evolution of glycemic management is from HbA1c, other markers, to glycemic targets. Now, this is where things have evolved, and you heard in the even this lecture, has got a class A recommendation today, especially in people with type 1 diabetes. All type 1 diabetes should have a sensor to be used on a regular basis, and even on type 2 diabetes who are on insulin likely to have hypoglycemia. So time in range is effective in capturing dynamic variations in blood glucose values. The time in ranges include 3 key parameters: percentage of readings and time per day within target glucose range, which is called as TIR; time below target values, which is called as time below range, red; and time above target values, yellow. Today we are going to share some data on time below range. So this is how you have classification of hypoglycemia according to time below range: level 1, level 2, level 3. The basis of the proposed glucose levels when reporting hypoglycemia in clinical trials. Level 1 is glucose alert values of 70 or less. This need not be reported routinely in clinical studies, although this would depend on the purpose of the study. Level 2 is a glucose level of less than 54 is sufficiently low to indicate serious clinically important hypoglycemia. And level 3 is severe hypoglycemia as defined by the ADA, denotes severe cognitive impairment requiring external assistance for recovery. So these are the 3 important levels which we understand. So defining hypoglycemia in the era of CGM, it's again a very interesting slide. It's a one-dimensional versus two-dimensional definition. What I mean by that is, for type 1 and type 2 diabetes, the usual recommendation is that the TIR should be more than 70. But older or high risk individual, you can actually make it more than 50 and less than 50. This is what is been recommended, and this is really very, very patient centric and useful in your clinical settings, because what we are looking into is, if you see the time below range here is less than 1%, because you heard that senior citizens, older people have a chance of frailty, fall and fractures, which can be prevented by keeping pregnancy. Again, type 1 diabetes, you have to have, you can happy with a TIR of more, but for a gestational diabetes, it should be close to 90%. So this is what I mean to say is, this cannot be done on the basis of SMBG or by your routine clinical testing. This is on the basis of CGM. So hypoglycemia is again a very important finding in the era of CGM. And today, most of the patients are using CGM where it is available. Now, in the age of CGM, what is hypoglycemia? This is what I was saying. This is what we get on our dashboard. Patients who are using Freestyle Libre and the Libre 2 Plus, the doctors get this data on their dashboard, and you can actually share with your patients if they are very bad, and you can tell them to prevent and take preventive cares. And less than 70, less than 60, and less than 50. The summary of the glucose metrics over a 24-hour period, find that all participants is 1.1, but as the age progresses to more than 60, the chances of getting time below range is higher. So this is the overview of the study called as the hypometrics. It was published from NHS. It was done in, I think, 2007. First study to actually address hypoglycemia. It was a multinational, multi-center observational study, part of HypoResolve Consortium. Hypometrics aims to provide an evidence-based definition of CGM hypoglycemia and further our understanding of the clinical, psychological, and health economics impacts of hypoglycemia. And all 602 participants across 9 sets, they actually included 800, but 602 continue on this across 9 sites. Adults on insulin who had experienced hypoglycemia at least once in last 3 months were included. And after the 10 weeks, you will find the participants wore a blinded CGM and continued their usual form of glucose monitoring. Sensor-detected hypoglycemia was defined as a glucose reading below the threshold of 70 or more than 15 minutes in accordance with the ATT consensus documents. And here you will find very data that episodes of person-reported hypoglycemia were recorded on the hypometric. There was a smartphone app, and the patient to report on them. Person-reported hypoglycemia was defined as a symptomatic event that resolved on carbohydrate ingestion or a self-measured glucose less than 7 grams per deciliter. This was recorded. And sleep status was also recorded. Echography was the device which was being used. And they actually recorded the sleep status, the Fitbit Charge 4. This allows us to assess the impact of hypoglycemia based on sleep. Activity levels and heart rate were also recorded. Now, if you see this graph is very, very interesting. You have a CGM graph, you have a step count, and you have a heart rate. All three included here. And you will find as there is a drop, the red right here, drop in the blood sugar, there is a change in the heart rate. There is a tachycardia, which right here. These are all asymptomatic sensor-recorded hypoglycemia, but patient has got tachycardia in response to that. And this is what is happening, what Alka was talking about, something like death in bed syndrome. Reported specifically in type 1 diabetes who don't understand hypoglycemia, especially at night time. So definition of sensor-detected hypoglycemia was 15 minutes below the threshold, that is less than 74 and 40 according to the severity. And person-reported hypoglycemia was defined as symptomatic episodes that resolved on ingestion of carbohydrate or a measured glucose value less than 70. This is the overview of the study. Almost 40,000 days, 1,60,000 check-ins, just under 1 million hours of CGM data, equivalent to 102 patients' years of CGM. And here again you will find that type 1 diabetics had a higher chances of getting, were recorded higher numbers of hypoglycemia compared to type 2 on insulin. And sensor-detected hypoglycemia was higher compared to the patient-reported hypoglycemia, especially in the type 1 compared to type 2. So how do sensor-detected hypoglycemia and patient-related hypoglycemia relate is that sensor-detected hypoglycemia is always higher, and it should be clubbed together to understand what actually the patient is getting. Why I'm saying this is many a times if you start a new sensor, patient will get a hypoglycemia for a day or 24 hours. And that actually gives you an alarm and it's a scary data. And that is not symptomatic, that needs to be confirmed using your ASMB. So this is how you actually change see type 1 and in type 2 the percentage of sensor-directed hypoglycemia versus in people with diabetes. Impact of nocturnal hypoglycemia on daily function. This was again a very interesting data which came from the study was the patients getting nocturnal hypoglycemia, as I said, without getting any symptoms, will find there were 10 domains which were actually included: sleep quality, overall mood, energy level, cognitive functioning, fear of hypoglycemia, negative affect, fear of hyperglycemia, productivity, memory, and social function. You will find almost all these domains were impacted if the person was getting asymptomatic nocturnal hypoglycemia. And this was one area which was actually sensor-detected hypoglycemia, which was, you see the graph, it was also both in type 1 and type 2 diabetics, domains were affected. So this was the effect of threshold on the rate of sensor-detected hypoglycemia per week. So you can imagine how important it is to pick up asymptomatic hypoglycemia using a sensor. So this was the impact. Asymptomatic, there was no biological impact, no impact on well-being. Symptomatic patients, there was no biological impact, but there was a negative impact on well-being, quality of life. And if you see again, negative impact on biological impact, no impact on well-being if the patient has got severe hypoglycemia, even with the sensor. And symptomatic, there was both biological impact and negative impact on well-being. So there is a big psychological impact. As I said, the wife sitting the whole night, the husband sitting the whole night and seeing the data from the notification from the sensor actually impacts the psychosocial life. So preventing hypoglycemia is the key. If it is going below 90, anxiety, annoyance and inconvenience, and if it is going beyond 80, again, along with this, have symptoms or counter-regulatory response, and if it is less than 55, confusion, panic, and reduced consciousness, counter-regulatory response, if autonomic function is intact. If it is not intact, again there is a problem, cognitive and inflammatory response and platelet activation, and less than 40, confusion, panic, reduced consciousness, possible seizures, counter-regulatory response, all these things are very, very common. So the important thing is we need to educate. Pressure lows, what do you mean by pressure lows? I have a sensor on my left arm and I sleep the whole night on the left arm. It gets pressurized, the interstitial fluid doesn't change, the vascularity is reduced, get poor readings. Interstitial fluid lag time, we all know there is a lag time in people who are using sensors, especially diabetics. Even in the physiological state, there is a lag time of 5 to 6 minutes in normal individuals from the interstitial fluid and the capillary blood. But in patients using sensors and diabetics, it could be even 15 to 20 minutes. Inaccuracies within the first 12 to 24 hours, especially hypoglycemic readings in first 12 to 24 hours, we need to tell our patients, hold on for a day. They actually throw it off and come to your clinic. Hamara to isme reading kharab hai, the sensor is bad. Every reading is 40, 50, they come with the sensor and you actually have to replace it without any charges. Skin sensitivity issues, adhesive issues, interfering substances are being used, sensor to sensor variability. Recently, one of my friend, Suresh, he put Libre 2 Plus on one hand and Libre 1 on the other hand, and he could actually publish the data on our group with two different readings. And this is a very common phenomenon. They have a comparative study with a Dexcom sensor on one hand, the Libre on the other hand, a big change in the sensor reading. There are lots of other factors which are affecting glucose that can interfere with your data. So to summarize, most episodes of sensor-detected hypoglycemia are asymptomatic, and many symptomatic episodes occur at glucose levels more than 70, irrespective of HbA1c. Asymptomatic episodes do not produce measurable reduction in quality of life. The technology-alerted events have similar negative impact as symptomatic events, and maybe we can be more permissive of reading 80 and reduce the fear of hypoglycemia. I thank you all for your patient listening, and I thank once again the organizers for this opportunity. Thank you.
Thank you, Dr. Vinay, for an elaborate talk on time below range. We discussed after the session. Next speaker is Dr. Balaji Jagmohan from Bengaluru, attached with Apollo Sugar Clinics, Bangalore. So, been awarded as the best center, so best diabetologist, patient diabetologist year 24 of 7. And today, Dr. Balaji will be talking on.
Thank you, Chairpersons. So at the outset, I'd like to thank Dr. Manoj and Dr. Purvi for having had invited me. It's indeed a pleasure to be back here. I grew up in Mumbai. I've lived here for 30 years. Now I've settled down in Bangalore. So it's nice to always be here. So my topic is actually incretins and hypoglycemia. We all have been using incretins for many, many years now. It's almost 2 decades since the DPP-4 inhibitors have been launched in the country, and of course now we have the GLP-1s, we have the GLP-1 receptor agonists. So all these drugs are something that we commonly use in our practice. Now I'll try to highlight whether these drugs either individually or in combination pose a risk of hypoglycemia from some of the published data. Now hypoglycemia, my previous speakers have already alluded to, that you have 3 levels: below 70, below 54, and below 30 you go into the stage 3, which is neuroglycopenia, where you require third-party assistance, and that can be detrimental. It can lead to the death in bed syndrome as well. Now, what are the drugs that generally predispose to hypoglycemia? So generally insulins are very notorious. You all know that basal bolus insulins, premix insulin, especially the older ones, human insulins carry a higher risk or higher propensity for hypoglycemia. The incretins, they do have a minimal risk if given individually or as a monotherapy, but if you combine them with a sulfonylurea or with an insulin, then we know that the risk automatically increases. Now everybody here understands the incretin effect, right? So an oral carbohydrate intake produces a much higher insulin secretion as compared to an IV administration of glucose. This was the one that was first demonstrated, and researchers could understand that we have certain cells or certain hormones in the gut that are responsible for this effect. And thus came the discovery of DPP-4 inhibitors and then GLP-1 receptor agonists. Now, talking about GLP-1 receptor agonists, what is their mechanism of action in trying to reduce the blood sugars? Now we know that GLP-1, they have a glucose-dependent insulin secretion. That how much the blood sugar is rising, only that much insulin will be secreted. Now these are all the receptors, the GLP-1 receptors, which you find on the alpha, beta, and also the delta cells. We know that delta cells, they release somatostatin, which depending on the blood sugars might stimulate an insulin secretion or might stimulate a glucagon secretion. So GLP-1s, mainly they act through the PI3K AKT pathway. This is the main pathway that is responsible for this glucose-dependent insulin secretion. So what do they do by this? They try to reduce the fatty acid oxidation, they reduce the hepatic gluconeogenesis, and they improve the energy expenditure in the peripheral tissues. Also, they have another function within the beta cells. They can try to reduce the apoptosis. That is one of the reasons why, if you see in most of the studies, incretin drugs like GLP-1s, they can preserve the beta cell function and the beta cell mass. Now on the delta cells, they bind and they will again try to stimulate more of an insulin release, and somatostatin in turn will try to inhibit the alpha cell release of glucagon. Now GLP-1 action on glucagon is only in the hyperglycemic state. It's not in the hypoglycemic. In the hyperglycemic state, it will blunt the alpha cell release of glucagon, and on the other hand, the beta cell stimulation of insulin release. In a nutshell, this is the main action through which GLP-1s bind to the receptors on the alpha, beta, and the delta cells to regulate the blood sugar. What about GIP? GIP, on the other hand, has got a dual action. So we know that when there is hyperglycemia, it will act on the beta cells to stimulate glucose-dependent insulin secretion. But when the blood sugars are going into the euglycemic or maybe the hypoglycemic state, then automatically it will try to stimulate, it will bind to the receptors on the alpha cells and stimulate the release of glucagon. So it's like a switch action it has. Hypoglycemia, insulin action. Hypoglycemia, you have the alpha cell glucagon release. So this is the main action of GIP. So GLP-1 basically does not have any action during hypoglycemia. It is purely dependent on the counter-regulatory hormonal response. If a patient has autonomic neuropathy or if the other counter-regulatory hormones are lesser, then the patient on a GLP-1 receptor agonist might still experience hypoglycemia. So it does not have an action on the in hypoglycemia to try to raise the blood sugar. Now I'll come to some of the clinical studies. Now this is evidence from a meta-analysis, and here what is seen is that alpha glucosidase inhibitors, SGLT2s, thiazolidinediones, DPP4 inhibitors have the lowest risk of hypoglycemia. The highest risk is seen with sulfonylureas. The odds ratio can be as high as 6.5. Also meglitinides, slightly lesser than sulfonylurea, but still the risk is high, around 6.3. So there is something called the SUCRA rating, which rates the level or the intensity of hypoglycemia, and it is seen that DPP4s and thiazolidinediones carry the lowest risk of hypoglycemia. Now talking about DPP4 inhibitors, some of the CVOT trials that have been completed, and if you see in all these trials, whether it is sitagliptin, Saxa, Lina, Allo, or even vildagliptin does not have a dedicated CVOT trial, but from whatever RCTs and the VIVID trial, it is seen that hypoglycemia as a monotherapy is very, very minimal. And you know that in the Savartimi, there's an increased rate of hospitalization, but that was not due to hypoglycemia. It's mainly a heart failure outcome. Similarly, allogliptin, slightly increased rates of heart failure hospitalization, but not due to hypoglycemia. Now, sulfonylureas, if you combine it with DPP4 inhibitors, then that automatically increases the risk of hypoglycemia. So this again is a meta-analysis, and you can see that it's better to give a monotherapy which favors the placebo as opposed to a DPP4 with sulfonylurea. So across the trials, when you combine it with sulfonylurea, the risk of hypoglycemia, the pooled risk ratio can be 1.66, confidence interval between 1.34 to 2.06. Now, other thing what they found out in this meta-analysis is that the hypoglycemia risk with the sulfonylurea DPP4 combination is dose dependent. If you give a lower dose of sulfonylurea, let's say glimepiride 0.5 or gliclazide, let's say 30 milligram, then even in a combination, the risk is much lower as opposed to giving glimepiride at 4 or 8 milligram or gliclazide even 120 milligram. So dose dependent risk when you combine a sulfonylurea with a DPP4. So they've concluded here that if you initiate with DPP4 as a monotherapy, the risk is much lesser, but if you combine with a sulfonylurea at a higher dose, then the risk can be much higher. Now looking at all the OHAs which I've already mentioned, so sulfonylureas and insulin, you can see here, they carry the highest risk. So exogenous insulin administration and sulfonylurea at higher doses, whereas the lowest risk of hypoglycemia has been seen with the GLP-1 receptor agonist, SGLT2 inhibitors and DPP4 inhibitors. The relative risk is 1. Then followed by that thiazolidinediones, glenides, and then like I said, urea, insulin, highest risk. Now talking about another meta-analysis. This was with GLP-1 receptor agonists, and they wanted to compare with DPP4 inhibitors and with insulin, what is the relative risk for hypoglycemia. Here again, you can see here in this forest plot graph that basically in all the trials, GLP-1s carry the lowest risk when you have to compare it with insulin. And similarly here, the 3.2 graph with DPP4 inhibitor, slightly higher than GLP-1, but again much better than insulin. Talking a little bit about the perioperative use of incretins. I'll talk first on DPP4 inhibitors. So these are non-critically ill patients who have been hospitalized in the medical or surgical ward. And here there were two groups. So one is the basal bolus group, another is the DPP4 basal insulin. So is that better or comparable with basal bolus? If you see in this graph here, the blood sugar control was almost similar, but main benefit was hypoglycemia. So if you combine a DPP-4 with basal insulin, then the hypoglycemic events are much lesser as compared to basal bolus regimen, whether in the general medicine wards or even in the surgical wards. Similarly, the lower graph here, the bottom hand graph, here again linagliptin with basal insulin versus basal bolus for patients who have undergone a non-cardiac surgery. This again is data from an RCT. Here again, the glycemic control was similar between the groups, but hypoglycemic events and episodes were much lesser with Lina basal as compared to basal bolus regimen. And lastly, there's also real world data which says if you combine a DPP like Lina with basal, then the effectiveness is same, but hypoglycemic rates are much lesser as compared to basal bolus. Now CABG is something that many of our type 2 patients routinely undergo. So here again in CABG patients, if you use a sitagliptin, there are some instances of post-operative hyperglycemia. So sitagliptin could not prevent that. But what it did help was the insulin requirement during the perioperative period was much lower, and also the hypoglycemia was much lesser. So this can be one benefit. Patients have to be put with sitagliptin and a basal insulin during the perioperative period in CABG patients. Now talking about GLP-1s and perioperative, whether pre, intra or post-operative use, this again is a meta-analysis. So here again they've seen that glycemic control was definitely in favor of GLP-1s, but hypoglycemia was the main benefit. So if you see the odds ratio, it's only around 0.6. And also the requirement for rescue insulin administration was significantly lesser in these patients who took GLP-1. So thereby this is the benefit you can get in perioperative patients. But these are some things, red flags that have been raised, which we have to be careful about. The risk is you can have GI symptoms. So there is, that delayed gastric emptying, so elevated gastric residual content. That's one of the high risk for odds ratio. But benefit is lower insulin requirement, there's a good blood sugar lowering, and mainly the benefit of hypoglycemia that can help most of the patient. But only thing is the patients can have nausea, vomiting because of a reduced gastric emptying. So that's something we have to be careful about. Lastly, I'll talk about a recent meta-analysis. This was done in 2025. So here it was done in all adult type 2 diabetic patients, and they've compared the use of GLP-1s to placebo, and the patients have taken the drugs at least for a period of around 2 months, and they wanted to see the key outcome was hypoglycemia risk with all the GLP-1 receptor agonists. So almost 26,000 type 2 diabetic patients were studied here. And in this study, they concluded that semaglutide, which is one of the newer GLP-1, whether oral or injectable, had a higher risk for hypoglycemia, followed by exenatide. Relative risk is 4.6 and 3.3 as compared to all the other GLP-1 receptor agonists. So in this critical analysis, they have concluded that you need to be a little careful with sema and exenatide. Exenatide, any which ways, we don't use here for hypoglycemia. So again, deep diving into this meta-analysis. So they're saying that if you compare it with all the other traditional drugs, so liraglutide and lixisenatide, which is still there in our country, there the hypoglycemia risk is much lesser. Also with dulaglutide. So they're saying from this network meta-analysis that tirzepatide again had one of the lowest risks. The sema and exenatide BD had slightly higher risk. So you have to be careful about hypoglycemia here. Now looking at some of the guidelines. Now guidelines have recommended if you want to use GLP-1 receptor agonists in obese people. So one is in obese people with type 2 diabetes. If they are already on insulin, if they are taking sulfonylureas, then you need to monitor them closely. The risk of hypoglycemia can be there. You might have to reduce the dose of sulfonylurea and insulin if you need to mitigate this risk. And if these obese patients with type 2 diabetes, if they are in the perioperative period, then the aspiration risk because of GI side effects can be higher. There you might have to hold the GLP-1s or bridge it with other agents. Similarly, if you look at GLP-1 receptors in obese people without diabetes. So the risk generally for hypoglycemia is minimal, and if they're also undergoing a surgery, only the aspiration and GI side effect risk is there. So at those instances, you might have to hold the GLP-1. Looking at some of the other clinical trial data, GLP-1 receptor agonist and hypoglycemia. So here again, it is seen exenatide BID, which I already showed in the other meta-analysis, has a slightly higher risk, whereas sema and lira here has got a rare risk of hypoglycemia, and dulaglutide once week has got the lowest risk as a monotherapy for hypoglycemia. Now, lastly, I'll try to summarize with semaglutide and tirzepatide, the GIP/GLP. So, semaglutide in obese non-diabetic patients. Now, obesity treatment has really picked up in our country. I think everybody are using sema as well as tirzepatide. So, data from the STEP trial, STEP 1, 2, 3, 4, 5, as published in NEGM, and semaglutide used at its maximal dose, that is 2.4 milligram. The findings from a summary of all the STEP trials have clearly shown that hypoglycemia is rare but slightly higher than placebo, especially in people with pre-diabetes. So if they have impaired fasting glucose, then the risk of hypo can be slightly higher. And this mechanism we know, it's because of caloric reduction, early satiety, reduction of hunger, reducing the gastric emptying. So that can lead to a glycemic variability. And if you concomitantly administer a sulfonylurea or insulin, then the risk of hypoglycemia is higher. Perioperative settings, it has not been studied adequately, but impaired glucose tolerance, impaired fasting glucose, there the risk can be slightly higher. So they've concluded here from all the STEP trials that in obese non-diabetic patients, an unexpected hypoglycemia can be seen in some of the people taking the higher doses of sema. So once weekly 2.4 milligram. And you need to closely monitor especially elderly patients and patients with an impaired nutritional intake. Lastly, tirzepatide. So tirzepatide in obese non-diabetic patients, we know it's a twin cretin, and we have a lot of data from the SURMOUNT trials, the SURMOUNT 1 to 4. And here it is seen that, of course, we start with the lowest 2.5, we up titrate, and we can go up to maximum 15. Actually, the maximal doses that we can give is 5, 10, and 15. They are the maintenance doses. And like I said, the GIP of this twin cretin will try to mitigate the effect of hypoglycemia. So hypoglycemia with tirzepatide in SURMOUNT trials has been very, very low. So they're saying that you can use this drug in all obese people. With 15 milligram, the risk is slightly higher as compared to 10. You can see here, and then the 5 milligram for hypoglycemia. So these are my last two slides, the practical use and take home messages. We need to personalize medicine. We need to personalize the way that we treat our patients. Perioperative use of GLP-1s or DPP-4 inhibitors is not very clear, especially in the nil per oral period. Obesity is a new frontier, and we've started to use a lot of sema and tirzepatide, but still lot of data, especially for safety, is awaited. And we know that if you combine these drugs, incretins with sulfonylureas or insulins, then the risk of hypoglycemia is that much higher. Guidelines are evolving. ADA 2025 has already endorsed the use of GLP-1s in obesity, but risk stratification of hypoglycemia is still lacking. Technology will be central. Dr. Vinay has already mentioned time below range and how we need to closely monitor with whatever sensors are available. And a lot of real world data will be very essential in the future, especially for hypoglycemia. So we need to balance the risk benefit ratio. But as a monotherapy with a lower dose of sulfonylurea and insulin, we can definitely mitigate the risk of hypo and have a good benefit for the patient. Thank you for a patient here.
Thank you. Now I will invite Dr. S.V. Kulkarni sir for the and there is MPS President Telemedicine India Maharashtra Chapter, Vice Chair Technology, Professor of Medicine, MGM Medical College, practicing since last 40 years, faculty in GMC, Organized Secretary of MAPCON 2002, EPICON 2007, pioneer and proponent in technology, IT and smartphone technology, and he's the father of clinical digital technology. Welcome, sir.
you. Uh, all the young boys and girls have made my job very easy. Just going to speak of the important aspects of how AI algorithms can help you to predict hypoglycemia. So I appreciate and my gratitude towards the organizers and being a very good part of this symposium, early morning symposium. Alka, Vinay and Balaji have done a wonderful job. The hypoglycemia is a real big. You have to experience it. And you ask your patient, what was your experience of hypoglycemia? The only one word definition is near death. अभी लगता है मर गया, सब खत्म हो गया. But we have to have some India-based specific. Friends, we have to see why you should treat hypoglycemia. You have done it very nicely. That reduce mortality, hospitalization, and of cardiovascular. Early prediction enables just-in-time self-treatment and with the growing adoption of CGM adaptation. I really request all of you to be in touch with all the engineering colleges and electronic digital institutes in your area where you can develop something called as a hypoband. With a wristwatch enabled temperature sensor can be a good project. It costs 50-100 rupees, but save thousands of diabetic patients. But the worst thing for any diabetic, apart from the immediate risk, death in bed, long-term consequences, is the last word, defensive eating. People go on eating with the fear of hypoglycemia. And that is really a very big problem to convince them that your diabetes will be controlled without hypoglycemia and adjust the dose. And please monitor your patient's cognition. आपको लगता होगा आप पेपर पेशेंट मॉनिटर करते हैं, suddenly you find somebody who is defocused, especially elderly gentleman between the age of 60, 70, 75. If there is any change in personality, there is a recent onset depression, or the relatives may say that this person is behaving very oddly, bipolar type of behavior. That is one indication that the patient is getting recurrent hypoglycemia and there is no hypoglycemia awareness of it. So I'm not going to bore with these subjects. These words, short horizon CGM models, random forest, XGBoot are the technology. If you want to have long horizon or weekly or severe risk, then I have got still more complicated things called as a logistic and Cox models. And there are explainability, that is called as a SHAP. The surface drivers like time below range, recent lows in dose, renal function, exercise, and today morning only there were some very good articles on snap and eat, how to get the carb count done. All these things that will help you. We don't want to go to the technical side of it. It is not Greek, Roman and Latin for us. What we should do, we try to understand the complex procedure if you can, otherwise forget about it. What is in your hand? You have got in your hand is either a blood glucose monitoring, 7-point chart of your patient, or a CGMS. Can we think out of the box? Can add some other parameters. For example, if you have got a temperature detector, any watch which detects temperature, if the temperature goes down, it is a cold sweat, the indicator of hypoglycemia. Then there can be tremor detectors. There are certain equipments which are attached to the wristwatch with a fingertip on it. It detects the tremors as early. So cold sweat and tremors and temperature loss, these are the indirect indicators of hypoglycemia which can be detected with sophisticated technology. So what else we have got in hand? CM monitoring, 5 to 10, 15 minutes sampling, electronic health records and claims, and factors like BMI. Low BMI people, more hypoglycemia. Demographics, HbA1c, renal function. In renal function, don't rely upon only creatinine. Always go for GGF. And medicines, what are the medicine combinations? Somebody is taking steroid for a skin condition, very likely to go to hypo. And there are a lot of variables and the patient's behavior. Heart rate is possible, steps are possible, sleep monitoring possible. And if you collect this data together, even in a simple Excel format, that with your CGMS, just put into Perplexity or Google, your chat GPT, give some idea of predictability of hypoglycemia. So it need not to be that complicated. So I got a data from CGM, food logging, heart rate monitor. These are the learning models which you need not know the details of it. It is like driving a car. You should know how to drive the car and need not go into the practical things. And these are the personalized actionable insights. How they are delivered with app or delivered with the test. So what you do, food logging, activity, body weight, heart rate, CGM, and at the end, you will get, with the help of your weight and time in range, you will get some idea regarding a possibility of hypoglycemia. Manoj is here all the time with the latest types of CGM equipment here, and we saw what Vijay was also telling, that the repeated night alarms. We have to find out a balance, and the mechanism need not be so complex. We don't want to know either say kya banta hai. What is most important, whether the patient gets the proper alarm or not. So this is something absolutely exciting. Enabling cameras to visualize your world. Please take down the name of this website. This is called as the Pushpak AI. Pushpak AI kya karta hai? If you have got a Pushpak AI enabled camera, then it analyzes your emotions. Where you are excited, where you are bored, or whether you are yawning, sleeping. And that is one thing which is the worth point of research. So it does emotion analysis, does face detection, it does expression analysis, and it does expression. So there are 7 expressions, basic expressions, which can be added on to, which will point towards hypoglycemia. Now we have got short-term prediction models, CGM, explainable machine learning shows recent time below range. The downward slope, you get a slope down. That means the glucose is going down. The person gets an idea that he is likely to go into hypoglycemia. And there are deep LSTM models, but they show cross-population generalization, supporting use, and then our penetration of CGM should increase in Indian population. Nowadays, we are concentrating only on the urban population. It should go to more and more rural or semi-rural people. And if you want to predict a severe long-term, severe hypoglycemia risk, there are risk models which use the CGM summaries. Then there are EHR-based machine language in type 2 flags. So what is the biggest combination? Renal dysfunction, insulin therapy, sulfonylureas, diabetes duration, DOD. In every patient's name, the second point should come before the age, is duration of diabetes. The duration of diabetes more than 10 years, the patient himself is a double diabetologist. We try to teach you also. So duration of diabetes is one of the important factor for hypoglycemia, HbA1c, and there are a lot of semi-supervised approaches. Leverages large unlabeled EHR to stabilize sulfonylurea and hypoglycemia high risk pregnancy. My request to all of you is keep data it in any form. Let it be even the pictures taken of your patients of your in a handwritten format. That will help you, because there are nowadays very good quality of cameras which will pick up the handwriting and give it to a near numerical form. So what are the evidences? Manoj has been part of this RSSD expert consciousness. Indian type 2 cohorts are there, and there are a lot of South Asian CGM and variable data sets which are available. One of the example is ultra-human rings, which even detect pulse and the sleep pattern. So what are the problems with model design choices? Data reality has to be there, and we should feature the sets to include percentage time below range in 24 to 72 hours. Nocturnal lows, very important. Rate of change. One of my type 1 wants to play football between 4 to 5. He says, come whatever it may be, I will eat complex carbohydrate at 3 o'clock and see my graph. People are very smart. They learn by themselves. They teach us quite good things. Presence of low eGFR, anemia, meal timings, these are very important points, and we should be like what Vijay was saying, that it should be totally individualized. That individualization of the therapy is possible, and the thresholds also you can be changed if it is less than 70 milligram for changes for pediatric and pregnancy, and we have got even a bilingual notification. Not only in English, there can be in multiple local languages. Last 2-3 points is of validation and reporting, what we demand. There should not be any discrimination. The area under the curve for the rare hypoglycemic episodes and calibration. So these are the early warning utilities. Lead time, and alerts per event prevented. These are very important parameters. Should have clinical safety for this algorithm. False negative rate should be very low, and the subgroup fairness should be there. In AI, there are only three problems. One is black box, another hallucination, and third is fairness. The fairness can be affected with age, sex, both young as well as old, insulin and plus minus sulfonylurea users, and patients with CKD. And we need external validation on many Indian sites. Typical group, urban or tribal, sensor bands, and professional versus real-time CGMS and decision curve analysis. Again, I am telling you, if you have got a Airtel connection, go for Perplexity Pro. Otherwise, it will cost you 17,000 rupees, but it is free with that. You put any CGM which you have got into Perplexity Pro, and you will get a very good insight about it. These are the implementation pathways in India. You have to start with risk stratification group, then integrate with your clinical decision support system, and we must make all these tall people who are selling CGMS at 5,000 and 10,000 rupees. Should insist that they should reduce the cost, then only the use will increase. So friends, last few comments from me. Data is the currency, the petrol of our, got it, use it. Blood glucose patterns, diet patterns, even take a picture and you will get a carb count. Your exercise schedule, your heart rate variability, your glucose variability, skin temperature sensing, or even the blood pressure, rough estimates of pulse pressure. That will also give an idea. Any fluctuation of pulse in the night will give you a clue that the patient is having nocturnal hypoglycemia. And there are many Indian jugaads that are available. This was one glucometer which I had, but nowadays they have stopped manufacturing it. It was a talking glucometer. And these are the color-coded glucometers which you have. A patient immediately comes to know whether it is low, whether it is in range or it is out of range. These are very simple things which can make a change in life. There can be something like this. You stand in front of a mirror and it will not only give your total height, weight, body content, muscle mass, your glucose also, if you have got a proper sensor attached. So there are so many research agendas and cautions which we should have prospective Indian trials, should have studied special groups. They are there in RSSDI. And in the regulatory and ethics, have bias audits, data privacy, and post-deployment monitoring. AI augments, not replaces clinical judgment. Please remember. Your clinical judgment is at number one. AI is just an augmented thing for it. There are some sort select references. You can be in touch for all the references. The question is from where to learn all this. From where to learn all simple digital technology and AI tricks. So this is our college called as the Indian College of Artificial Intelligence. It doesn't have any building. It is a virtual college. And we have got a conference coming up in November. That November event, it will tell you, it will unfold your medicine of 5 years ahead. And take it from me. Right now, I am running 70. The medicine which we are going to practice after 2 years, 3 years, 5 years and 10 years is going to be totally different. People are not going to come with your papers, files, कुछ नहीं, QR code लेके आएंगे, आपका data project करेंगे. There may be a virtual screen in front of you on which you can see all. So please become members of our organization. It is a non-profit organization, Doctors AI. Attend this event in Bengaluru. It is a very, very good, exciting event. And if you have got something to present, see, there are only two ways in which you can progress science. Is ask a question. Ask any idiotic question. Or prove a hypothesis. Raise a hypothesis. Either raise, prove or defute it. Either side of the thing. And there is a fantastic audience. You will be getting really good exposure to different kind of stalwarts in this. So thank you very much for your patient listening, and I conclude the session here.
Thank you, sir. So our hope session concluded. If there are any questions regarding it, you can ask us. Inviting all the speakers on the stage for a group photo.
invite prestigious like Stanley.
Thank you, chairpersons. At the outset, I would thank our entire DRS team, Manoj Chalaji and Puri Chalaji, for giving me the great opportunity to talk on this important session on novel biomarkers. Friends, this session is important because of the advent of modern medications, we know how to protect the vascular endothelium, but we know how to protect the cardiac myocardium also. But we have some challenges on preventing the prevalence of pre-diabetes or impaired glucose tolerance, and also the preventing the prevalence of complication among the diabetes patients. So we need appropriate markers. So we are in the era of precision medicine. We are practicing the modern diabetology. So we want to invest our knowledge in the field of precision medicine to algorithm accordingly to prevent the prevalence of diabetes. The power of prediction is very, very important. For that, we need the biomarker. This is the definition given by Professor A.R. in the Indian Diabetes Prevention Program. An ideal biomarker should be redefined the identification of those at risk of a disease or progression of disease, improve the prediction of cause. The power of prediction is very, very important. Which patient going for pre-diabetes? And if so, we how to mitigate the prevalence from pre-diabetes to diabetes. We want to stop the progression of pre-diabetes because we have almost 130 million population of pre-diabetes in India, according to the data given by Professor V. Morgan in ICM in Diet. So biomarkers for diabetes should predict the onset of diabetes in non-diabetes subjects. That is very important message. This message by once again by Professor A.R. Biomarker can be added to conventional risk variables to improve the power of association or prediction, including the impaired glucose tolerance and also including the cardiovascular burden. You know that there is increase in the prevalence of pre-diabetes. Pre-diabetes, 30 to 40% of the pre-diabetic population may progress to the diabetes, and also some patients will progress to normal. So we need biomarker to identify how to prevent the progression of pre-diabetes to diabetes, and also the pre-diabetes hyperinsulinic state, that is highly atherogenic, and they pay for the cardiovascular complication. Now we need the inflammatory biomarkers among the pre-diabetic population or diabetic population, how we can prevent the cardiovascular burden or impact in that group we want to analyze. This is a prediction graph published in Lancet in 2018. This shows some patients will have the complication very early and some patients will have the complication late onset. That may be 7 years, 8 years, and 9 years. Already we have multiple clusters. We have the inspired data. We have multiple clusters in diabetes like that. The fast progression of complication, slow progression of complication, we want to identify why, what is the need. So whether there is any genomic play, whether any metabolomic play, any proteomic play. So these we need the omic approaches. This omics consists of genomics, DNA model, transcriptomics, RNA model, proteomics, once again protein assay. With these means of clusters with the study population, we want to generate a collection of data, biochemical data or biomarker data we want to implicate in our clinical practice for the research purpose, because these plays an important role to prevent the prevalence of diabetes as well as the pre-diabetes. So what is the ideal biomarker? The center shows the characteristic and the periphery shows the specification and presentation. The ideal biomarker should be sensitive, predictive, specific, and also robust. And we want to implicate in early detection of diabetes and access the acute and chronic complications and the selection of therapy, because we are in precision algorithm, right patient, right treatment at the right time. That we want to follow the holistic approach in our clinical practice. The timeline, these are various timelines with the various category of level of progression of risk factor, pre-diabetes, diabetes, and complications. So there are various biomarkers implicated, including from the adiposopathy and also glucose dysregulation, microscope complication, macroscope complication, cardiomyocardial complication. So there are variable biomarkers. I will elude one by one. These are the biomarkers. We know the traditional biomarker HbA1c, fasting sugar, OGTT, and some of the other traditional biomarkers are there. And we know about the type 1 diabetes biomarkers also, like genetic disorders biomarkers and T cell biomarkers there. And the left side you see the multiple biomarkers are available, but we are not practicing in our clinical diabetology. Why? So we want to analyze some one or two important biomarkers, and we can combine the biomarkers so that we can easily access the patient, and early screening of patient also is mandatory to prevent the complications, including the diabetic population as well as the pre-diabetic populations. So these are our traditional biomarkers, HbA1c, fructosamine, glycated albumin, and also 1,5-AG. So these are the traditional biomarkers. These are a very good diagnostic tool, predictive tool, but the complication is very, very alarming here. See, the complication cannot be predicted early, even though Wikipedia's data shows that every 1% increase in HbA1c, there is 26% increase in microscope complication and 14% increase in macroscope complications. But it is available at the late onset only. But we need the biomarkers to predict at very, very early. That is very, very important. That is, need to identify the novel biomarkers to detect the early stage of diabetes, including the pre-diabetes patients, and also to prevent the complications, especially cardiovascular complication burden among the diabetic populations. Vitamin A, the right side you can see the various biomarkers have been attributed in the IDPP program, that is India Diabetes Prevention Program, which is very, very important slide, my dear friends. They have invested a lot of biomarkers in IDPP program. They published in 2003 itself, before, after the coming with the Framingham data in 1996. Even Framingham study doesn't innovated the importance of novel biomarkers, but Professor A.R. clearly mentioned the importance of novel biomarkers, adiponectin, retinol binding protein A, interleukin 6, leptin, vistat, and vitamin A. This vitamin A is one of the important biomarkers because these have the importance of hepatokines, that is hepatocytokines. This detects the pre-diabetes at the early stage, even before the onset of pre-diabetes, 5 to 6 to 7 years before the duration. That is very important. And it is 90 to 100% accuracy. Ceramides is the lipid molecule. The increase in the activity of ceramides have the impact and burden of both insulin sensitivity as well as the increase in insulin resistance. And it makes the leptin resistance. It aggravates the ghrelin activity, and therefore there will be more and more adiposopathy. Adiposopathy culprit is mainly among the Indian population, and that can be prevented if you see the ceramide activity more among the Indian pre-diabetic or diabetic population. Combining of the oxyhydroxybutyrate is an important thing because this is a catabolic outcome from the amino acids. The combining of the both alpha HB as well as the LGPQ have the impact, because even with the one biomarker is very, very difficult. But if you combine the biomarker, but the power of protection will be more on analyzing the pre-diabetes as well as the diabetes patient going for the complications. Adiponectin, we know that adiponectin is an important biomarker of the insulin resistance. That is very, very important for the insulin sensitivity also. It is prevalent about both in lean diabetics as well as the obese diabetics. And also it's very important hormone, because this adipose tissue hormone, it prevails the adipokine, because this hormone itself have been published in Lancet in 2003 by Professor A.R. once again in IDPP program. See the right side of the graph, it shows increase in the activity, that is decrease in the activity of adiponectin. There is increase in the prevalence of both pre-diabetes as well as the diabetes, and also the diabetic population can be easily go for the complication, including the vascular inflammation and myocardial damage. So pre-diabetes correlation in offspring, those the parents having the diabetes, we can easily identify the parents and we can select the criteria for their children to prevent the complications, including the pre-diabetic diabetic population. Wonderful data published in 2003 by Professor A.R. in ADA and published in Diabetes Care and Lancet also. Low adiponectin level was found to be a strong independent predictor. The power of prediction is more than 90% with adiponectin. Adiponectin is one of the individual monobiomarker can be easily utilized in our clinical practice for the early screening and early detection. Another important data is given by the biomarker retinol binding protein 4, because this shows 80% belong to hepatocytes and 20% belong to adipocytes. And therefore, this is called as the hepatoadipokine. This shows the prevalence of pre-diabetes, IGT, as well as the diabetes population to prevent the complication. Bisphatin A is another important biomarker adipocytokine, makes a revolutionary adipokine with the potential to transform the diabetes screening. This shows the early detection capability should prevent the millions of diabetes cases worldwide, because this makes the adipose more and more vulnerable and white adipose tissue rather than the brown adipose tissue, and therefore there will be increase in the insulin resistance and impaired insulin sensitivity. Plasminogen activator inhibitor, that is very important, because this is a serine protease inhibitor. High activation of plasminogen activity, there is more and more vascular inflammation among the diabetes population. Also, it impairs the glucose tolerance. It increases the insulin resistance and impairs the insulin sensitivity. Combination algorithm is very important. So, finding with one biomarker can be do. We can enjoy the benefit of 40 to 50%. But if you combine this bisphatin A and vitamin A, see the odds ratio more than 12. The prediction of analysis will be more and more specificity, as well as the sensitivity by more than 90%. So, combining of the biomarkers will have more benefit among the pre-diabetic population or diabetes population to prevent the progression of complication, or also to prevent the progression of pre-diabetes to diabetes. One of the important, previous speaker was talking about the lipoprotein little a, genetic oriented, genetic inherited substance, low density lipoprotein little a. What are the component of the apolipoprotein A? This increase in the lipoprotein A will have the impact of the whatever the compound you give for the LDL control, even with the high dose rosuvastatin combining with STMB, there will be no control of LDL. But if you identify the LPA in the early stages, you can go for some other useful molecule, inclisiran or PCSK9. It is more and more mitigate the problem of complication due to high LDL. That is very important. And also, utilizing microRNAs. MicroRNAs plays an important role in identifying the patient, because there are multiple microRNAs. These are non-coding small RNAs. There are large microRNAs which have the high pre-diabetes, and also small microRNAs that are low high pre-diabetes. So, with the multiple microRNAs, we can easily identify the patients regarding the prevalence of pre-diabetes to diabetes. And not only that, see, there are this slide shows the various microRNAs having the problem of progression of diabetic population easily for the neuropathy, nephropathy, cardiomyopathy, and so on and so forth. So, this microRNA by means of microassay and also proteomic assay will be more and more helpful to identify the patient both in pre-diabetic as well as the diabetic population. PNP, NT-proNP, these are one of the interesting biomarkers we can easily implicate in clinical practice, because heart failure is one of the menace among the diabetic patient, almost in both preserved ejection form as well as reduced ejection form. Any diabetic patient more than 5 years or any diabetic population with obesity, please do this test importantly. That is natriuretic peptide, brain natriuretic peptide, clinical practice, so that we can identify which patient having the high prevalence of NT-PNP, so that we can prevent the progression of the diabetic patient to the cardiac failure. That is very, very important. Already we learned about the SAVA-TB data. Saxagliptin increase the impact of BNP, and therefore this BNP plays an important role in the diabetic population to prevent the heart failure. Another important marker, inflammatory markers, oxidative markers. Interleukin-6, one of the important biomarker, and also along with the C-reactive protein. We already learned about the Jupiter trial. Jupiter shows the primary prevention population itself. The rosuvastatin in small dosage, we can easily prevent the prevalence of both diabetes and the cardiovascular burden by 26%, and also the reduction of CRP by 28%. So, these are the important biomarkers can be implicated in clinical practice, eluding the data from IL-6 and also getting the data from PAI, and we can implicate how the patient going for stress, including the oxidative stress, reactive oxygen species, and therefore so on and so forth. We can mitigate the importance, the burden of the pre-diabetic population going for cardiovascular complications, especially among the diabetic population, obesity population also. ICAM is one of the important intracellular adhesion molecule, one of the gene-related adhesion molecule that is, most of the diabetic patient will have retinopathy in the early stage itself. So this is the problem. So identify the biomarker. So those on both type 1 diabetes as well as type 2 diabetes is very important. We can easily identify each patient going for retinopathy as the earliest. The future directions, dear friends, omnic approach along with the bioinformation. Previously, we had one of the important talk by AI. So AI plays an important role. Data mining, imaging, machine learning, neural networks, forest firing, revolutionary biomarkers are important and so therefore we can implicate this in genomics, microbiomics, metabolomics, proteomics, and lipidomics. So there are various omnic approach we want to utilize in our clinical. It's difficult only, but for research purpose also, we can select simple biomolecular like retinol binding protein or lipoprotein A like that. Adiponectin also plays an important role. With this, we can easily diagnose the patient. The going for pre-diabetes population, progression of pre-diabetes to diabetes, and also those the patient having the diabetes, progression of diabetes to cardiovascular complications can be easily identified. Dear friends, these novel biomarkers maybe looks like somewhat controversial, but utilizing the novel biomarker in clinical practice because we are in the era of modern technology. Our Manoj is very good in modern technology, but even in the technology, we couldn't be able to control the complications, especially both macro and microscopic complications. So we have to utilize this with novel biomarkers, both genetic biomarker, proteomic biomarker, inflammatory biomarker in our clinical practice. And we want to prevent the complication and we want to enter the good quality of life and outcome and make our India as a diabetic care capital across the globe. Thank you very much for giving a great opportunity.
Yeah, yeah. So, thank you so much, Dr. Manoj Purvi ma'am, for giving this support. And I'll be talking on young onset type 2 diabetes and individualization. This topic is really close to my heart. I feel we do something for young population actually can change. So this is really important. And for the next 5 to 10 minutes, I'll be covering clinical aspects. Most of the theory, biomarkers, and digitalization is already covered by my course. So I would start with my presentation. So diabetes, yeah, youth diabetes is actually heterogeneous. There are multiple types of diabetes: type 1, early onset type 2 diabetes, MODY, FCP, fetal diabetes, endocrine diabetes, genetics, and gestational diabetes, and others. Today, mainly I'll be talking about early onset type 2 diabetes because this is so this mainly my presentation 5 minutes is I'll be focusing on early onset type 2 diabetes. So ICMR and ADA guidelines they've clearly shown that diabetes and youth onset type 2 diabetes also by 4.8% annually. And especially why we need why Indians in South Asia, there is a sharp increase in diabetic 5 to 30. So huge concern. There is overall 11.4% diabetes, yeah, and youth onset type 2 diabetes 10 times in urban last 30. Yes, it's time we need to actually bring it down or to halt the further progress. Why type 2 diabetes? Type 2 diabetes very important. It is not like adult type 2 diabetes. Youth type 2 diabetes more aggressive compared to the adult diabetes. Faster cell. There is a longer lifetime exposure to the hyperglycemia and higher rates of cardiovascular early age. Plus psychological impact because happening at a younger age till the development happening or adolescents are going through a lot of psychological stress issues. It's really handled aggressively and to down. South Asian P. Mohan and in India we are in South Asia get complication at an early just 1 decade compared to fat Indian type higher body fat percent 30%, right? And have higher fasting resistance even in normoglycemic rapid beta cell atherogenic higher hepatic fat deposition. Even if we see sometimes there is abdominal obesity compared to the Western population, have a higher and metabolic glycemic complication. Pathophysiology overview is like same as like type 2 diabetes. The key factor there is adipose inflammation factor leads to and beta cell failure. But here the added factor in diabetes it is puberty effect where the insulin adds to resistance hyperglycemia. Another greater risk fat deposition. So now we know that are at risk. What we need, and I am sure everybody must catch them early. They show 40 to 50 any symptom of diabetes. What we need is if has strong families, if the mother has history, if the patient is overweight or obese, or there are signs of acanthosis. A very important thing, I think, practitioners sometimes we might miss dietitian check for acanthosis. Acanthosis checked early, and you can start them on as early as per the guidelines. Age to begin testing at 10 years. So 10 years or at the onset of puberty starts obesity or acanthosis, diabetes. And frequency of testing every 2 years. GTT is recommended, but I think basic clinical testing, if your family is positive and acanthosis, then you can ask them to go blood test. There is no point in doing all the patients. And then if you find anything, well, then you can go ahead with a normal basic workup like lipid profile and other. Clinical presentation, diagnostic, again, I said a lot of patients are asymptomatic, but the signs which are skin tags, acanthosis is the thing which normally we are doing scans in where we don't do any random check, just anthropometric and acanthosis. Can tell the family child might develop diabetes, start dietary activity right now. These are the changes you should. And a lot of patients, they develop diabetes. Along with that, they come a lot of metabolic other complications, hypertension. Then they might come with other complications that we need to. Yeah, so this is a very important slide where I really like this picture. Don't forget everything, but just remember this. Whenever you see coming to you, but if you see attender is young and attender is having spend extra 10 minutes counsel the attender, at least attender. Sometimes they feel a doctor patient to time later. Why are you behind him? Doesn't have any problems. There we need to tell them work on it, And young patient, you tell them, "आप Google कर लो." But when they Google says yes, then they will follow you. Tell them this is important. In fact, I tell them, you, your family, now we have Rakhi festival and also. I tell them, you check this when you have a get together and whoever is finding this, have this check. Please go to your doctor at least and diabetes or diabetes. Simple pedigree chart. You IFI investigation. First patient coming to you, first clinical checkup, and your pedigree chart will tell you type of diabetes patient is having. If when you know you classify, yes for Modi, but looking at your clinic, spending 5 minutes, family is top prediction, you will know category type 2 or type 1 diabetes. So this is very important. I think I was lucky to work with Dr. V. I was diabetic, working with him. If a patient comes to you, compulsory stop it. And this was a privilege that we had written on young onset diabetes in an adult, how you classify, what are the criteria you should find, and what type of see when you patient comes to you. Very simple, handy thing. When you see that no criteria are fitting, and so you patient might be having this. The other routine, we know all this criteria. Guidelines are complication diagnosis. Yes, keep in mind. Yes, okay. Hypertension check, retina evaluation, micro. This you need to keep in mind. And at the whenever you see patient diagnosed first time, all the complications workup because except that they have diabetes, they are going to develop diabetes. Time to set. That's the route. Can't wait till you develop diabetes. Start your name. As per the ADA, first and very important, management, counseling, parents, family, all the family members, explain them what is this, how your weight loss is the key. Patient is obese. Activity. What's even now nowadays now we really go academic, but it's all the physical activity. Really important. Daily 1 hour of physical activity or sports and nutritional counseling. Start metformin is the first line. Start metformin from the age of 10 years. That parameters. Definitely start with metformin. If the HbA 5, bring it down, the sugars are high, or if sometimes positive sometimes, then you can start with insulin. Stop the insulin, add GL. And then third is titrate the SGLT is also approved, empagliflozin is approved from the age of 10 years. You can GLP is approved, metformin is approved. Plus, but the main key is management, lifestyle model. ICMR again recommend BMI if it is more than 23 or BMI more than 25, you should start at the age of 10 years. Waist circumference more than 90, boys waist circumference for girls, screen them for diabetes or pre-diabetes. Therapy, again it means that you can't give the same for everyone. You background, them understand the social factors, understand how is the accordingly you can tell them you start with GLP and them diet more accordingly. You convince them definitely advices. Precision medicine, I'm sure Dr. Mohan must have taken in many lectures. The thing it is help us to just decide the type of diabetes the patient fits in category, and this helps us decide the type of management will be. SIDD, severe insulin deficient diabetes. There are severe resistant diabetes. Based on the pathophysiological, help us to type of medication helping bring it down. The blood sugar is the same thing which covered how you will start with the stepwise manner to diabetic. These are the medication. Young diabetics, metformin is approved. Then yes, is approved. LP glutide and semaglutide, but cautious. And retina eye checkup mandatory for starting G1 receptor all the patients. SGLT start, but hydrate them about hydration, inform them about the caution about fungal infections of private parts, and immediately they need to get any symptom. I think sir has taken half an hour lecture diabetes, and a young patient, they are happy. Tell them we are going to. That will be. We have a team. What we do, have a team. Then sometimes high, and like we had a patient 180 point. For that we advise and then so pattern. So they are really excited. That, and along with that, we started on technology plays a very important role for them. The results at the same time beneficial for the patient as well as for us to decide. Yes, I think I've already covered the psychological aspect. Consider young diabetes plays a very important role, and involve the counselor in your team. Have a counseling, or you can ask offer patient about maybe once a month them or behavioral, bring down their parameter. This is a very excellent slide when you have a patient young diabetes and you need to classify which category. This is when you see families, or you go ahead all the just families tell you patient is type 1 or type 2. If the patient is families, whether it is or it is parents diabetic, it is 3 is under have this patient diabetes analysis. At the same time, then patient is negative, then you need whether it is accordingly MMRD or it is type 1. This helps you decide how we are going to patient and his therapies. Summary and key concept requires a management plans based on type risk. South Indian type 2 high threshold and in current ICMR has add-on candidate technology. Multidisciplinary. I've gone. Yes, so if you want to change the future, we need to act now. We know we have all the high-fi patients, but don't forget and 5 minutes stop addiction and idea tell you that diabetes actually one patient. Thank you so much.
Thank you very much. Lecture. Yeah, I know.
Is for a lot of injectable. Earlier, we used to dealt with that better control. Now we have the other end of the spectrum, wherein people come to us for injections. Injection phobia seems to have now gone away along. And let me see what we. Thank you so much and writing about the dietary sedentary. Also, why do injections matter? Burden of diabetes. All have been that burden of diabetes. Oral medication. 5 point, and then there are injectable available. Type 1. We're talking about young diabetic years old, first time detected diabetic, and of course now in that situation you maybe he will be a type 2 because he had a lot of acanthos, but I have to start these after the better sugar time delay, titration, flexible, GLP-1 agonist as well. Cardiovascular. The blood sugar better now the pain infections tablet can either make it half or you the effect we at what still some more weight reduction, rise the blood pressure, reduction in cardiovascular target pathway, appetite is satiety. That's how just very brief of the glycemic finally injectable cardiovascular benefit reduction progression in the dual antagonist. If as compared to the Therefore, result is benefit. Besides this, diabetes. Side effects, all patients, the medication, what they eat everywhere else is or they take other things. But when come to a, all face this nowadays, what is the side effect? Side effect is that hypoglycemia. Side effect, but which most times I tell them side effects so that less and a rare case of pancreatitis have been start titrate. Guidelines first line PLB was it active child is now that depends if expect that you start and then suddenly starts coming. Doesn't happen like time. They have to comply with who would take and about have to part of the them that they expect that that they will come. There'll be 5 kilos. Talk with them regarding what the expectation, what will the medication. The thing is, in they always lifelong. Tell a patient that then cost is always a factor. Cost and how they can get some can be more. What is tightrope? Tightrope. They will come back later. Back is Just take time to courage is. I will not try to be. There are some at time we need. Guys, what's very important? Traveling, check-in. That is another thing. They just throw them away by right because ideally it can hurt the lifestyle. Injectable junked with learn how to check their blood sugars. They know what to do. Log they start them. Again, the myth. Last day. Again, we have insulin can be used. The type 1. They are very effective. Prevent the cardiovascular patient devices, pens, pumps. The better, but and what's very important. And we have to educate. Like Anjali said that we go, educate about child disease. This is something all must come here, educate them, have
Thank you, sir. going to talk about GR value in our country. Three, four other income in dollars responsible. What's alarm? 7% diabetic regions. Of course, trying to code how focus the diabetics. Another disheartening because of this inertia have baseline A 0.9 where failures important key role on percent. Talked about weight and glycemic cardiorenal. Last 3 decades, newer drugs, but in spite of all these still lies complete. Common notion which window shopping, doctors he say no, retain that patient fourth, fifth. We know that fourth. Correctly told him to insulin. He refers one of the examples. Therapy reiterate per pen, then the patient. So this is what in the part of DPP side has diabetic. So diabetic problem. Right. 17. Study about because it's the longest use the modern. Tell about failure as a treatment worldwide. What data says for means in line. And side for the real world you say state register is 6 on till today. First line. Existent. Still, what do you say? It rates percent. All know what they want. Drugs. Picture on this issue. Plus, I pride our country में plus but longest limit. When you choose a drug in your certain factor into depending on benefits, progression of the factors which you look into, and once you can see LP1 almost, of course, weight reduction in generation the tellurias. The third generation key mechanisms at the unit of the ATP depolarize let's look at the hypoglycemia. What the cat slide when you choose analysis times more. All of us know, but first section the trials now. Yes, trial. So 1000 plus. First diagnosis. EP arm also for vascular or macro 11,000 8 years for 2 arms of respective duration of that EGF column is very important. All came that we never outcomes 7.32 this trial for all your age the side the intensity we showed 5%, 10% micron macro. Bifurcate those again. Alka's model, coronary, worse. One of the trials which showed Wikipedia showed the macrovascular. No overstimulation of beta. In lesser Just to show you, RCTs, put sax, nucleoside. So the trials which once trial goes at foot, but it put. But advanced you can third was one of the trials. NC1 pre-closed ADT and metformin in increase. Reduction is in the allogliptin. I was part of where glycoside, which is SU, is at least studying the how does glycosides differences. That is what contributes to benefits what you that ring what matters. Exhibits rapid reversible binding. Lesser as other issues after the one binding and comparison with yes again R for risk of pride you can give me earlier longest best molecule the benefit apart from CV benefit how do you remember study automatic again de-emphasize fact of course paid gain trade is given plus 3 point ADT wait the cardiac cardiovascular safety vascular is not in the glyph. Again, what is the basis? You are on receptor at what? So, risk of S beta cell compared to the reversible you are receptor. Binding from pride also binds to both the of course. Let's look at the renal outcome. Again, I am talking not Parega. Age 55% acro normal albumin advanced plus that is arm again showed study which relation to 46% ESRD one was continued beyond 80 third kid follow-up But it is 4%. Of course, the median of 5 years at one. Again, different side, caution, and of course, give side, end stage, for risk of the side for risk of. So in this, either with gloomy years, 0.5, what risk of. Another one, real life with done. Observational. Make real world rates. Clarity effect. It release. Gliptin end line. Comparison with the EPB outscore fusion effective with reduced event. Thank you very much. Any questions? Yes, ma'am.
Then after the after stop, actually,
Done in
so
UTI.
is the I didn't find nothing. Actually, nothing.
That
was
they would
there.
have ruled out, but what they won't hyphenate. Yes,
Yeah.
cause which is
I think the drivers I
but
would
why
introduce-
only other drugs?
The inauguration session has started at Mumbai Chowpatty Hall. Everyone is requested to go down. Thank you.
check.
Very good afternoon. Afternoon. Yes,
Short. Thank you so much. Nice. So my topic is benefits of real-time CG, and very topic to time CG. Now, yes, but we have new devices coming. What is very permission of in the slides from here. So the powerful tool, and it helps you to achieve the goals of the glycemic control, the outcomes, much better in the matrix, which much better because the micro and macrovascular complication prevention is seen. The interstitial glucose may provide a more accurate representation of mean glucose than A1C. Far more data is gathered with C. Therefore, more opportunities to be alone. Not get the same kind of a feeling, or cannot get a same kind of a data or patients peep into lifestyle. Only with this can become very important too. How it works, we know it's continuous. Monitor the small sense that tracks the glucose, right? What is used for? Improve diabetes management. Actionable insight where you can immediately act. What kind of actionable insight? For the exercise, medication, how the medications are working on the patients, how the exercise is working, how the exercise is bringing down the blood sugar, what kind of food is. Those kind of insights you'll get. Convenience, comfort is there. You need to prick again and again. At a long term, outcomes are seen. There's something which is called real-time CG, where you can track the glucose real time. You don't have to scan the glucose again and again. So you can update every 3 to 5 minutes. Get a trend analysis of the glucose trends, which analyze the trends and actually help the patient better control the. Maybe sometimes you have even medication. Sometimes stop the medication well with the lifestyle. Customize alerts and alarms you will get and calibrate. You don't have to calibrate. Factory calibrated. Quite accurate nowadays. So accuracy, the blood glucose ISO standards, FDA has mandated that be passing certain kind of standards be released in the market. For the CGM, you have a MARD, which is an indicator, or which is just the device. MARD is a mean amplitude of relative differences, and this is the points which are very important. The very rigorous testing and indicators which is by FDA. I will not dwell into the detail. I'll tell you there are 3 high requirements mandated by FDA. Test the device and pass the device. The requirements for less than 70 should have at least more than 85% blood glucose within the range of plus and minus. 70 to 180, more than 70%, plus minus 50%, 180, plus minus 10. So these are some standard requirements. So then you have requirement 2 also. These are the technical details, and FDA uses to actually assess the device and give the recommendation. Get device. We know about the blood glucose, about the flash glucose monitors as well, because you have to have a scanner. You have to scan every time when you want to have the blood glucose reading flashed on the mobile. CGM or real-time CGM, you have to do that. And of course, a lot of things are much better in terms of CGM, because you can see the analysis in a real time and automatically tracks the entire glucose patterns without any doing much of it. If you don't track your the flash glucose monitor, you will not get the data. The data will be broken. With CGM, data is not broken. Continuous linear data which you will get. So this is the benefit of CGM as compared to the other two parameters, other two devices which we are using. There are two types of real-time CGMs currently available in India. One is Freestyle Libre Generation 2 and now 3. But it's still not a real time, because you scan before you start. Must have seen, you have to start, scan it. Then you will have to scan in between also, because sometimes the Bluetooth connectivity and the signal loss is there. You use that, then come back again and scan it so that the data is continuous. At the ICANN i3 CGM center, the first sensor, which was 15-day wear, Abbott brought it out later, 15 days. It is wearable device, 3-minute readings you will get with high accuracy of MAR of 8.7%. Industry standard, you have MAR of 11% is sometimes nowadays become rigorous, 11%. 8.7% is very, very good MAR in these sensors. Dexcom not available currently. ADA has published a guideline. So if you're using the CGM, all the data which you collect has to be in the form of ambulatory glucose profile, which is a pictorial representation of all the data. In a one glance, you can see all the data, and time in range is accepted metrics now as per the world bodies. And you can see this is the how you get the report. I'll dwell into the details of it. You can see there are time in range between 70 to 180, around 70% and more. More than 80 to should be around less than 25%. Time above range, which is, and less than 5% above 180. And time below range also 4% and 1%, the lower ranges. So you have to look into the ranges very importantly and accept the reading should be in these ranges if you want to accept the glucose readings. That is very important. GMI is a indicator which is as equivalent to HbA1c. So glucose management indicator, give you a complete summary of all glucose throughout a defined period. And if you extrapolate this number and the patient follows the same behavior and exercise, you can say it is a 3-monthly HbA1c. You can equate it to 3-month HbA1c. So this is the useful tool, and this is how it looks like. Here, a report, you have to first see the usage of the sensor, the date, how many days the sensor has been active, what is the activity percentage, and then you look at the entire report. Time in range, time below range, and time above range. Look at the average glucose, look at the GMI, and look at the glucose variability. 36% is what is defined as to be less than 36% normal, 10.9% you can see here. So this is how you see the reports. And if you want to see the entire report, you can see the AGP report, then you can see the profile, and then day-to-day profile you can see in one single page. And you can evaluate the entire data in 6 steps. Look at the data adequacy, look at the indicators. Then first you evaluate the hypoglycemia. That is a rule of thumb. You have to correct that first and then go to the hyperglycemic events. If you want to adjust the medications, get a 25th and 75th percentile bar that is affected by medications, and the patient's behavior is affects the 5th and 95th percentile that will be affected by patient's behavior. So depending on which bar is wider, you can understand what has to be done next. Patient engagement is very important in his entire process. You have to keep communicating and counseling the patients. Now time in range is a concept which everybody knows it. It's the amount of time you spend in a target glucose, which is defined as 70 to 180, and for most people, and it is around 17 hours of 20 hours total. 17 hours of your entire total time in a day you should be spending in this range. That will be equivalent to 7% HbA1c. Okay. Guidelines are very clear. Time range is a core metric now, which is accepted for blood glucose control in patients with diabetes. All the guidelines, EDA, ESG guidelines, ACE guidelines, everybody has accepted this as a core metric. But what are the benefits? Do you have any benefits in using the real-time CGM? Yes, you can see type 1 diabetes, very good. RT-CGM versus the intermittently scanned CGM, difference in the HbA1c control, latest publications from this journal. And you can see type 2 diabetes patients with insulin therapy benefits. The RT-CGM is more favored for hyperglycemia and time in range, and just near for hypoglycemia, just affecting maybe a little better than only the SMBG. So you can see the RT-CGM is really useful in both the types of patients, type 1 and type 2 diabetes patients. And if you look at the patients who have got pregnancy and diabetes, type 1 diabetes and pregnancy, data is very clear that has got a much better A1C control, 0.2%, but translated into better outcomes in terms of low for gestational age and neonatal hypoglycemia requiring IV dextrose and ICU admission. Was much lesser when the patients were using RTC. The concept study which I was speaking about, very nice study. And then you have a gestational diabetes in pregnancy. The gestational diabetes meta-analysis very clear. It is also shown to reduce the gestational weight gain and lower infant birth. So in both the situations, type 1 diabetes and pregnancy and gestational diabetes, it helps. And more support for CGM and our pregnancy is now a point of discussion whether you should use CGM or not in pregnancy. We have a lot of real world data showing that you can use the RT-CGM in pregnancy. So clearly there are benefits in all types of patients. This is a newer sensor which we have, ICANN i3 sensor, third generation sensor. And you can see there's a sensor pack, transmitter, and a health app which is there on the mobile. You can put it on the abdomen. Now it has been approved also to be inserted on the upper arm. And MAR accuracy, you can see closest which comes is the Abbott Freestyle, okay, but it's also not far, 8.71. So it's a very good mark showing it's very accurate as well. And the third generation sensor uses direct electron transfer, right? And it's uses a different set of enzyme, glucose hydrogenase. The interference with acetamide, paracetamol or ascorbic acid is much lesser. What we used to earlier sensors and glucose monitor. Now you don't interference kind of a sensor, third generation. So you can see this is can be used a role for 15 days, and it's a real-time Bluetooth. You have connectivity. No calibration is required. 18 months this sensor can remain, and 120 minutes is the time of initialization. MAR value is 8.1%. You can have a data receiving device from iOS, Android, Google Play app, and output frequency of 3 minutes. Every 3 minutes you get the data. So this is in one glance about this sensor, and no interference from vitamin C or acetaminophen has been seen. But you have to have some software to interpret the data and generate the report. You have IGM Health, I Can Reach, and I Can Review. The doctor platform, patient health platform is I Can CGM or Health app. So this you can use it for the patient, and there's a partner app also, I Can Reach, which the patient's caregiver can use. I just go of I Can Health. This is the patient app. You can see here arrows. You can see the Bluetooth connection. You can see the trend arrows, how the sugar is trending. Then you can see the landscape and glucose graph, and high and low glucose. Yeah? You can add a note of what you are doing, exercising, eating what, everything can be added during that time. Landscape view, you can see the glucose 24 hours, daily average glucose, glucose trends, all things can be seen with this app that the patient is using. And you can add, they can add their events also, right? Then you can have glucose reports, they can generate the reports, they can also export the reports and can send it to the caregiver for the further evaluation, and if there any change be done. The customized alerts, you can keep the alerts on vibration or Maybe you can decide what level you want to take the alerts. 20, 70 patients can have their own alerts customized, and they can keep the alerts in the way they want. Either they can silence them or they can put it only on the vibration. They can also share the data with the doctors, and the doctor's side of the app is called I Can Review, which is the healthcare service management system. And you can see this is very important system which is assist the doctors in viewing, analyzing and evaluating patient glucose data for more effective diabetes management. You can see this is my workbench, my patients who are already on the sensors, and you can see with one glance I can see how the sugars is being tracked for all the patients, and I can immediately click and find out who is doing what. And this is at glance data facility, which is not there in any other software. You can just with a glance you can see what is the time and range, how many hypoglycemic events. So if you want to see somebody's hypoglycemic events, you can directly go there and check what's happening that kind of a patient, and you can immediately call them and understand what was going wrong. This is a daily glucose report, data analysis indicators, glucose level records, and see the events have been recorded by the patient, what she has eaten. Can I have the here? This is the point. You can see here whatever has been eaten, whatever events have been recorded, has been entered by the patients who can get it directly see everything at one glance. This daily analysis, daily glucose report, and ambulatory glucose profile overview, everything you can see, high glucose condition, multiple daily glucose, a lot of data you can see. You can customize how you want to do it. And this is a AGP report which you can see time in range, time above range, and the glucose profile day to day. Everything can be seen in one glance here. Typical AG report which is generated here. You can see that 50th percentile, 25 to 25th to 75 percentile bars, and 5% to 95 percentile bars, and accordingly you can judge what is happening and what is mainly deciding the variability and instability of the glucose, and then accordingly you can counsel the patients. And you can see data reports. There's a lot of things you can do. Everything at one glance. You can time above range, and then you can see the glucose management indicator. In one page you can see all the data at a glance, the facility which they give. So and also export the data for your research purpose and whatever you want to do. So take home messages: RT-CGM is transformative in diabetes care. Clinical evidence supports use across type 1, type 2, and pregnancy as well. Behavioral changes also we have seen. Also the data is still lacking, but people are saying that behavioral changes are profound and lasting. Recent paper which I read was showing that CGM, till you're using CGM, the behavioral changes remains. Post that probably the behavior changes are not that way, very consolidated. So we still have to wait for that. Technology keeps improving and adoption must follow. Training and access are critical care for success. That's very important that you keep talking to the patient and keeping training yourself about these conditions. And now I invite you for the third IMPA conclave. Not playing. So we have an IMPA conclave, this is the International Metabolic Physician Association. We're having a conclave next year, 28th February and 1st March. You're all invited there. Thank you so much. Questions?
Thank you, sir. As we are getting late, so we'll take all the questions.
Thank you.
Thank you, Dr. Vimal. Now, moving next, I would like to request Dr. Santosh Malpani. Please come to the dais, and he will be speaking about painful. Over to you, sir.
Good afternoon, everyone. Manoj, thank you for giving this opportunity to us. Important topic. Diabetic neuropathy. जे पाय दुखतात तेव्हा डॉक्टरचं डोकं पण दुखतं. Very difficult to such patients. No one is satisfied, neither the doctor, neither the patient. And how to manage these cases that we are going to. About 34% of the patients who are having neuropathy are having painful neuropathy. It leads to sleep disturbances, reduced recognition, emotional distress, depression, anxiety. That leads to poor compliance with the treatment. In turn, poor compliance can lead to deterioration of glucose. That will lead to further deterioration of neuropathy. These symptoms are very typical as far as peripheral neuropathy are concerned. But there are certain risk factors which are avoided by giving proper treatment. Duration of diabetes, glycemic control, age, obesity, yeah, insulin resistance or insulin cellular failure that can also progression of peripheral neuropathy. In particular, smoking and renal health, important things. Along with that, genetic predisposition. Importantly, for the painful diabetic neuropathy, vitamin D levels are important along with B12 levels. So this is in a nutshell the pathophysiology. Can have various based on the and insulin deficiency or insulin resistance can lead to faulty signal of the insulin receptor that can lead to active pathways. Hyperglycemia, when it enters the cell, can lead to the activation of other pathways than the routine pathways, that is the polyol activation and all those pathways that will lead to cellular view. So also dyslipidemia, uncontrolled efflux of the free fatty acids and increased LDL in the intracellular hypoxia, DNA degradation, and entopy that will lead to the microcircuitry cell injury, and this in turn will lead to faulty signaling, and that will lead to neuropathy. So friends, as far as the neuropathic pain symptoms are concerned, either it can be spontaneous or evoked pain, and permanent paroxysmal, these are the two types of pains, spontaneous, allodynia and hyperalgesia. This the permanent superficial burning, the deep compression pain also for the treatment. There are various drugs which are available that we are going to decide. But when to screen for the, as far as type 2 diabetics are concerned, time of diagnosis for the signs and symptoms of peripheral neuropathy. In type 1 diabetics, it will get 5 years of diagnosis. And there are 25% of pre-diabetic patients. Then of these, those patients are to be searched. There are various tests that are available. As far as the symptomatology is concerned, gives the clue about the diagnosis. The large myelinated fibers, when they are involved, we get numb, tingling, poor balance, and decreased ankle reflexes, the peripheral, impaired proprioception. The trouble starts when the small nerve fibers are involved, like pain, hyperalgesia, allodynia, and there is a symmetrical distal to proximal thermal. To have the tests, we have got the motor system along with peripheral neuropathy. Suppose there is motor muscle involvement, then that also becomes a problem as is concerned. Large fiber sensory assessment done by vibration and light touch and pressure and thermal sensation can also be calibrated. And there are various meters which are available. Biostation, accurate thing. But as far as the bedside and bed diagnosis test, we have got the vibration perception test, thermal touch, and the positions that has to be on for each and type 2 diabetes. Assessment of glycemia, lipids, renal and hepatic parameters, program, and don't forget to estimate vitamin B levels. Patients who are on long-term hormone therapy, they think accentuate the peripheral diabetic neuropathy. Along with that, many patients are there deficiency. Associated factors, there are certain potential diagnoses taken into account. For that matter, nerve conduction study and electromyography performed. But mind well, the small fiber neuropathy are not going to be positive. That is also a pitfall as far as peripheral nervous system. Symmetrical polyneuropathy, 50% of mononeuropathy, less than one. Radiculo. These are the three categories which painful diabetic. These neuropathy symmetrical. Whereas the duration of the start treatment in a long-standing diabetic patient, get a sudden drop in the blood sugar level, that can small fiber. Go slow in such cases, the sugar, proper control of the sugar, along with that not be there. There is the other type of neuropathy which is accompanied by the poor glycemic. Such cases, we have to control the sugar robustly and avoid the symptoms of the chronic peripheral neuropathy in more, and PSPN is most problematic. Otherwise, other not that troublesome for management. Radiculoplexopathy, though rare, it is there, called with the proximal muscle pain in the muscle parts. And well, we have to get the autonomic features also. For that matter, postural hypotension, under bowel incontinence, all the abnormal sweating, dryness of the skin, places, all this is taken into account. As far as the differential diagnosis, mechanical compressive neuropathy can be taken into account. Inflammatory, particularly alcohol abuse, inflammatory due to then the toxic neuropathy, the metabolic for patients are concerned deficiency. So for prevention on the glycemia, reduction of HbA% has been shown to have the effect on primary and secondary type 1 people. As far as type 2 diabetic people, primary prevention, secondary prevention is problem, which the control of glycemia not that beneficial. We have to target the factors like the obesity, smoke, obesity also. We have to concentrate on the at the treatment. As far as the management is concerned, 50% of the patients will not respond. But when we get 50% relief of the pain, it is in between 49%, that the therapy is sufficient. But one has to wait for at least now the proper effect of the therapy. And one can go for the combination of better treatment. We have got the control of glycemia prevention. We have got pharmacotherapy. We are going to go into details in that. We can combine the therapy. Whereas tropical we have got the by various, and we have got the high frequency cords, spinal cord stimulation as the ancillary treatment. There are AN, ATA, the German IDF. These are the 4-5 associations. They have recommended certain therapies for the peripheral neuropathy. There is no consensus on the neuropathy treatment. As far as the tricyclic antidepressants are concerned, that amitriptyline, nortriptyline, they come at the first place. Cost, you can use them. As far as the SNRI is concerned, duloxetine, the popular for practice. Gabapentin, pregabalin, and gabapentin practice. But as far as the American Association of Neurology is concerned, they have considered sodium channel blockers, that is carbamazepine, as a first line, taking apart the other association. So opiates also can be tried, but abuse, we are not going to start them at this stage. They have got a proper effect. And there are certain treatments, topical treatments. So TCAs, SNRIs, gabapentinoid, sodium channel blockers, the second line oral treatment, opioid combination of treatment. As far as pregabalin and gabapentin are concerned, more than 300 milligram dose of pregabalin should not be given. Less than 3 milligram be given, and gabapentin can be given in the dose of 1006 per day. But one has to wait for at least 4 to 6 to have a proper judgment of the dose. As far as the duloxetine is concerned, you can go up to 6 titrating. 4 weeks is the duration. Amitriptyline, very popular compound, you can go up to the 75 dose. 4 weeks is the titration period. Nortriptyline, which has become cheaper now, can be given in the dose of 150. But mind well, for amitriptyline and nortriptyline, you have to monitor the cardiac stress of the patient and wait for at least 6 to 8 weeks for nortriptyline to have a proper action. No association will recommend opioids as the first line. The desperate are not able to win. You can use tramadol, tipentadol, morphine also, respective doses, and one has to wait for 4 to 6 to have proper symptomatic relief. But as soon as you get symptomatic relief, try to decrease of opioids in any case, because the use is there and patients are habituated. Sodium channel blockers, particularly the oxycarbamazepine, which for urea, and the sodium valproate can be used, but it is a recommendation only. You can go for, you should watch for glaucoma, old age, then unsteadiness of gait, falls, orthostatic hypotension, weight gain, edema, hepatic disease. Before you start all important, because orthostatic hypotension very common with the TCIS. Topical treatment by capsaicin 8% can be tried, is safe, not leading harm to the patient. So also lidocaine can also be tried to this. Suppose you are not getting a proper effect with go for the combination. The most popular combination gabapentin or triptyline. Go for that. You can add duloxetine, third drug, but you should wait for at least 8 weeks. Hematology improvement in any case. So maximum dose monotherapy versus maximum dose combination therapy can go for either of the two. The differences effect profile of the drugs, but combination therapy lower doses is always beneficial because we have lesser side effects as compared to the dose pharmacotherapy. There are some patients who do not want to that situation. Go for lidocaine infusion. You can for botulinum toxin for spinal patient. You can go for spinal cord stimulation, but safer procedure. Thing. As far as the pathophysiologic based treatment is concerned, observed that in type 1 diabetics, when transplant done, has got reversal of neuropathy in its stage. Alpha lipoic acid, then the very popular tried dose reductase inhibitor, which has marketed nowadays in very robustly, that is iperlastat, can be tried. Control of dyslipidemia and hypertriglyceridemia done in. These are some key emerging pharmacotherapies. We are novel therapeutics which target the glycemia, analgesics, food analgesics, analgesics. They will be marketed in coming days. So also nurse, the stem cell therapy, the gene therapy, microbiota therapy, the biomarkers marketed in days, in coming days. So in nutshell, you have to truly control the glycemia. Mechanism based treatment also be tried. You can go for therapy, you can go for the combination. In some cases, acupuncture also had tried. So also spinal cord stimulation, the transcutaneous electrical nerve tried. This is my talk. Thank you.
Right.
Good afternoon. Last 2 days we have been discussing a lot about newer drugs associated with therapy of obesity and very well observed in complications. There is something known as NAION. It is a part of AION, arteritic anterior ischemic optic neuropathy, was coined by a French scientist almost in 1817 It was redefined by Miller Fisher in 1935 with the classical symptoms picked up by him: quick onset, no pain, and optic disc edema with end stage atrophy. Non-arthritic ischemic optic neuropathy was coined by Dr. Sohan Singh Haire in 1970. Why we are discussing this? Because this is a well-known entity which ophthalmologists pick up. But as I said, with the drugs like semaglutide, tirzepatide, and other GLP-1 agonists, AION has been seen in some of these patients at particular examination level. The unfortunate part is this affects a very small head of optic nerve and can lead to sudden painless loss of vision of one eye, more common, caused by reduced blood flow to optic nerve. It is usually seen in adults above 50, predominantly males. Caucasians are more affected, and US incidence which was shown was 2.3 to 10.2 per lakh in that particular population. I know the prevalence incidence is very rare, but the unfortunate part is the person who gets it to the eye which is having it, the visual loss is almost complete, and that is a very, very distressing feature. And that is the reason this so rare complications we must give due respect. There are a lot of litigations coming up in US for this particular complications. This is classical fundus, yeah, optic disc, everything absolutely normal. But if you look what happens in optic neuritis, the disc practically becoming obscure, the margins are gone, and this is a classical picture. Those of us who look at fundi, they are probably familiar, but this is a very important observation which is seen with optic nerve affection. In this particular entity, it is acute painless unilateral vision loss, often with inferior scotoma, which has been shown here, and is visual acute dyschromatopsia, RAPD, and again this is a classical picture which I have shown slide. Why we should note it? Why this is important? Last 2 days we have n number of lectures on tirzepatide, GLP-1 agonist, which has come up as a very, very important drug in this tsunami of obesity. And though rare, again I would like to emphasize this has to be appropriately addressed. The pathogenetic mechanisms are multiple, there are many confounding factors, but still happens. The main issue is compromise circulatory insufficiency to the optic nerve head because of either hypoperfusion, hypooxygenation, and there are multiple factors which have been quoted and thought. All of them, the ultimate cause inflammation, edema, finally permanent optic nerve atrophy. These are standard understood classic risk factors: diabetes, hypertension, sleep apnea. List of drugs apart from these two are PD5 inhibitors, amiodarone, interferon alpha, OC pills, and sumatriptan, which is a drug used for migraine. What is culprit? One of my colleague was asking whether we can pick it up early in some patients so that we can either do not use this medicine or correct the defect. The major issue, cup to disc ratio, most of us when our patients are looked at with the eye, and whenever the normal ratio considered, whenever it becomes more, the narrow margin which we see around this cup becomes more and the disc becomes smaller comparatively, and this narrow margin at the periphery of cup and in between disc leads to ischemia of the disc head and causes this particular pathological issue. So whenever we examine fundus of all our diabetic patients, apart from diabetic retinopathy, this aspect has to be looked into, because in future most of our patients would require drugs like semaglutide or tirzepatide, or some of them would need older drugs. There are some evidences which I'll pick up couple of them. The first, where SEMA and this entity was recorded, about 8 lakh patients were seen, and the incidence rate was 14.5 per 1 lakh, which we have quoted was up to 10.2, and the risk was higher than EMPA for SEMA while using specific definitions which I have quoted. The brief message of this particular study is the study suggested a modest increase in NaION with semaglutide use. This is another study which suggested that it revealed higher risk of NaION in patients who are prescribed SEMA than other non-GLP drugs of diabetes, but requires further assessment of casualty. Look at HR, hazard ratio. SEMA and LIRA had strongest association with this particular entity. What Drug Watch quoted, this is a recent 12th August mention that SEMA or tirzepatide and optic nerve visual pathway disorders in type 2 diabetes. This is a recently published data, and this has concluded that both above molecules had increased risk of NaION in patients who had no prior disorders. So these are some important mentionings about this particular hazard. And last series of about 9 patients using GLP agonists, both the drugs, the eye complication was seen in 7 patients according to this case series given by Bhattacharya. So what do we do now? Globally, only European EMA has made it rule that the product label should have warning about NaOIN and it's a documented rare side effect. They also told the health community that all patients should seek to their medical or ophthalmological doctor if they have any sudden changes. The point is, once patient develops signs or symptoms, recovery to normalcy of vision is very, very difficult in spite of all possible modalities which are not really targeted to the expected result. And that is the seriousness of this particular entity, though it is rare. And if you look through, Europe is the first country which put it on its medical guidelines. Australia, the therapeutic good administration report said that they have collected lot of reports with respect to NaION and tirzepatide and semaglutide. They have requested their RAG-CP body that this is coming up, and they have noted it, but till now in even Australia there are no guidelines. The health professionals are advising their patients, especially with those with pre-existing risk for NaOIN, to undergo regular medical examinations with their doctor, and if there are any acute symptoms, they must report it immediately. Unfortunately, the biggest user, USA, it has not yet shown, and the FDA and DeliMed say that this point is not yet come in American FDA guidelines. So is the story of CDisco of India. So US and India do not have this labeling. Japan, they say that we are monitoring this, we have noted this, we are warning our health professionals and we are telling it to the patient, and they are watchful for this AE. They are also yet to put it officially on their request. So, in spite of all these, though the data is inadequate, not complete, should we use it without monitoring? Probably the answer will come after about 3 years. Focus is a dedicated long-term diabetic retinopathy trial conducted to establish effect of once week SC semaglutide 1 milligram on the development of progression of diabetic retinopathy. 1500 patients, 18 countries. This would be completed by last quarter 2027 and it will be out by 2028. The study aims to capture all eye-related AEs, not only diabetic retinopathy, but this also. And probably after this study, we will have a final answer. Till then, I think we have to respect this rare but vision-threatening complications. And as per our regular recommendations in diabetics or probably obese people, we have to look at the eyes for retinopathy, CD, that is cup to disc ratio, and if it is abnormal, I think we have to be watchful apart from all those. And yes, definitely diabetic, obese, hypertension, OSA and hyperlipidemic patients should be under more of risk. And that is the reason why we should do. Though there are surgical options, steroids are used, aspirin is used, anti-VEGF are used, but the outcome, improvement in therapy, the results are not satisfactory. So till the focus study comes out, we know that it is ischemia of optic disc, acute painless, one eye vision loss, which is really bad for an active person. Risk factors are well understood: diabetes, coronary heart disease, hypertension, hyperlipidemia, OSA, and drugs which we have quoted. There are many confounding factors. The exact cause, pathophysiology, is not known, and that is the reason this entity with typical clinical symptoms will keep coming, and till then I think we have to respect vision of the person. We must watch at the disc at risk, and regular retinal assessment along with CD ratio, cup to disc ratio should be done. Thank you very much.
Thank you, Dr. Sanjeev. The discussion will at the end of this session, sir. So now I would like to call on the dais Dr. Manoj Chalna, sir. He is Director and Consultant at Diabetes Center. Over to you, sir. And sir will be talking about the dynamic duo of high protein nutrition with pre and probiotics.
Thank you. Thank you, Chairpersons, Ayaz and Dr. Mohanty, and thank you all of you who've managed to find their way to this hall. I've been worried. You know, originally when we planned the meeting, all the meeting halls were going to be on this floor. This is how we were going to have 1, 2, 3 halls. Then fortunately, to some of our educational partners, we got better fund and we could move up to the, but they didn't have the third hall. They had already given it away. Otherwise, all the 3 halls. So again, thank you for all of you. And I see good number of people here. What is extremely difficult to speak about in nutrition is to do that when you've still not had lunch. So I'll try and justify the topic and bring about certain important aspects. You keep hearing about this all the time, right? Protein cow and proteins. Why? Why is protein so important? Why should it be replaced? And there are different aspects of protein and fiber. And let's also then quickly dwell into the different products available in the market, how it helps us choose. So protein intake in India, essential for various bodily functions, often lacking and overlooked, especially in the Indian diet. And it's not the vegetarian diet. How many here are non-vegetarian? I can see almost 80% of the hall is non-vegetarian. What is non-vegetarian? So, you know, we are actually poor non-vegetarians. We will eat
at all, you'll have 2 bites. Just in a conference like this, sometimes it's crazy, but otherwise you will eat 2 bites of chicken or something. That's our protein. There are times which is difficult. I've traveled to different places in the world, and when they serve you in places that have especially European influence, French and others, the kind of meat that comes onto your table, it's difficult to finish it, and you wonder, but that's the normal portion of that they. Even if I eat meat, I just can't eat meat. I will still want to have it. By the curry, I will put on the rice and or have it chapati ke saath, the chicken curry. That's the kind of thing. So we still need our carbs. That protein never really suffices, and that's where we are extremely deficient. So 73% of Indians are protein deficient. Over 90% are unaware of daily protein requirement. 85% believe protein consumption leads to weight gain. I'm going to eat more chicken. I'm going to eat fish. I'm going to eat more paneer. I'm going to gain weight. So that's the kind of myth which is there. And health issues which are associated with low protein are weakness, muscle atrophy, brittle hair and nails. How often have we really considered that when patients tell us about the brittle nails and we just say iron deficiency hoga, calcium deficiency hoga. We've never really dwelt into the protein aspect of that. So let's think again how much ill-informed have we all been, and hence not really, we look at it as non-specific complaints from the patients. And all of us are very smart. When somebody will tell us about this, wo theek hai, but sugars ke liye dhyan dena. This is what we do, and we go back to talking about that. So that's important for us to evolve. Sorry. Adequate protein intake recommendation for adults. So how much is that? It's close to 0.8, 0.85 grams per adult. So if somebody is 65, this also, look at all the examples, they will tell you 65 kg and 70. Indians also average are not 65, 70 anymore. So, that example should also change. The average Indian weight has also gone up now. But this is where it tells you. So 54 grams of protein. It's difficult. Try calculating in your meal how much protein is there, and most of us would struggle to go beyond 30 grams of protein a day. It's not really easy. And you ask, especially a vegetarian individual, and they would say, I'm having dal, I'm having pulses. Sorry, that's not giving us enough at all. So that's the problem, that's the daily recommendation. And life course changes in muscle mass and muscle strength. So this is important in terms of how our protein buildup is. So obviously, in our early life, we are deficient as we grow up and get into adult life, which is where you get your muscle mass and muscle strength. A 25-year-old is the one which has the best possible muscle strength. Right? Some of us here are gone beyond, and we are already in our decline. Post 50, you're going to lose muscle, which is where people celebrate their 50th birthday. You should start giving them the protein shakes or the protein supplements available, because that's what is needed more than the malt whiskeys which get distributed. So I don't mind the latter also, but let's understand the muscle mass, how it happens. So factors which also affect the muscle mass are lifestyle habits, which is impaired nutrition, reduced physical activity, too much of alcohol, and smoking. And there's genes which are also responsible for this aspect, such as the IGF-1 and the vitamin D receptors, which are actually responsible for the muscle loss. So sarcopenia and muscle loss is extremely important, and all of us should be assessing it, whether it's hand muscle grip, right, or different aspects where you can more refine body composition analysis, DEXA, whatever means available. Factors which affect the muscle health and role of nutrients, functions of muscle protein. Again, if you can reiterate, it's reincorporation of amino acids into the protein, energy production through oxidation, gluconeogenesis, synthesis of immune components. Proteins are actually extremely important for your immunity and immune protection. Go low on protein, you don't have your immune protection at all. Factors which influence the muscle development is muscle contractions during exercise, and hence which is where muscle building, muscle resistance and exercise becomes important, and the amino acid intake diet. Which is essential for your muscle repair and growth, and highlights the significance of sufficient in our diet. Lifestyle factors in muscle loss, again, to repeat, it's about excess of alcohol, smoking, inactivity, reduced energy intake, no exercise, and vitamin D deficiency also adding to the problem. Quick call on proteins, calcium, and vitamin D on the musculoskeletal health. Post age 35, your joints do undergo degenerative changes. So, how are each of these components important? So, proteins and amino acids play a crucial role in the muscle growth, its physiology and metabolism. Protein constitutes approximately 50% of your bone volume and around 1/3 of its mass. So, it's not just your skeletal muscle, it's also your bone health where proteins are so much important. Calcium, of course, is the dominant mineral within the bone matrix, and vitamin D is involved in differentiation, proliferation, growth of muscle cells. So protein, calcium, and vitamin D all are going to be important for both your muscular and your skeletal health. So let's keep that in mind. Gut wellness and its role in nutrient absorption. Importance of gut health is also important. Maintaining a healthy gut can significantly reduce the occurrence and severity of functional gastrointestinal disorders. Persistent digestive issues such as so-called acidity, gas, bloating, and constipation can also alter the gut motility and microbiota balance. And it's going to be important, and I'm going to show about how different products can actually influence your gut microbiota. So the importance of a healthy gut is effective digestion and absorption, improve the gut motility, stable intestinal microbiota, effective immune status, and absence of illness. Role of gut microbiota, extremely important in the metabolism. We keep hearing about the gut microbiota and enough conversations and talks and its impact even in metabolic health. It's also the host protection and immune system development. Again, that's where the gut microbiota is important. And the gut muscle axis. The right kind of gut microbiota will improve the protein digestibility, gut motility, and the short chain fatty acid production, and it will reduce the translocation of inflammatory molecule. Now, what is the general perception of pre and probiotics? What are probiotics? Probiotics, we all hear. Yes, your pro is actually the gut microbiota. You're supplementing the healthy bacteria. That is your probiotic. And the prebiotic is something which helps the probiotic actually work and proliferate and be there. So let me clarify a bit on this, because I myself, all of us have used these terms so loosely, pre-probiotics, things like that. So what really are prebiotics? Well, they're defined as non-digestive oligosaccharides that go transformation by the beneficial colonic microorganisms, which is the probiotic. Your so-called gut bacteria is the probiotic. And these are non-digestible oligosaccharides that are required for the probiotics to actually function. The prebiotics will inhibit pathogens, reduce allergy risk, enhance immune protection, modulation of probiotics, production of metabolites, and so on. And the effect of probiotics is going to be, the probiotics are actually live microorganisms, what we loosely refer to as your gut bacteria, the healthy bacteria. That's something it's so difficult to explain to your patient. Common. If we want your, we are trying to give you bacteria in your stomach. So that's how. So people, it takes a while to understand that gut bacteria or microbiota is so important for your digestion, and which is where probiotics are helpful for causing immunomodulation and the cascade that here normalize the gut microbiota and have beneficial metabolic effects. So pre and probiotics have a huge role in protein absorption and muscle integrity. They regulate the intestinal microbiome. They induce the host digestive protease and peptidase activity, the small peptides. They reduce the harmful fermentation. Now, let me quickly highlight on some of these different unique products, which is the unique IS2, which is a probiotic, Bacillus coagulans. Bacillus coagulans unique IS2 and health outcomes achieves the adult gut health, and when you use this, reduces or alleviates abdominal pain, normalizes bowel movement, and mitigates overall symptoms in adults. Manages even acute diarrhea and small intestinal bacterial overgrowth. How many of us, till a few years back, if we got a call from the patient, diarrhea hai, and what would we say? Take an O2 or take an Imodium. This is what we were doing. Today, probably many people into telling them that take a pre-probiotic, take an enterogermina, whatever, you'll have multiple different products. We take that. We're not rushing into just using antibiotics, which funnily enough are destroying that helpful gut microbiota, and we were contributing to it. It was giving the relief, but it was not really doing the job that it should have. This Bacillus coagulans also improves the muscle strength. So it augments muscle strength and optimizes the protein absorption, and also concentrates on improving the muscle power and plasma amino acids. There is data on research and safety for these aspects. And quickly on the properties of Bacillus coagulans: vitamin synthesis, good probiotic potential, resilient nature, digestive enzyme, and antimicrobial properties. There is some clinical evidence and studies have shown that as compared to placebo, in the interventional group, when you've given the protein supplement or protein powder, which has 2 billion units of the Bacillus coagulans, it has done much better in terms of increasing the availability of protein, improving the gut health, and overall improving the exercise performance as well. Finally, the dietary fiber and health benefits, again a term that we use very loosely. There are two aspects in the fiber: insoluble and soluble dietary fiber, and which is where I would want to end the aspects. What is insoluble dietary fiber? Not fermentable or poorly fermentable, non-viscous. Examples are actually your whole grain products, cellular resistant starch, and protein, lignin brands, etc. These are your insoluble dietary fiber. And then you have the soluble ones, which is fermentable, again which you have viscous and non-viscous, and you have examples listed here. When you're trying to give a wholesome fiber, you actually want to have a composition of both insoluble and soluble. So dietary fiber would consist of remnants of edible portions of plant cells, polysaccharides. These fibers are not digested by the human digestive enzymes, but are fermented in the colon. And which is where even in other exams, whether it's grain, legumes, salad, when your patients start complaining of poor gut health, constipation, you tell them to have fiber because it's so essential to form the stool. Only your other food is not going to form the stool. The person is going to be constipated. So you need this roughage, you need this fiber to help that aspect as well. And then you have the highlights on fructooligosaccharides, which is a unique prebiotic. And there are again properties of this prebiotic listed here: water soluble, highly hygroscopic, and resistance to hydrolysis by the human digestive, which is what a prebiotic should be. And the mode of action of this FOS is it reaches intact in colon, undergoes fermentation by the colonic flora, and promotes growth of the healthy microbiota that we want. The health benefits of this product FOS: prebiotic, relief from constipation, facilitating mineral absorption, and modulation of immunity. So let me conclude by showing highlights on this aspect of protein metabolism and our choice of taking a product or a protein supplement which has probably this unique probiotic which I mentioned, and also having sufficient fiber which helps in ensuring that you're getting the right prebiotic. So muscle loss begins as early as the age of 30 and accelerates significantly due to lifestyle factors. The musculoskeletal integrity is maintained by an interplay between protein, calcium, and vitamin D, not just one aspect. Maintaining a healthy gut microbiota and effectively managing gut health issues like listed IBS, constipation, etc., which is where the maintaining this gut microbial health is going to be important in multiple health aspects. High protein supplementation, including prebiotics and probiotics along with physical activity, will go a long way. Pre and probiotics, including Bacillus coagulans, unique IS2, and the FOS, which is fructooligosaccharides, have been shown to improve nutrient absorption. When you choose your protein supplement, probably having something which has these aspects would be the right choice to offer to your patients. But more importantly, this conversation is about understanding the need for protein, fiber, and the different aspects towards gut health. So with that, let me thank again all of you for being here in this room and being itself. Thank you.
What do you say?
Thank you, respected chairperson. the outset, I would like to thank Manoj and Purvi and Team DRS for giving me opportunity to speak on the molecular and clinical characteristics of monogenic diabetes. And young diabetes has been our area of interest in KM Hospital, and we have been the part of young diabetes registry with ICMR for almost last 2 decades. And we are doing enough and enough research on that. And in today's presentation, I'm going to show you what work actually we have done so far, and how it can be helpful for our clinical decision making if such patient comes to you. Thank you. So, single gene variants affecting either insulin synthesis, secretion and action, it accounts for 3.4% to 4% across all over the literature. And the commonest problems which occurs with monogenic diabetes is either it can be a neonatal diabetes, it can be MODY, or it can be syndromic diabetes. There is a high prevalence of monogenic diabetes in type 1.5b, which is antibody negatives and causing around 12.5% of type 1.5b could be monogenic diabetes. Today clinical trial, one of the largest trials showing 4.5% adolescent type 2 diabetes were actually MODY. So there is a heterogeneity of eligibility criteria and screening of a limited number of genes which possesses the challenge in determining the true prevalence of monogenic diabetes, and that's why we aim to describe our experience of evaluating the genetic using next generation sequencing and clinical characteristics. We all know NGS, it enables rapid and simultaneous screening of all known diabetes genes at a single test, and very useful for that. How it is going to be useful? Guides the precision therapy, switching from insulin to sulfonylureas, and make the patient very happy that so-called clinically labeled type 1 diabetes patients, and now they are switched to sulfonylureas. Patient also become happy, which can be possible for ABCC8 and KCNJ gene mutation, and it facilitates the family screening and management also. So ours was ambispective study in Department of Endocrinology, run over last almost 2.5 decades. The onset of diabetes mellitus was before 30 years, and their patients with strong family history of young onset diabetes were included. And we definitely excluded type 1 diabetes with high titer autoantibody positivity and type 2 diabetes with obesity and signs of insulin resistance. We definitely recorded age, sex and demography and anthropometric metric parameters, including lab evaluations and GAD antibodies and other parameters, and the treatment and outcome. So we screened a total of 119 patients suspected monogenic diabetes, characterizing the absence of high titer beta cell antibodies meeting at least one of the following criteria. A, it is diagnosis of diabetes and hyperglycemia before 30 years of age, positive family history of non-autoimmune diabetes mellitus, at least 1 or 2 or 3 generations of diabetes in that family. C-peptide cutoff, what we take is 0.2, the fasting C-peptide, and stimulated C-peptide 0.6, stable fasting hyperglycemia, the signs of insulin resistance, and presence of extra pancreatic phenotypes. So results were, out of 119, we found monogenic diabetes in 45 patients, which is 37.8%. It's very high. Of which 5 were neonatal diabetes, 20 were MODY, and syndromic diabetes were 20. And among syndromic, Wolfram syndrome were 9, Walcott-Rallison syndrome was 1, Rapson-Mendenhall syndrome were 3, lipodystrophy syndrome 3, Rogers syndrome 1, mitochondrial inherited diabetes and deafness 1, Fanconi-Bickel 1, and APS 1. And amongst the MODY, the highest prevalence what we have noticed was for MODY 12, which is MODY X ABCC8 gene, 7 patients. So when talk about neonatal diabetes, although the true prevalence of neonatal diabetes is very less, 1 in almost closer to 1 lakh live births, it can be temporary and it can be permanent. There are certain genes which shows temporary neonatal diabetes, and there are certain genes which can show both temporary and neonatal diabetes. One thing is very interesting, and I'm going to show you the case next subsequently, that the diabetes frequency relapses at the puberty because of high insulin requirement. Now this is a girl, she presented to she's a 9-year-old girl studying in 4th standard. She presented with polys and LRTI. She was investigated somewhere, found to be diabetic. C-peptide was 0.55, antibodies were negative. So she was diagnosed as type 1.5b diabetes and started on insulin. She was referred to us for further management to AK3 mutation suggestive of Walcott-Rollison syndrome, where there are extra pancreatic involvement which has been noticed. Another patient, 30-year-old female, diagnosed with diabetes as 25 years of age, no history of DKA, C-peptides are normal, treated with insulin. There is a family history of diabetes, and mother died. She had deafness and she died for whatever reason unknown. We did the genetics and found that the patient had mitochondrial diabetes, and it is MIDD, mitochondrial inherited diabetes with deafness. Patient is treated with DP4 inhibitors and coenzyme Q. We stopped the metformin because of very low BMI. Again, 16-year-old female born out of non-consanguineous marriage, presented with generalized darkening and primary amenorrhea, diagnosed with diabetes at 15 years of age. C-peptides was very high, insulin levels were very high, and there was acanthosis at neck, axilla, groin, and the patient having muscular appearance. We did the next gen NGS, which is showing partial familial partial lipodystrophy due to LMNA variant, and patient when treated with insulin sensitizers like metformin and pioglitazone. So when we summarize our syndromic diabetes, we have 9 Wolfram syndrome, we have 3 lipodystrophy syndrome, we have 3 Rapson-Mandel syndrome, we have 1 Walcott-Rallison syndrome, 1 Rogers syndrome, 1 MIDD, 1 Fanconi-Bickel, and 1 APS, where lipodystrophy and MIDD are on oral hypoglycemic agents and others are treated with insulin. The discussion which I started with that, when the antibodies are negative, you can screen the patient with genetic testing. But the French study, the Finnish study, pediatric registry showed that low levels of ICA antibodies, islet cell antibodies, sometimes may have genetic mutation positive for HNF1 alpha and GCK. So the titers what they have proposed, these titers, they say that if the antibody titers are more than that, you can still think of it is not type 1 diabetes, but go ahead and do the NGS sequencing. So high prevalence maybe at our center, maybe because of referral bias. The most common subtypes were MODY and syndromic diabetes. The most common MODY was MODY 12. The most common neonatal diabetes was ABCC8. The most common syndromic diabetes was Wolfram syndrome. Family history is very important. Young onset diabetes in 3 generations of family members, and consanguineous marriage increases the likelihood of autosomal recessive syndromic diabetes. Obesity is a feature of monogenic diabetes with MODY 11. Extrapancreatic phenotype may help in etiology. If the beta cells are with sufficient C-peptide showing they do respond to OHS, otherwise like MODY 4 and 5, they require insulin. Patient can be successfully transited to sulfonylureas. MODY 12 can be treated with sulfonylurea. Few cases of MODY 1 and MODY 3 can be treated with sulfonylurea. GCK like MODY 2 can be treated with lifestyle modification. So if a child comes as neonate comes with a diabetes, always think of NDM, neonatal diabetes, if the antibodies are negative. If the patient presents below 30 years of age and having syndromes, or there is a family history of 2 or 3 generations in the family, think of either it can be type 2 or it can be MODY and screen for that. If the patient is having any extra pancreatic features like deafness or neurologic features, think of syndromic diabetes, and the milder part you can think of GCK as one of them. I would like to conclude, the prevalence of monogenic diabetes is more influenced by the pre-selection criteria at our center, and that's why it is showing almost 38%. The precise diagnosis of diabetes has enabled and replacement of unnecessarily insulin injections with oral medications, and the families and the children are very happy, even though they were taking insulin for many years, and genetics were available, we have successfully shifted them back to sulfonylureas. In summary, our study described clinical, biochemical, and genetic characteristics of Western India people living with monogenic diabetes, and underscored the importance of NGS, that is next generation sequencing method, for better individualized management. With all this, thank you for patient listening. Thank you very much.
Thank you, Dr. Venkatesh. Thank you so much. We can get one quick question if there is any question. No, then we are already late for this. Thank you very much, sir, for finishing this on time. We request other speakers, sir, to come onto the dais.
Thank you, doctors, for the insightful session. Now, moving ahead to a practical AI workshop in DRS. And to chair this session, I would like to invite Dr. Ritu and Dr. Sachin.
Everyone. Able learn. Instead, the next one. This is big. Or think that excited and have any because Dr. Alok is very common face now about proper and then this fellow of American College of Physicians USA, fellow of hypertension, fellow of diabetes, done a postgraduate diploma in psychology from ex-faculty Shivaji Hospital has been top 20 editor and public chapter in clinical medicine of country top 10 reviewer award. This is also been the year 2020 by the AC chapter, the both certified personal artificial intelligence has been also undergoing training. He keeps himself IIT has been invited by NDTV faculty says, and the list is exhaustive. Also part of Faruglitazar is managing committee, various associations, medical consultants and legal consultants, course director for a lot of committees, also recipient of various district chair awards, well, and that. To you,
Thank you, Ritu. That was so sweet of you. I'm hearing so many sweet things in a diabetes conference would increase my blood sugar. But then you are a very fantastic and a very reputed diabetes. So thank you for that. The outside, I would like to thank the organizing committee of DRS. Dr. Manoj was here. The real organizer, Dr. Purvi, is here. So thank you, Purvi, for giving us this opportunity. Thanks, Banshi sir, Dr. Sir. Dr. Bharat could not make it today for some health reasons. So I would like to take his talk on his behalf. So I'm grateful to him for this opportunity. So we are going to talk about something very basic, which is going to come in the pipeline in the next few days. And I would like you all to understand that this is something which is very much relevant because you would be facing it whether you like it or not. It always happens. Tech glitches in any tech conference is always a very good. Fine. Except we will be now talking about smart document. Before I go ahead, I'll tell you something very important. A lot of you people are using EHS, which is not an AI-based solution, because EHS is just something where you manually entry and you get the data printout. I mean, it's more like a glorified typewriter or a computer that we're using. We hardly use it to do anything. Once ABHA comes in, ABHA is the health Aadhaar card for an Indian population. We have created an over ABHA. You can do it, it's voluntary, it will be mandatory within 2 to 3 years. Where a patient would have his own ABHA card, which is an Aadhaar card without which health records will not move. They will all be digitalized and from hospital to hospital. The Ayushman Bharat scheme, the government is going to make it very. They've already started an office in Pune. So why smart documentation and how ABHA gets connected with AI, I will tell you very soon. First, let's understand why smart documentation is important in AI and how does it help the patient. The problem in documentation today is one, if you don't document, you would not be able to get back to your patient data. Medico-legally, you need to have a very smart documentation system. If you do not have it, you're going to ask for trouble because when you land up in court, courts don't see what you have done, courts see your paperwork. Now the problem is when you're documenting, a lot of time is spent in documentation. If you go to any corporate hospital, you will see that the nursing staff in your own, and we are all NABH, and yesterday was my NABH inspection of my hospital, 80% of the energy is spent in how did you document, why did you document, why not that, how did you do that? I mean, it's maddening, you know, you would like to spend 10 minutes diagnosing a mitral stenosis or understanding the diabetes glycemic variability rather than jotting it down how and why it happened. So that is something either you do or you keep an RMO, assistant officer under you, or a trained nurse under you who has a potential of shifting your patient to their own clinic after some 5 years of training from you, etc., and it's a big burden on you. So this is a crisis of documentation. See the reality across the planet, 4.5 hours every day is spent by the clinician. 63% clinicians get fed up just entering and data. The amount of money you spend is huge. Necessary amount of patients don't understand your jargon. And see, suppose Dr. Shambhu is my, I'll put the scene. Suppose I am Dr. Shambhu's patient and tell him, look boss, I've got some chest pain. It's nagging, it's coming with nausea. He said, Acha. When did it come? Tuck, tuck, tuck. Does it increase or decrease? Tuck, tuck. Acha, did you get it in the morning? Tuck, tuck, tuck. Does it increase or decrease after eating food and walking? Tuck, tuck, tuck. So what the hell are you doing? I'm coming to consult you. Then he looks at the computer, takes a printout, and my patient told me, ये डॉक्टर को कुछ आता नहीं, वो कंप्यूटर इसको बताता है, वो देख के बाहर निकल. This is the reality of today's working in engaging the patient through a written work or a paper work or keeping records. So there is a huge amount of patient gap and patients don't get connected with you, and what jargon you're printing out, naturally the patient doesn't. So this kind of a documentation system that we are having today, it's overloading the patient, it's stealing the focus from care to something which does not exist, which is mandatory on the healthcare provider. The legality, naturally you practice defensive medicine, that matters. So, you know, you always dream of a system where I and Shambhu could have a eye-to-eye connect. And if he were a lady, I would love to have a better eye-to-eye connect. And probably get things moving, and I would come and tell my wife, what a fantastic doctor I have met, and he put a hand on his shoulder and he looked at me, or meri bimari dur ho gayi, you know. And I get a prescription which makes sense to me because he is busy talking with me. So your chest pain comes on the left or the right, and don't worry, I'm there to take care of you. And every time he is talking, somebody is working in the background documenting things and taking care of things in a scientifically valid, accurate and pragmatic manner. That is the role of AI. Why AI? Intelligence. AI is artificial intelligence, which we fondly call as augmented intelligence or additive intelligence. So this is one aspect of AI which transfers clinical documentation. So what are these AI, agentic AI? Something called as an agentic AI, which is an ecosystem of AI on its own. These are the new medical assistants. So what they do is they just listen. So you guys are listening to me. You guys are estimating what I'm saying. It's making sense to you. The AI works like an intelligent partner. It listens and makes sense. It processes that information. So if you have seen some good AI tools in action, when Dr. Shambhu tells me, so does your chest pain increase after food or does it increase after walking? He's referring to angina on effort. So AI understands if I say yes, that means I'm having angina. But that means it's most likely a coronary. And suppose he tells me, do you get chest pain, which is accompanied by nausea and it does not go away when you take rest? AI understands that this could be an inferior wall myocardial infarction with the chest pain component, the gastric. But an AI cannot be ruled out, and it documents all that. All this happens seamlessly in the background and does a lot of. It makes a huge impact in clinical practice. 550 plus clinicians in New Chicago found it fantastic. 90% of them paid a huge attention to it, and there was a satisfaction score of 71%. So the bottom line is you're going to focus on the patient. You're going to focus on the behavior of the patient. You know that communication is 90% is body language, 10% is the words. So when you do this kind of a pragmatic communication, आँख में आँख डाल के बात कर दो. I like to talk, even if it is a guy, we both are guys, but we connect better. Professional platform to clarify what jokes on that level. So AI freezes you to focus on the patient's body language and focuses the patient to focus on the doctor's body language. Comfort each other, have a pragmatic, scientifically professional conversation, and get out of the consulting room with the paperwork running in the background, which is medico-legally, ethically, and professionally. So AI also does that, and then AI can convert it into materials. So suppose after making a diagnosis of probably a myocardial infarction, which is stable, I would like to know what is it, what kind of future do I have, what kind of treatment do I deserve, and why am I getting an aspirin and clopidogrel, and why am I getting a statin? That patient handout get auto. We're talking of precision medicine, of personalized medicine. So it's not a standard pickup from the Google and print out to all the patients of MI that come to Dr. Shambhu's clinic. It is personalized for Dr. Alok Mut because his symptoms are different from maybe Dr. Ritu, if you pardon me, level infarct. Somebody like that, I'm making a guinea pig. So that becomes personal, and that education material is ready, pushed patient's WhatsApp, pushed on the patient, handed over to from a wireless printer sitting outside when the patient walks out. And this simplifies patient education. It increases the patient connect with the doctor. It increases the reading level from grade 10 to as 5.6. The word count, there's something called as word count. There's something token ChatGPT. The number of tokens you give, that elevates the cost of an AI. So what is this token? This is called transformative AI. I'll just give a little bit about what is transformative AI. There are some people who books very fast. Like I could read some I was known as a walking, talking Harrison. I could finish the entire Harrison in probably 1 hour. Not that I was a great big. I could finish the Harrison in 1 hour only because there were a lot of words. So when I say, I went out with my wife on the side of Ganges River, had a lovely bhajiyas and a lot of good adrak ki chai. So there are some words which need not be spoken. The message is clear when I say, I went on the side of river Ganges. I say, side of river Ganges, onion bhaji, good chai. The meaning is there. It may not convey sense, but for a machine, you don't have to give emotionally. So a lot of words are cut down. So that is called transformative. It picks up what is relevant, and a lot of crash is relevant. The size gets cut, the communication gets speeded up, and the conversation becomes scientifically accurate by cutting off a lot of from there. So that transformative AI happens. That is a part of natural language. That natural language process, something else, it puts a text, audio, or text, audio, and video. Human cannot do, and that grading level grade which I am talking to get reduced. So people having a low grade with after reduction of word count, the AI gives sense to them and makes a good help to them. So now if you look at your discharge summary, it's loaded with Hep B positive, Hep A negative, and child score so and so, NYHA class 3-4. Patients doesn't understand all that. They think it's all garbage for us. They go to a lawyer and they get treated. It's the whole thing could be a medical jargon that somebody could be kept with you, but a medically jargon list that somebody kept with the would convert into a difficult patient, a very lovable patient, and all this you cannot do. You cannot do it. Please, as you all would like anything. AI can do that at a high speed. That challenge gets recognized, and the impact on the patient, the connect with the patient, adherence to the doctor is by 20. So the complex scenario in a medical ecosystem today, in a medical hospital or a medical training college today, becomes a very simple, easy to assimilate and get better work done to clarity. I would like to add here something from Mike's. Your wife or start going to boil your tummy in a month. Tomato are forced to creep in because hunger is a necessity, but you're not getting food. Not that you don't want to eat, I wish my wife was here because she feeds me very nicely, but yet I got to sweet tomatoes like out of humor. When you give simple discharge summaries, communicative languages, which make sense, people are less inclined to go to apps and media and so it does help over there. It's shown in the Western world. Bottom line is your burnout is reduced. Instead of spending 1 hour for one hospital, probably spend 15 minutes, and the remaining 45 minutes probably you'll be happy to spend with your spouse or your girlfriend or boyfriend, and probably you'll spend in casual faculty room having a good time over. So the documentation burden which drives burnout and errors gets reduced significantly to the tune of 70 to 75%, and you can use all these LLMs. LLMs stand for large. These are generic LLM, ChatGPT, Perplexity, and what. You can use even those, but when you train them, medical literature, which Google has done recently, and Microsoft has come out very recently, if you have been following up our tech groups. So these are medically trained, medical literature trained LLMs, which do a fantastic job, and they can be or incorporate and add up to your EHS system, senseful, intelligent outputs. So when you understand the system, artificial intelligence reduces the load of both the patient and the clinician and the paramedical staff. It gives you an overall accuracy, privacy, and trust. Question that you can ask is, everything has been taken over by AI. What is my role except to nod my head? It is a doctor or the human in the loop. Right? Because whatever data is generated, output is generated, has to be approved by you. Unless you approve and you oversee it, it will not get passed channels. So unless you sign it in it will not move further. A transcription, approval, draft generation, and the reviews, everything is in your control. So clinician oversight becomes very important. Important aspect. Privacy. That data always belongs to the patient or one of the intermediaries handling the data. The paramedical staff handles that. But when data moves from a doctor to doctor, what happens? A lot of blockchain that takes care of it. The data gets encrypted, it gets decrypted, de-encrypted, and decrypted, and whatever data is collected, what work is being done, the moment done, the prompts that are required are deleted. Control access is entirely with the patient. Limited doctors will have limited control. Limited paramedical staff will have limited control, and all this becomes highly HIPAA compliant. So this is the core of an AI documentation that remains very secure to your server. It doesn't become universal, and even insurance companies have the blockchain technology. Blocks at each step. Whatever data needs to move from one block to the other, authorized to move, authorization set in place. Everything will not move without the consent of the patient, so it becomes highly secure. Bottom line is, when you implement the system, there is a better patient engagement. There is a better documentation. It can integrate from a Windows OS to a Mac OS, Android OS. It can integrate from various sensors. It can integrate from various EHSs, whether you're working with Medeva or Tocon or any other EHS or which is there in the market. Only AI can integrate these practical manner and customize it to suit your clinic. And depending upon the use, you can get a real-time decision analysis, get an automated follow-up. So whatever data paperwork you have done through AI can follow up with that patient. Hey, look, boss, you had inferior wall infarction, you got admitted, you got discharged. How are you feeling today? It will send a WhatsApp message to follow up, and patient can reply like you have airlines following up. What was your experience after deplaning from Air India? Did you have a good cabin? Did you have a good air hostess experience? Did you have a good check-in system at our, you get those WhatsApp messages where you answer 1, 2, 3, 4 and all that. So that follow-up will come automatically to your patient on your behalf, and it will also send an interactive education. So here I would like to talk about Sabuz Mitra, for which he recently got an award in ADA just 2 months back. Mitra is a fantastic chatbot that he has created. Maybe part of Docyantra, and Dr. Harsh is very much here. Another author is here. Unfortunately, I'm also the on a humorous ground. So we have worked on all that, and that has got an award, and it works so well. It can interpret that you're getting SGLT2, getting some kind of a urinary tract infection. So should you stop it or not? It takes care of all that. So it reduces your burnout and tells you, do not stop your SGLT2. Now it's time to consult your doctor because things have gone at that level. So bottom line is, you're creating an ecosystem with AI, which is legally valid, is scientifically valid, which is absolutely secure, which reduces your burnout, which reduces the patient's burnout, increases the body language interaction between the two partners of the ecosystem, makes for a better patient and a better doctor. And at the end of the day, you can take time out for your family and enjoy life as a doctor rather than sitting here burning papers and medicine. I'll stop over here. So that's the process. When you put AI into the system, that's an artificial intelligence. You don't get replaced, but you get less burnout and a better time to go to your beauty parlor and have a good time. Thank you very much.
Yes, sir. Thank you so much for elaborate session on the AI. Here I have
Bharat Sab, I mean Dr. Shambhu is next. I'll get burned out.
time to, go through his CVC. He's MBBS, MD, DM in clinical pharmacology, gold medal. Then his diploma in endo and diabetes, fellowship in respiratory and critical care, diploma in allergy, asthma, again gold medal. He's consultant physician and diabetes and allergy consultant at Kolkata, faculty at JMN Medical College. Treasurer, he's secretary to various organizations, published 148 articles, author of like best practical pharmacology, diabetes in practice, artificial intelligence in physician. There's so many here. He has published more than 80 books, 80 book chapters in different national and international. He is again fellow of Indian Pharmacological Society. Got awards, got few awards, Indian Academy of Diabetes. In 2022, he is S.C. Patel and B.C. Mehta Best Paper Award, the WIDF Innovator Award from Mayo Clinic, and he has got RSSDI Innovation Awards in 2024. Got government recognition for ACP India chapter, been awarded as MPS Promising Young MD Pharmacologist Award, and he's been awarded Young Scholar Award 2020.
Thank you, sir. Thank you for your kind introduction, and really thankful to Mr. Chawla and Purvi Chawla for giving me this opportunity to share my thought on how we can use artificial intelligence in medical research, literature review, and paper writing. So we all know that we want speed up everything. That rapidness, compressed timeline, that actually tell us why we should shift from the traditional design, which is actually time consuming, more literature dependent and expertise heavy. So that is why we need artificial intelligence, which is a smarter solution, and of course it increases the reproducibility. And when we talk about research, the first step is hypothesis generation, and how we can generate hypotheses with the help of artificial intelligence. We'll talk about a little bit about that. Though we in this particular slide I had mentioned about BioGPT or Perplexity AI, I had not been or expertise in that thing, but I used ChatGPT, ChatGPT 4. Now we all have ChatGPT 5. So when we talk about ChatGPT, prompt is very important. How we are telling ChatGPT, communicating with ChatGPT, that is very important. This is an example of prompt by which we want to prepare one research hypothesis. Here we had mentioned we want to explore the effect of religious fasting and on different health outcomes among the populations who are suffering from type 2 diabetes. And also we had mentioned few important points. The hypothesis, it should specify the relationship fasting practices, glycemic control, and possible cardiovascular metabolic outcome. Now we can see here there are 4 types of hypothesis. One is on Ramadan fasting, one was on intermittent fasting, one is on Lent fasting for Christians, and now cross religious comparative. But what is very interesting is all the responses we got from ChatGPT. But one thing I want to highlight here, the note that also given by the ChatGPT. So after hypothesis, we need to the research, and for research the design is important. And they had mentioned about you can do it by prospective observational study, by randomized control trial, or retrospective study. But what is again important, I just want to highlight how much ChatGPT becomes advanced. In our city, they had clearly mentioned where culturally. This terminology is important because being a member and sometimes secretary and chairperson of certain ethics committee, we had faced lot of debate with this theological point of view, and this is very critical, and good that ChatGPT also can identify this type of crises. So again, we want to do it in a more formal way, more detailed way. So we had modified the prompt here, and you can see we want all those 4 hypotheses in one. So we want to compare all those fasting practices between Muslim, Hindu and Christian populations. And also we had mentioned critically that we want to understand the effect of Ramadan fasting, increase the short-term risk of hypoglycemia or worsen the glycemic variability or not, or how the effect of intermittent fasting observed by Hindu or Lent fasting by Christian can improve long-term metabolic outcome. So again, we had mentioned this clearly, that please propose measurable outcomes, possible confounders, and culturally sensitive method to test this hypothesis. Now, why this prompt is little bit different than the previous one? Because we had clearly mentioned the population now. Then we had also mentioned independent variable here. What are the dependent variables? Like outcomes of short-term glycemic control, long-term metabolic or cardiovascular outcome, that also we had mentioned. And also we tell them to design certain add-ons like measurable outcomes with confounders and specific methods. Now we can find a modified research hypothesis here. We can see the modified research hypothesis, what we can get, the religious fasting practices exert heterogeneous effect on type 2 diabetes outcome across different faith group. So also we can see that when we talk about long-term metabolic outcome, now they had mentioned about HbA1c, lipid profiles and insulin sensitivity, and how it could lower the cardiovascular risk compared to non-fasting control. With this research hypothesis, also ChatGPT tells us about the study design. You can see here it could be a multi-center observational study. Age adult, here they had mentioned 30 to 70. Here it is our expertise that need to be involved. Why 30 to 70? We can make it from 18, above 18. That is not a problem. So the artificial intelligence need human intelligence. So we need to modify them little bit in a more robust way. So that is the thing what we want to highlight. It is not only the artificial intelligence that matters. Your intelligence is crucial. For an example, here you can see regarding the cardiovascular risk markers. They had mentioned blood pressure, HSCRP, Framingham risk score. But we instead of Framingham risk score, as we are doing this particular study in our country, we may think about score 2. So this is the area where we need to add our intelligence with artificial intelligence. But overall, what we need to appreciate, they will give a good structure and we can modify that structure further. So there are multiple tools we can use. Again, I use generally ChatGPT, but apart from that, we have BioGPT, Perplexity, Elicit, which is a very good tool to do systematic review and protocol guidance. So as of now, what we understand, artificial intelligence accelerates and enriches research design. But it is not a replacement, powerful assistant, We need to choose tools based on domain depth and task. Coming to another important area, because to search you have to do review, and systematic review is the most important reviews, and there are certain steps we can see in data analysis, starting from literature search to evidence synthesis and report. So while doing literature search, the AI tool, even the ChatGPT, will suggest relevant measures. And I think many of us know that now the ChatGPTs, their interfaces with PubMed and Embase API. So it is a faster, more comprehensive travel. And when we talk about data extraction mode, different NLP tools we have which extract the outcomes, intervention, and sample size accurately. And they will do the table for us, do the PDF mining. So ultimately, it will be a speed up structured data capture from all text articles. When we talk about bias assessment, which is a very important area for systematic review meta-analysis, we can use this artificial intelligence like Probust AI, which standardizes risk evaluation with suggestion justification. So this is one type of automated Cochrane risk of bias flagging. Coming to evidence synthesis and reporting, again, the different AI tools, the systematic review meta-analysis, talk about ChatGPT also can craft the summary, and they will guide us how to draw, how to prepare the prisma, and also writing support for result section. So ultimately get reporting accelerated. But again and again, human review is very important. So artificial intelligence support each stage of SRMA, but expert validation, scientific rigor. So we could use ChatGPT, we could use Search Refiner, because they will also give us the idea of different Boolean or mesh strings, and they will categorize into different type of Picot format, population, intervention, outcome. They will tell us about the design of different available researches, and then we will understand what is the effect. So it is a faster iteration of question framing, improve comprehensiveness of search strategies, reduce the risk of missing key studies. And when we talk about the difficulties with using this type of tools, of course, it should be reviewed again by the domain experts, because may overlook contextual nuances or rare study terms. Always is important to validate the criteria. I am giving you a small example here. You want to tell the ChatGPT, like, please generate a PICO framework for evaluating anti-VEGF versus laser therapy in diabetes retinopathy. So what are the AI output here? We can get PICOT was perfect. How much time left? Okay, I shall end up. I am learning only. So the thing is that just want to finish here. You can take the when we use ChatGPT, they give the search string like here, the last line. Okay, please note it. But as an expert, we got help from SRMA expert, and it is clearly visible that this search string is not appropriate. So we prepare the actual search string now. Again, with the help of ChatGPT only, you will get how many studies here? In the search results, you can see 150 results, 56 results. But if we use the previous terminology, previous Boolean string, then how many study? 0. So this is why we need artificial intelligence with human intelligence. as the time is less, I can. Thank you very much.
May I again request Alok, this session will not go into the listing, but always a privilege to be requesting. Going to speak to us about AI ethics, safety, and integration in clinical practice. Over to you, Doctor.
The chairs are very nice and helpful, so thank you for the kind words, Dr. Ritu. She herself is a dynamic author and she's done fantastic work in literature and AI. That is the level of her modesty. Thank you very much. Thank you, respected chairs, for this opportunity. Thank you, Manoj, Purvi, and the respected organizers of DRS. Now, the topic that I'm taking is a very tough topic because I've been talking a lot about for AI, and I'm going to blast AI and I'm going to tell you everything against AI. So we get prepared for the war here, running both sides of the debate, and because I'll be telling you about the problem. Timing starts now. Fix in the constriction. So I always call this like this. Marriage comes with a responsibility. It's wonderful to get married, but you need to stay in your marriage. So when you're using AI, it's very nice, but how to use it, stay compliant with AI. That's a huge topic. Generally take it for 3 hours. It'll be difficult to cover it in 15 minutes. I'll try to do a little good job of it. There are 5 problems that you come when you're talking of ethics in AI. How is the AI behaving? Is it biased? Who's liable for things going wrong with an AI? So suppose you treat a patient wrongly, you're responsible. Versus give a wrong injection, you have a vicarious responsibility. But if the AI tool behaves wrongly, will you take responsibility? That's a question. Are you sure about the security that we talk a lot about security, but how do you know the data is not leaking? And with an AI tool, a lot of people are going to make money. The company which makes the AI tool is making a lot of money. So if things go wrong, will they pay that money? Pay the money. And why should they make a lot of money when you're working with AI? So that is wealth inequality. And finally, just as insurance company decide whether your patient should be admitted or discharged, will the AI tool decide whether your patient should be treated or how you should? The company which is making the AI, will they be in control of healthcare or will you be in control? Some very pragmatic questions have been asked. And this has been covered extensively well in this WHO article. It's a 300-page article. They've covered this very beautifully. This is one editorial which we just wrote, me and Dr. Kulkarni. It has just got published 15 days back. Responsible use of artificial intelligence in clinical medicine. I would implore you people to read. It's a 2-page article. We have tried to cover this in a very pragmatic and dogmatic manner, and we have tried to do a good job of it. This was a paper which was just got published 15 days back in Jyoti Sir's journal, The Race of Artificial Intelligence in Healthcare Competition, and we have tried to cover, and I'm happy that 2 co-authors, Dr. Shambhu and Dr. Harsh, are sitting here only. In this paper, we have tried to cover a lot about the ethics of AI in Indian scenario, in Indian ecosystem. So coming back to my talk, the concerns are, how do you know that the responses are right, or is it a bias? How do you know that the data that was used to train the AI was a qualified data or was it a junk data? Because you have no control of the data on which it was trained. How do you know that after using AI, your own skills will not degrade? So when you put in a lot of ECGs in AI and you start getting a diagnosis of infection, you'll stop looking at the ECG. You'll tell your assistant, tool में डाल दे, infect है तो ICU में डाल दे, नहीं है तो घर भेज दे. So that will be the level because you will yourself replace yourself with AI. Question is, when you're operating on a patient, you have to take a consent. I'll take a little 10 seconds and tell you, since I'm also working for the medical legal team and I'm attached to some courts. If you take a patient for operation and you want to do a hysterectomy, and this was a case in Mumbai High Court in which the doctor paid a huge penalty for it. So the doctor went ahead and removed the uterus. He went ahead and removed the ovaries. It was a selfing or pan-oophorectomy. The patient said, with whose permission did you remove my ovary? I'm 30 years old. So he said, we took permission of your mother, and this is in record. The patient said, then you should have removed the ovaries of my mother. How dare you remove my ovaries without my consent? And the court ruled in favor of the patient that if you wanted to remove her ovaries, you should have closed the surgery, come back, take her consent and come back. So that is the meaning of a consent. It's serious, something very serious, because if we do something, this is to protect the privacy and the concerns, because a patient owns his body, her body, and he or she has a right to decide what they want to do. So when you're using an AI tool, you need to take the consent of the patient before you use the AI tool. If things go wrong, how will you answer the patient? And I ask this question also because we are in NC stage. If you do not use an AI tool and the diagnosis does not come to the nth level, patient will say, why did you not use an AI tool? So I'll tell you my recent example. I had a patient recently whom I'd seen 4 months back for diabetes. Sugars were 420 and some 320. It's a Gujarati patient, came to my clinic. I put them on SGLT2, glibeparide, metformin, the standard cocktail that we decide on a type 2 diabetic. Patient sugar came to some 140 and 90. Patient was happy. Then they decided, allopathic medicines are not good for health. So they moved towards Ayurvedic. For 6 months, they didn't show their face. Then after 6 months, they got a little nausea, vomiting, and a little chest pain. So they went to a cardiologist who did an ECG. It was normal, sent home. Went to another cardiologist, ECG normal, went home. Went to a gastroenterologist, because the area where I practice in Thane is loaded with Hiranandani state and Lodha and all. So those patients decide whether a headache should be seen by a neurologist or a physician, and they first go to a neurologist. After 6 visits, they realize that it's an ophthalmic problem. Now they need to visit an ophthalmologist. So that is how the private practice goes. So after visiting 3 cardiologists and having got an echo done and ECG, which was all normal, they realized that the sugar was some 420 and 520. So they finally said, Dr. Modi took care of her sugar, so let's go back to him. So they came back to me. So that is where I saw the patient and I thought things are not right. Why should he have a persistent nausea, vomiting? So I got an ECG which was normal, and I put that ECG in ChatGPT out of fun, and ChatGPT said this is non-STMI. And 3 cardiologists have told it to be a normal ECG. This is an actual case which I'm sharing with you. And having done that, I got the patient's tropi done, which was highly elevated, got him admitted, treated him. Angio showed a 100% right coronary block, 80% right left main block. Patient got 2 stents put in, is doing well, is doing fine. Bottom line is, if I didn't use AI, I would have missed a non-STMI. So patient can take you to task saying, why did you not use AI for my treatment? Consent is important. Did you take the consent either way or not? So that's an ethical issue. Doctor-patient relationship gets highly strained if you do not work ethically. Now let's discuss about bias response. So we train AI to give the best results. So an AI model has been trained to increase the ventilator output as the patient saturation is going down. If it keeps increasing the output till it develops a barotrauma or develops a pneumothorax, who will be responsible? So that bias response which gets done because of inaccurate and incomplete training. So that's where we play a role, and I don't want to advertise, but since me, Bharat and Harsh are doing this job, we are taking the AI tools and we are creating it ourselves. So we encourage you people to do that. When you create an AI tool, you know what medical science is. When an engineer creates, he doesn't know what medical science is. So that's where things go wrong. You can get a wrong answer because of wrong training of an AI tool. What about data quality? So what tool? Now, for example, Mayo Clinic is using a fantastic tool of picking up AKI, acute kidney injury and sepsis. And that's shown fantastic results, 23% reduction in the mortality rate. You read there are many papers in NEJM, which is AI journal, which is one of the top journals for AI. When you read those papers, you realize that the mortality comes down before even the creatinine rises within 24 hours of the patient walking into the ICU in a very stable condition. Now that sepsis model cannot be translated to an Indian scenario and copy pasted because the scenario there is very different. We're doing an antimicrobial resistance AI tool which tells you what antibiotic is good for empiric therapy in an ICU in Las Vegas. You can't communicate it to a Gurgaon ICU, or you cannot take it to a metropolitan Mumbai ICU. For example, an ICU which does this kind of an AI tool in Hinduja Hospital in Mumbai cannot be translated to a Thane corporate hospital because the scenarios are different. So data quality fairness plays an important role. Automation bias, over-reliance on AI. When you're getting your EGFRs and therapies and prescriptions on a complicated brittle diabetes, type 1 diabetes, you're getting a fantastic prescription to prevent hypoglycemic attacks. You will start putting it on all your patients. You won't even bother to think. I give a very classic example. When we were doing our undergrads, so you have a patient of mitral regurg, rheumatic fever. So it's a systolic murmur. Correct me if I'm wrong. Now a systolic murmur person with mitral stenosis, mitral regurg starts coming with a diastolic murmur. How can you get a diastolic murmur in a mitral regurg? When you ask this question, and I will ask you if any of you would like to answer in 5 seconds, a well-established mitral regurg patient starts getting a diastolic murmur. When can that happen? Any ideas? Anybody can answer? So a regurg is becoming a stenotic lesion. Why? Simple. You have got an atrial myxoma which is putting down. You have got an infective endocarditis which is a huge mass which is converting a a regurg lesion into a stenotic lesion, right? Now that answer, if you rely upon AI and you don't use your clinical sense, how will you make a diagnosis? So a lot of automation bias occurs when you depend too much on AI, and that has started showing results in medical students. They're using their AI tools and mobiles to walk into the wards and not using the stethos. But the idea, informed consent I've already covered. It's a two-edged sword. Did you use a consent before you use the AI? Did you use a consent for not using the AI? Either way, you can land up in trouble. So there is something like that, that LLMs can also be used by patients. Challenge your diagnosis and they can be right. Google patient can challenge your diagnosis and is wrong. But an AI trained patient can actually make a mincemeat out of you because you could actually be wrong. And he can pick up Chidiachi-Hikashi syndrome which you can't pick up. He can pick up Down's phenomenon which you can't pick up. He doesn't know what is Down's phenomenon, but his tool is telling you which you didn't know. So the output could be inaccurate, it could be manipulated, it could have an impact on certain individuals with disabilities and other ethnicities which have not been covered by AI because that tool has not been trained on that AI. It could manipulate an edict. So there was a case in Belgium where a patient actually committed suicide because the AI tool told him, the chatbot told him, you're useless, you cannot do anything. And he actually committed suicide, which was not required. AI tools can actually manipulate you and edict you. Like there were some games, where kids would jump out of the window to follow the orders in the game and they've committed suicide. An AI tool can tell the patient, boss, you've got cancer, your prognosis is very poor, you've got a very short life, which is not the case. Could be wrong, just as you could be wrong, I could be wrong. What about privacy? When you load all this patient's data on ChatGPT and Perplexity and DeepSeek, so much is being talked about DeepSeek, which is a Chinese tool, right? How do you know that data is not being manipulated by certain private companies to use the data for advertisement and creation? How do you know that you're right? I talked about doctor-patient relationship that, you have an eye-to-eye contact. But depending too much on AI could even deteriorate your contact further because you're not interested in talking to them. The patient is not interested in talking to you. Google patients make life hell for you. An AI patient can make life even more miserable for you. He doesn't need you. So there's something called as an epistemic injustice and hermeneutic injustice. Epistemic injustice is when a person's capacity as a knower is wrongly denied by an AI system. So this is ischemic heart disease, but AI says, no, it's a normal thing. Hermeneutic injustice is when the bulk, a collective medical college says that this is Chidiachi-Hikashi syndrome, but your AI says no. You say, no. AI is right, all of you are idiots. This was happening today. A Google patient says the entire hospital doctors are idiots. My Google is right. So there are a lot of responses called hallucination. This is a medical term. It's also called as GIGO, garbage in, garbage out. You put in a wrong prompt, you'll get a wrong answer. So I have got EGFRs of 1,340 on my patient from ChatGPT, which even is not possible. So if you ask a wrong question, you'll get a wrong answer. Try doing it with ChatGPT. Many times you get a very wrong answer. Like one of the papers I published, I got a reference from ChatGPT which does not exist, and Dr. Shambhu reminds me every day for that. See, because of you, something has gone wrong. So you can get wrong answers when you give a wrong prompt. And what is prompt engineering is nothing. So you have a very intelligent colleague. So let's say Dr. Shambhu is mine. I'll pick up a lady. Let's say Dr. Ritu is my very fantastic colleague and we are working together in a diabetes center. And I put in a very good case, but I forgot to tell her that HbA1c is 6.5, but I don't tell her that HB was 6. So she's going to tell me patient is well controlled. I'll say, no, you gave a wrong diagnosis. See, it's not a good control HB. Patient ka sugar itna high. How did you make a wrong? But I never told you the HP, na? What is her fault? So the prompt is not right. So an intelligent doctor can make mistakes if you don't give complete information. If you don't give the right prompt to an intelligent AI, it will give you a wrong answer. That is called GIGO, garbage in, garbage out, or hallucination. Technically called as hallucination. And that is where the role of prompt engineering comes. Prompt engineering is very important. And do you know that prompt engineers are being paid 7 lakh to 15 lakhs per month today in Mumbai? So I tell this in all talks. A couple of you could be interested in ditching your current profession and shifting to prompt engineering. After 6 months course, you'll be much better off than what we are doing today. So what is prompt engineering? I'll give you a small example. So when me and Harsh gave the MIT, Massachusetts exam, our capstone project was to create a model for Ola and Uber, because we were told which sectors have the maximum traffic, which customers are got the highest rating, which drivers have the highest rating, which time of the day has the maximum travel, and create a model to decide which avenues, which car, which driver, which patient should be given more importance so Ola can make 25% more money. Everything depends on what prompts I create for that model. The whole business of the organization. Now you understand why they paid 15 lakhs to 20 lakhs per month. So if you implement your own AI tool for your own clinic, for your own share market, for your own tax return, which I do, you will see how things change. That's called data analytics. So take out the data of your 20,000, 30,000 patients and see which patients are coming regularly, who are payers, who are non-payers, who are on insulin, who are not on insulin. Do that kind of analysis with your own clinic. You will see a very different experience of how your clinic will behave after you understand all that. So that analytics you need to create. That is where prompt engineering plays a role. So data quality, data issues, data bias, before they ring the bell, I'll move fast. LLM training is very important. Generic, we call it generic, ChatGPT, Claude and all. They're not trained on medical data. So they give you any answer because they're full of internet searches. But when you train a chat model, which is an intelligence model, on only restricted papers, restricted tools, it will give you answers from that. So when me and Harsh and Shambhu are writing review summaries of the papers that you just saw, which were written by AI, we have trained ChatGPT to write a review article only from the 10 articles that we give you, or only the 50 articles that we give you. So now a lot of eyebrows are going up. Oh, that is the secret. So we can write a very ethically accurate article because we tell ChatGPT to pick up information only from these 20 articles. Do not do a general search. So the output has to be accurate. So the data model, the data training, accuracy all depends upon how you work. So it's not a rocket science. A lot of your intervention is required. And can you depend upon the patient usage of LLM and how much you can depend on that? A big question mark over there. So there are a lot of issues. There is something called as a black box diagnosis. Now that is called as saliency. Now look at the saliency map. The first tool picked up the torso and the head of the, this is an army light tool. It was picking up enemies. So it could target the torso and the leg and send drones to shoot the army. Whereas the second tool started picking up trees and bushes and not this thing. So if you send drones to kill the trees and bushes where the enemy is hiding, you would land up in trouble. So the saliency map, how you train, is important. You can create havoc if your training model is not right. So safe failure modes in AI, just as when you do drug analysis, you do phase 1, phase 2, phase 3, phase 4 studies, you make sure that the drug has been analyzed in detail. How do you know that your AI model has been analyzed in detail or not? Have you validated the model? Have you checked the training models of your AI tool? That all plays a very important role. What about the long-term side effects? So an autonomous ventilator can keep oxygenating the patient irrespective of the patient going into oxygen toxicity. A lot depends upon your model, upon your oversight, about your implementation, about your migration of the model, on the companies that is making it, the engineers and the doctors behind it, the validation behind it, and if you're upgrading your model on a regular basis or not. And do you know that running ChatGPT is not a time pass thing? It's a very costly thing. It is costing a lot of money and resources to the company OpenAI which is making it. They spend a lot of money. Let's talk about labor and employment. We feel ChatGPT or AI will not replace professionals. The truth is it is otherwise. Look at the way that jobs have been taken away by Amazon and Meta because of AI implement. Look at the numbers. Let's finish. Look at the numbers that the jobs, they say the jobs will not be disappearing, but Elon Musk has very clearly shown a lot of jobs have been replaced, and he has gone to say that maybe after 5 years, Dr. Shambhu, me, Harsh, and Dr. Ritu, all of us will not be here. Our clones will be running the conference, and we would be sitting somewhere else. So when I said lady doctors could have a good time at the beauty parlor, 2 ladies came and told me, thank you very much for saying that. So maybe the next DRS conference, Dr. Manoj and Purvi will organize it, but we will be having Vatata Vadas and our conference will be running. That is a reality with AI. And I would implore you to see the YouTube video, Shashi Tharoor talks to Shashi Tharoor. You can't and check. Shashi Tharoor talks to his clone, and trust me, you can't make out who's the real Shashi Tharoor. So there is cybersecurity risk. Remember one thing, in training an AI model, you're using 7 million liters of water. You're using 3.4 gigahertz, which can power 300 US households for 2 months. Finally, concerns about dominance, concerns about dangerous algorithms, concerns about the legality. I'm not going into the legality. It is a huge topic. No law in the world is yet clear on legality. We are stuck with the DPDT Act. We do not have a clear principle of how legality should behave if an AI model goes wrong. There is a lot of work remaining, a lot of things to be discussed, a lot of FDA regulations to come in place, a lot of Indian regulations to come into place. And this is our ex-minister, honorable minister who would deal with it. Works is in progress. Sam Altman says that we would work with you guys, but we are not clear where we are entering. It's a nascent forest we are yet exploring. So I just wanted to elevate your this thing, to behave responsibly, to be a little concerned before you surrender yourself to AI and let AI take over you. Don't let AI take over you. Use it responsibly, maturely, and use it to help you as an additive intelligence and not to replace you. So thank you very much for giving me this opportunity. And I could not cover the topic. It's a huge topic. I just wanted you to just pay attention and go through it on your own. Thank you very much.
Questions?
That's in the preview of the chairperson, so I'll abide by that.
Let us welcome speaker. Quite interesting. We have here BBS and in diabetology, diploma in pharmacy, fellowship diabetology under Dr. Current Young Scholar Award, plus trained in diabetes therapeutics, USA gold level trainer, academy, USA again, diploma, advanced certification AI in medical certificate, code AI and ML, director, Dokayantra, state of the art AI in healthcare solutions, authored chapters, peer reviewed diabetes patients, the winner of best research abstract. Dr. Harsh Irani, and he will be talking on how to better prompt.
All right. So once again, a very good evening to everyone. It's indeed a great pleasure and honor to be here. Grateful to Dr. Manu, Dr. Puri, as phenomenal opportunity here. So I'm going to be talking more on practical utility of things, stage of AI. When you open ChatGPT, Gemini, basically how beautifully in our previous sessions, Dr. Alok, what we put the, what really defines what actual output AI can. As he rightly said, if you put the wrong context, it 1,000 feet. Yes. So just in this line, perfect. All right. So these are my disclosure for this. There's no of the products. We don't. Not one, but multiple ways to build this content. Now let me thank the team again for beautiful topic. Let me start. Why should, because 40 year on year, 86% of will be using some or other form of artificial competency gap challenge. It will be on happening. National mandate, guidelines are proactive towards faster and more. Let me start with hands-on prompting. But before I begin the topic, what does a prompt mean? Prompt is a specific action give to an AI bot, like how you see, get you a desired result. Prompting, the act of giving a specific instruction to that. Prompt engineering is a field which is involving process of designing to give AI a desired mode. As Alok mentioned, like 15 lakhs a month. But friends, let me tell you, packages for a good prompt engine. And in US, on more than. This is the trajectory of importance on communicating to the. So I'm sure you would have seen. Try asking illogical ChatGPT or any bot, hoping that it answers everything. What it's actually. What AI is make sure that AI understands you well. This is a adopted called the CRISP. Very important. I'm sure of this. So CRISP stands for context. The right context. Let that AI message be a wholesome message. Then section that message. Chat what you're typing. Type what content. Talk about. Be very specific about relevant history and assign. Allocate a role to an AI. Give an example. Tell an AI and Smasher, help me solve a finance. Kind of output you get is going. You're basically a banker. Why? Because if you tell it a banker, it will be like a banker. If you tell advisor, it will be a simple example. Recently I was planning to an email as tax with the car. I want to make sure that my EMIs don't go up, but at the go 20 lakhs. What? Can you guess what solution? First, I allocated the role. Second, I did as a banker. When I gave role of message for a finance planner and advisor, gave me that the old car you get tax. Put that 8 lakh systemic withdrawal plan. Put 8 lakhs into fund every month, whatever amount. The remaining amount, get a loan. The same query, when I allocated role to the AI chatbot as a banker, said no, that's loan. So I rely upon financial advisor. The same AI chatbot, same context of the conversation, but different. To be very specific, if you are putting an oncology query, you have to type, think like an oncologist, psychologist, or a layman. You need to define a role. The third aspect of the CRISP framework is very important. I'm going to show you live scenarios why these things are important, because start using AI. Follow this thing, trust me, friends, amazed by symptoms, lab values, findings, very structured way. Give it a structure. What's the response you want? You want it as a 500 words article. You want it 35 points. You want it as a content to speak. You want it as a content spoken to. Very, very special. Output, uska format kya hai? Very important to be bit of structure. Chat goal. What's that purpose you want? That goal. Are you looking to diagnose something? Are you educate someone? Are you protocol? Fine. Very, very important. Friends, you will be thinking, oh, help. Right now, let's apply this CRISP framework. Why? Because this framework is developed by an entity called Polo AI. They've done some phenomenal work. If you use this structured CRISP framework, not only your accuracy, guideline adoption, whatever it picks scientific information, that is accurate. Gappebazi nahi karta. Doesn't give fake DOI number, fake responses. It's very specific. Yes. Documentation time also reduced because the area you put it is the right one. Now, let's move into the application of this framework with the real examples. Let me take you. So this is how a chat window would open. If you use ChatGPT, sure, all of us. This is how a typical chat window looks. Let me give an example. Kya karna? So of the CRISP framework, what we discussed, apply the CRISP very specific. An unclear request is something about diabetes. That list common symptoms, hypoglycemia, type 1, type 2. What do you want? Contextualize the whole thing. Very vague thing. What to monitor in 30-year-old patient, 5-year-old patient. type 2 diabetes, whatever maybe, with history of hypoglycemia or history of rebound hypoglycemia, or whatever you want to add, but be clear. Find the desired output as we see. Give me advice on it. Provide a step-by-step plan for adjusting a co-formulation. Very specific. This formulation. What do you want? Specific. Incorporate evidence-based testage. Rather be specific. What guideline? RSSDI guideline. What do you really want it from South Asia Pacific? This is very important. This is the core difference between a general from crisp format utilized. So let me give one more. I'll showcase you 5 different scenarios just to give an insight, because this will open your mind to start using. So the first thing is, tell me about an elderly cardiac patient with comorbidity. General. Same query, if you put it as a more specific finding, 5-year-old, including relevant comorbidities, current medical, person is on lisinopril, atorvastatin, and possible. Now this, putting the same thing, first line है, उसी का ये है. More detail. You're applying here context, 5-year-old person. You're asking, you're allocating a role to an AI. You're telling the AI that think for the hospitalization, mentioning the medical history, medications. You're giving it a structure because you want a summary. You're giving the purpose. The purpose is to provide a concise overview. So again, what causes chest? Very irrelevant question. Again, differential diagnosis for substernal, find where the chest, whether it's radiating or non-radiating, accompanied by dyspnea, aphoresis, whatever be the case. A negative high sensitivity for troponin. And for that, if you're more specific, whether it's a 0 to 3 hours or 3 to 6 hours or 6 to 10 hours, specific. Yeah, specific. If you again break down as crisp context, you can. Symptom-based query. What can I do? Very specific. Find the TI suspicion, whatever may be, right? Again, another one I'll give you for a fever in infant. Infant is age bracket you're defining it. You can be very specific. Give us all defining it properly, giving it a history of duration of history, 4 days, 5 days, or 7 days. All these specific. So just few examples to open your minds. Another one is of hypertension in mid age, right? The stage 2 hypertension, finding it the person or is a non-diabetic. Let it appear to an say find the question. Let me go towards the end of my session with 5 important do's. Doing medical prompt, do specify your role. Do include numerical values relevant to your question. The question. Do request the rationale. Give it a chain of thought. You can ask it to stage mind. Do specify guidelines of follow or think of. Most important, do. Without that, you'll get all stupid cutoff. You get BMI of 25. If you find that the our BMIs are not 20, cutoff we want our patient. Defining that's very critical. 5 don'ts. Very, very important. Yeah, nahi. Don't use. Don't skip negative. Very, very important. Editing. Editing. Don't think test समझ लेगा कि नहीं. Don't accept the first. Why? Because if you accept the first output and if that first output is wrong, AI will form its own chain of thoughts that what I have answered is correct. On answering all wrong questions for the consequent 7 interactions, ultimately 15 single. If we are talking to, don't forget key contraindications when. This is very interesting. This is best treatment for allergy CKD. Considering CKD stage 3, what if it gives a treatment irrelevant to us? Don't forget. Don't use undefined abbreviations like MSP. Multiple sclerosis for us, but for AI it could also mean Microsoft. So be very specific. Don't use. थोड़ा मेहनत पड़े, but it's so my last take home message is adopt the CRISP framework, specify the role, context and guidelines, thought templates with AI. Remember, AI augments, it replaces if you are not catered on how to talk to AI. And then a last slide, you can all take a simplified slide of the entire last 50 conversation. Yep, with this I would like to end the session with a quote: the illiterate of the 1st century not be those right, but those who cannot learn, unlearn, and said none other than by Alvin Toffler.
Thank you so much for helpful, interesting session. I have next speaker talking about in diabetes, thyroid, dermatology, thyroid. I have been consultant, past experience, AM Hospital, Maya Hospital, 5 years of active experience, diabetes, thyroid. He has treated more than patients, 300 patients, and 300 of his patients are walking towards reversal of diabetes. He has published 10 publications, national and research works in national and life member of Indian Association of Preventive Medicine.
Thank you so much, sir, for the kind introduction. And at the outset, I would like to thank Dr. Purvi Chawla, Dr. Manoj Chawla, Dr. Banche Sahu for giving me this opportunity to share my insights on how AI can be used, the tools AI can use. So already the context is already set. Some of us are already partial experts into how AI is being used, but to tackle the day-to-day scenario, we are really out of time, and nowadays we need everything quick. So yes, we need everything quick. Everybody knows about this scenario. We want it quick, right? We also want it very quick, right? And again, pretty much quick. The results what we need are to be quick, but whether these results are meaningful, but we really don't look up to it. So what I'm going to do is, my job is to share you with some of the AI tools which will probably help us to read the articles quickly, yes, but of course meaningfully. So we'll talk about the research assistants and search engines. Then there are some tools for summarization and simplification, and there are some tools for critical analysis and context. And finally, the right prompt. Of course, the right prompt is already been dealt with, but we'll see the right prompt scenarios in the diabetic context. So yes, so there are some tools which will help us read the search engine, like that a search engine we can use. There are some tools which will assist us to go deep into it, and there are some tools which will help us to write the articles also, something like systematic reviews as well. So we have Elicit, we have Consensus, we have Semantic Scholar, and we have SciSpace. Okay, so what I'm going to do is, there'll be some presentation, and I'll have the actual real videos of my screen recording that how AI is getting used. So semantic search, Elicit helps us semantic search. Semantic is basically play of words which gives us an output. So we have to make sure that we are using the right words, again, which also insinuates to the right prompt, and it automatically extracts the data. We really don't have to use, of course, we have to use the PubMed and Embase for that, but this helps us to go to, we really don't have to learn the mesh terms. We don't have to really learn the booleans all the time, but we can still do it. And it also gives us a transport sourcing, and it also gives us the workflows, how it goes. So how it goes, turn off the yeah, please turn off the presenter view. Thank you so much. Yeah, great. So Elicit is going to use us. So I've done these videos really fast. So just put in the hot topic, impact of empagliflozin and dapagliflozin on HbA1c levels and blood sugar levels, and if at all there are some side effects, adverse events. So it is going to give, see, as soon as I typed it, it's already started generating the title. It is going to give us a summary on top. There are some resources it has come out with, okay, and it is giving us the entire context, okay, all the studies you can see here at the bottom, right? So you can search the studies, you can put in what you want summaries, you want main findings, methodology, all these. At the same time, it also is going to give us that who's the author of the research of that particular article, and as well as how many citations that got. You can go to those citations also. So that semantic workflow view I was talking about, it is that. So it is going to give us the data which will help us, and ultimately it is also going to give us in a tabular format like this abstract summary. It is going to give, it is more effective than the dapagliflozin reducing HbA1c. So yes, rather than reading the entire article, you can just go to the summaries, abstract summaries, if you're really quick. Okay, so now we have another tool called Consensus. It is add an additional feature of Consensus Meter, and it gives you a fact-based answers. Okay, it also can talk about, like, how much is the reduction, how much HbA1c has gone down, and that also can be given. So there are three different search mode. There is got a quick search mode, it is got a pro search mode, as well as the deep search mode. So we'll see that in the consensus setting also. Yeah, so again, the similar question what I have done is impact of empagliflozin and dapagliflozin. What it is given is the specifications of the studies also, right? Whether it is an RCT, whether it is a non-RCT, whether it is human trial, large human trial, smaller human trial, okay? And it is also, in an addition, gives us and comparative data and safety here. As we can see here, it also and gives us the citations also. You can backtrack the citations where it has come from. Maybe, as one of the speaker already told us, that there is a chance that ChatGPT gives you fake made up studies. It is going to give you fake made up studies unless until you give a good prompt. So rather than that, you can actually back check all these responses, and also it gives us the study design, whether it is a large trial, small trial, whichever trial it is, how many citations it has got. So that way it is helpful. So it has got an additional feature of Consensus Meter, which tells you that all the authors on this context, whether they have a consensus on this particular topic or not. Yeah, so that is an extra added feature for the consensus. Yeah, Semantic Scholar, it's more of an old Semantic Scholar which we are using. It just gives us citation maps. It has got a very peculiar TLDR thing, too long didn't read. So one line summaries, that's it. So how does it give one line summaries? Sorry. How does it give one line summaries? Yeah, so you just put in EMPA versus DAFA, and I want to know that what is the kidney outcome. Of course, these prompts are not correct. I'm just giving you like in a very generic context. Yeah, so it is giving that TLDR, too long didn't read. Very clear. I just want one single thing, and I want it to compare with all other things. Yes, if you want to expand it, you can really expand it and read it a little bit more. But you can still stick to that one-liner thing. So what I've done is I've expanded it and I wanted the data with what exactly it is talking about. Yeah, and I just highlighted it and I know what exactly it is doing. So yes, Semantic Scholar has an additional AI interface with it, but it still works like the older typical semantic way. Yeah. So SciSpace is one good for literature review. It again gives us a semantic search, and for additionally in case of an paid version, upgraded version, it also gives you a PDF video podcast. Okay, it can give you a video podcast that you can actually chat. Whatever chat has been done with you and the tool will be given to you in the format video podcast model also. So it converts research paper into video or a podcast summary. So SciSpace, again the similar study, it is analyzing it, and then it is going to give you at the background with the live activity. You can actually look at how this particular tool is searching at the background. What is happening at the background, that also you'll be able to see. And how many spaces it search. It is searching SciSpace, it's searching Google Scholar, it is also searching PubMed, all these terms. And what an additional feature it is give you that some of us might struggle with it. It's also giving us a free PDF link that you copy that link and go to the paper as well. Okay, so that one also do. We know that there are quite a few unofficial things on internet that we get the free papers on, but still in a manner where we're talking about ethics and all, it's better to go ahead with that. Okay, so it gives you PMID number. It also talks about which journal, and yes, this is the mesh thing also. If you want to learn the mesh, that what exactly mesh terms it is used, you also can use with that, with this particular tool as well. Yeah. So this is the mesh term which it has used with the PubMed. So you also can learn the mesh with this particular thing. Yeah. So there are some tools for summarization and simplification. So what we've done till now is just searching, like a kind of like a search engine. But now I have finalized one final paper and want to talk this paper. I want to chat with this paper and I want to see that what exactly is it talking about. So first thing is explain paper. So it is going to go.
Unfortunately.
Yes. Yeah. So we have to highlight and explain interactive question and answer session, support for technical content, and it will adjust the complexity as well. So explain paper, just upload the paper and it will give you the highlight the text, and it will explain it to you that what exactly is happening, and it will also help us to understand the paper. ChatGPT, our own ChatGPT will help us. It is just that you have to go to GPTs and download this AI PDF version of it, so that then only you will be able to understand and chat with the overall thing. Yeah, Scholarcy is one good thing which I really like about is it gives you flashcards. Okay, it also gives you important outcomes, important points, wherein you will be able to only get the important points which you are interested in. Yeah, so it will highlight you those points that what exactly you are looking at with one paper. Yeah, and then finally for critical analysis and context, if you are doing a lengthy research, or you're doing citation work, you are doing writing papers, so you have core features, you have cite.ai. It will be helpful for you all. Currently we are using Zotero and Mendeley's for the citations, but it is connected with the Zotero and Mendeley also. So you can just do that, put in, and all these citations you can download as a BibTeX format later on for your Mendeley's and Zotero, and it will be saved in your Mendeley or Zotero platform as well. That's cite.ai. Research Rabbit is a fantastic tool wherein you just put in the study, the name of the study, and it will also give you a fantastic map that which researchers have done that, how these studies are connected. You can cross-ref it back to the original articles also, and you can actually click on the individual studies. You can see the maps, and there are some research and co-researchers also, so you can actually track them. You can also track them chronologically. That's the beauty of it again. So Research Rabbit is a fantastic tool for research again. So PaperDoc, again similar kind of a thing wherein you just upload the paper and it will give us the context of all the studies which are, and this is an additional feature. Does empagliflozin, dapagliflozin impact HbA1c levels? If you want to read the studies which are only talking about yes, you can highlight those. If you want to read about only no, you can highlight those as well. So that's a PaperDoc for you. And then Ryan is more for the people who want to do systematic reviews and meta-analysis using ChatGPT, using the Ryan model. Again, these are the paid versions. You just have to upload all the studies, and Ryan might be helpful for you all for screening, full screening and data extraction. Yeah, the right prompt is important. Yeah, vague prompt is tell me more about diabetes, and then there are effective prompts. What is the best treatment for diabetes? Again, there are, so vague prompts are not just the prompts for in general for all the tools. You have to learn, or you'll have to train that, as Modi sir already said, you have to train that model, that how you think, similarly the AI will think for you. So for each tool, the prompt is different. You have to get that hack in the original. So all these are there. Oh, sorry. So actually I had given the, because it's a Amchi Mumbai kind of a conference. So this is my final slide, which talks about how meaningfully and quickly. So quickly is quick response. So these were the vada pav emojis, and these are actually chili emojis, because you go with the vada pav and you have a mirchi along with you. So elicit in terms of quick response, yes, it codes 5. It has got a good meaningful extraction as well. Consensus, it has got, again, almost quick it is, but meaningful extraction you really doubt, because ultimately it is judging consensus meter on its own. But ultimately what we have to decide clinically, it's up to us, right? And then semantic explorer, it is really tedious. It's more like a manual thing only, but it is going to give you meaningful extraction later on. And all these tools are going to help us. Specifically Ryan, not good for the ones who really want to just stick to the clinical part of it, but will be helpful for the people who want to do systematic reviews and possibly meta-analysis. Meta-analysis tool is not really very well developed with Ryan, but the systematic review tool is pretty much very well developed. Research Rabbit is something which I highly recommend, because it just gives you that context overall, and will be helpful for you all to track the authors as well. So at the outset, thank you so much for giving me this opportunity. That's all from my side. Thanks.
Thank you so much, Dr. Amit. Wonderful session indeed.
Thank you so much.
So now we've been hearing about artificial intelligence, and what more would you want? Is a surprise element. We have a lawyer in the house. So we have our next speaker, Mr. Tarak Chawla. He's a law student pursuing BBA LLB with keen interest in data privacy and data security, as well as legality surrounding same. And he's going to talk to us about health data and patient privacy, the legal perspective. Also, not to mention, Tarak is the son of Dr. Manoj and Dr. Pool. Over to you, Tarak.
Hi, good evening. If anyone's wondering why I'm speaking, it's because my parents needed an unpaid faculty. Only kidding, I'm obviously the highest paid faculty over here. Okay, so my topic for today is health data and patient privacy, a legal perspective. Now, because this session was so delved into AI, this is going to be a little bit of a refresher course. I'm not going to go too into detail, and this isn't just AI specific. It's to do with all patient data that we're collecting. Right, so why does this matter? Now, your doctor-patient relationship is obviously built on confidentiality, and every patient that develops trust with you, it's because you promise to keep that data confidential. You're not misusing that data. You're not giving it out just like that. And also, the right to privacy has been deemed as a fundamental right. Now, I know this seems obvious, but this was only developed recently in, as you can see, 2017. And one of the most important developments is the Ayushman Bharat digital mission. Now, for those of you that don't know what this is, it's a new system that's come, like, you know how we save all our data with our DigiLocker and UPI, Unified Payments. Similarly, ABDM is trying to be a repository for all health data for patients. So it's like a national repository for the same. And because this is a growing aspect, I mean, some of you might be feeding it into your hospital information systems, your own softwares, which is why this topic is important. Now I'm just going to go over the key legal framework, so the acts and laws that actually govern this. So unlike the US, India doesn't have a specific law related to health data. It's governed by all of these acts. So initially it's the IT Act, which covers the part about security and liability, the fact that you're liable for all the sensitive personal information that you carry, as in if you leak this data or if it is misplaced or misused by you, how you are liable for the same. And so the IT rules that came out in 2011 is what places health data under the definition of sensitive data. The latest act, which is also the most relevant, is the DPDP Act, which talks about consent, ownership, and erasure of data. This word lays the groundwork for what you're supposed to do with the data, how exactly you're supposed to take care of it, and everything along those lines. There's also a draft for the same act for a set of rules, attached rules, which is to come out soon, but it's not there yet. The Clinical Establishments Act from 2010 talks about record retention. Again, this is to do with how long you're supposed to store the data and for what purposes you can use the data. And the ABDM guidelines. The ABDM is the digital mission I was just talking about. So now the idea of this talk came with a conversation with my parents, where I think my dad asked me, okay, so now that I collect patient data, I feed it into one glance, I'm collecting their data, I'm getting these tests done, I'm storing all this data in one place. Does this data now become my data, or is it still the patient's, or now that I'm feeding it to the software, is it their data? I know all of these things seem very obvious, but when you think about it, I think, as I said, this is just an informative, little bit of a refresher course, but your patient will always be the true owner of their data. As a doctor, you and the software, the doctors, hospitals, everyone will be the custodian of fiduciaries, as in you will only be handlers of the data. You won't actually own that data. You can obviously use it for the purpose it's being collected, which in this case is to diagnose your patients or treat them, of course. So your software that you feed it into, and I think this is where it's extremely important with all this talk about AI and all the AI tools, your software is a data processor only. So no software that you feed this data to will own any of the data you're giving it to. They have rights to process it, use it. Again, those rights are given by the doctor or the patient, which is why I'll come to the aspect of consent. I think Dr. Lok Modi mentioned it, and it's a very important point. I'll get to that. So again, just because you consent or give your data to these softwares or your doctors doesn't mean that there is any ownership transferred. Right, so collecting patient data. I know, again, all these things seem very obvious and might be taken for granted very often because in practice it seems very inapplicable to, constantly ask, okay, I'm collecting your data for this purpose, I'm going to keep it for this long, and are you okay with it? There's two kinds of consent, implied and expressed. So as a doctor, when a patient shares any history with you, any information, anything at all, and again, they give it to you willingly, it's implied consent. But when you specifically ask them that I am going to collect your data for this reason, I need it, I need this test report for this reason, that is express consent. So again, when you're collecting patient data, it obviously must be lawful, it must be necessary. So you need to explain to your patients why you're collecting that specific data, why are you taking this history, and it must be proportionate. So the information you carry shouldn't be that wide. It should be very specific to the purpose or the diagnosis. And again, explicit informed consent. These are the keywords here for sensitive data. You have to tell them that I am expressly asking you for consent to store this data with me so that I can help you with your diagnosis. I can help you suggest your treatment plan, etc. And privacy notice. So again, it is important to inform your patients about the confidentiality that you hold with respect to their documents. And again, your collection of data can only be respective to their medical needs. Now, what can data be used for? Treatment and continuity of care, insurance claims. I mean, this is a little bit far off aspect, but it's still important to keep in mind. Government schemes, as in also this ABDM. Because they want to collect such a repository and it is going to start implementation soon. It's already in practice, but since it's going to be a growing thing, it's just important to note. And also medical research. Now, prohibited is, of course, sale and commercial use without consent. So say probably a pharma company, any research company for that matter, comes to you and asks you, okay, we're ready to pay you this amount of money, but we need your patient data. Can you do that? Absolutely not. The only scenario you can do that in is when you take consent, you give them, and again, you can't sell it, but you can share that data for that specific purpose only after taking express consent from your patients. So again, this is just same thing for data retention and deletion rules. This is basically just giving you a little bit information on how long you can hold it. Of course, in practice, most people tend to hold your medical records for a longer time so that you can develop your patient history. And again, because a lot of diseases, a lot of different treatments will be correlated, so you can maintain this kind of data in practice. Now, sharing and disclosure. Again, when you share some data to other labs, say, okay, now, for example, most people in the room are diabetologists. If they're referring it to another doctor and say, okay, I will send your reports across, you need to ask your patients, can I send your records across? This person, this colleague of mine is in this field, say a cardiologist. Can I share this data to them? You cannot just send it. I know in practice that's what happens, and the patients don't have a problem with it, which is where it's implied consent. But to get rid of any legal liability on you, it has to be expressed. You need to ask them for permission. Without consent, only if there is any legal mandate. So there is a case law with respect to this. It's not that interesting or that relevant to most people in this room, but it's when you can break that aspect of consent and share it for the sake of public health or public good. In this case, it's an anonymous case, but say a hospital or a doctor specifically broke their disclosure to warn another patient with respect to an HIV case. In that case, the court ruled that you're permitted to, since it's in the aspect of public health and another person's health. So again, you need to ensure minimal disclosure. When is consent required? Collection for any health report, diagnosis, disclosure to any insurers or third parties. And this is the most interesting and important and most relevant part with respect to this session. Use this for secondary purposes, research, training, and AI tools. Now, what I wanted to mention is we have spoken about using different AI tools for diagnosis. Can you do that? No. You're supposed to ask your patients, I have this report of yours. Can I use it? Can I upload it on any AI portal? I know, in practice, you can just upload any report. It can be anonymous, of course, but the best thing to do is ask your patient, okay, I have your ECG report. Is it okay if just, for the sake of ruling out all possibilities, can I upload it on ChatGPT or any other AI tool for that matter? Even for training AI tools, I think that's what a lot of you over here are working on right now. Every patient data that is collected, you have to you require express consent for training these AI tools. So whoever's data you're sharing, it needs to be informed to them, or rather requested for consent to use and train these AI tools. Of course, it's extremely important because only then I think that's what this session was for, the different kinds of AI and what can make AI way more accurate in the future. And again, cross-border transfer of digital health data. These are some landmark cases. With respect to these are in general medical legal cases. I spoke about 2 of these already. The third one was basically no forced medical tests without consent. And in the sense, just because you might have some report of theirs, any data, and you think a procedure is necessary, you can't do that without explicit consent of the patient. So a simple compliance checklist: train everyone's staff on privacy obligations. Mention why, mention to your staff why you can't disclose reports, you can't disclose cases of any patients. Privacy notices. Now, again, this is not something we see very often, but it's a good measure to keep in case to avoid any legal liability. And secure your IT systems, of course. That's I think pretty obvious. And again, obtain written and electronic consent before using or disclosing. So the most important takeaway, I would say, is consent, right? Everything you do with your patient's data is tied to consent. So take specific permission. Specify exactly what you're going to do with that data, whether it's the smallest thing, whether I can send it across to a different doctor, use it for whatever purpose. Because non-compliance with this would put, again, ethical liability as per the MCI rules. And I think the MCI is now referred to as the NMC, which is the National Medical Commission. And I don't think anyone would want that liability upon them. So it's just better to handle patients' data with care, especially in the growing age of AI, where we feel like, okay, we can just use AI for everything. So I think this is the most secure way. And yeah, that's...
Thank you so much. So without further ado, may I request the entire panel on stage for discussion. Lok, Amit, Advocate Tarak. Just let me up as their artificial needs human intelligence. Prompt correction is ultra critical. So the AI training that we give is inside the AI accuracy. Expert validation, the human brain always prevails. Patient consent is just prior to using AI tools. And of course, we should know what role also we are giving to play. Of course, patient data privacy becomes very critical when looking at that. May I?
Countries like the US have HIPAA in place.
It is time, but the problem is, if you speak to the NMC, Dr. Badamat attended his talk in GNLU last week when I was there with my wife. I discussed that with him. The problem is there are many people in the government sector who have not yet understood AI. They're yet struggling to come to terms with AI. They yet feel AI is, many people yet feel it's more like a glamour, it's something like a playing thing. They don't have. And the last that I read was in the month of May, 20 countries have got together in the Asian continent. They've selected Delhi as the hub where they would be discussing. Discussions are on. ICMR is the only organization which had come out with some guidelines few years back, but there has been no official guideline, no legality yet. No, but there are laws which have come out in US. Maybe. I think the best thing I can answer is the first thing. It's premature to say that, but I think the first thing that is happening in this ecosystem is something called as Juris Medica, which is originally Hertz baby, and we're working on it. We're developing an AI system which has officially been approved by the Prime Minister's office. It is in a work in progress. It is already incubated by the Gujarat Law University. We have come to the near completion of that project, and we're just discussing with Manoj about involving the last speaker on it, because it's something we're developing as a medical legal tool which will be highly compliant, which would aid judges and lawyers in their decisions, as well as doctors on getting their legalities in place. It's something when we talk about it, you'll understand it's a huge thing we're developing. It will be updated with the latest Indian Penal Code and the latest judgments and the medical side together, and we are training. We have already trained the model. We are going for validation. If that comes in place, a lot of legalities of AI would fall into place automatically. It's a work in progress, so we can't speak much about it. But what you said, I think we are the first people in the country who have started developing it towards that end.
I asked for a very important question regarding the restrictive study and the reward-based. Very, very often we bypass the by terminology of study. But one of the very key from lastly by Mr. Chawla, the owner of the data, patient. Very recently had they were about to take 5 into MSLD out. Categorically our chairperson and as patient taking
data, have to take the patient. That is very important. Even if we are doing retrospective and if we have connection with the often we
There's a midway to this. Relevant to blanket currently sound is fact. But
Don't
No.
think so. That's what happens. Most stringent ethics. What is search? Recruit sample. A general thing. Sample has to be popular. Cannot be generalized to everyone. The results ultimately are being out to the public. Information and bargaining. This is select.
there's a here.
Informed consent is fine. Not a secret. That is the first thing we. And second thing, as you are taking, I have any contact with my patient review. I have to not at all possible justify that I can analyze and I can. That's
Speaking is an same energy. But be कर रहे हो. After this.
So as per DPD, if otherwise, inspection, if right, as we saw. Second point, if the data server inside the country, that country, the data the simple answer to this, build a server against Act, have the server in India, everywhere we. Fourth thing, and in fifth thing, in clearly mentioned that data processing which have Indian, I mean, in follow-ons of.
There's something which
data. Understood. That point, yes,
barrier.
I use it in that way. Targeted.
That when we are sharing data for the research purpose, clearly we have to follow two guidelines. One is the clinical trial rule 19 and another is DHR bioethics guideline. They are clearly telling us we permission the government, central government, and then we need, and then the final part. Otherwise, of course, we need having some plan research agency globally, then document it. Red alert. Exactly what you as simple. Like in the and
I just think about life. Came to know. Filed a case against. Is the because recording is not. What's important is whatever you're collecting is not a crime. Public. How you make it public is important. Collecting is better you take a you have no rights to make it. The patient allows you to make it. It's a very important. It applies to research. Very relevant. Don't take the IVF for. First, started collecting for patients. Why this is relevant? I'm your patient. Write good things about you. You're not in trouble. I give you a very fantastic video and review. You put it on Facebook, then you are in trouble. They're not advertising. Talk about. Have consented to it. What's important is whatever you do. A lot of photographs and videos. For research purpose, you have ethics, a boundary. It is aware that is nowhere the idea based what research identity.
Interest. Quick, a paucity of time. We'll limit it to questions. Ma'am, your question.
Questions because two people are waiting for a long.
So I'm suitably scared. And I have a very sweet history. Type 1. 27th country. Now I'm scared. What doing? How is it? Trouble can. What should we do? We stop. What should
consult? Consult our
yes.
Yeah, Sarupam.
Okay. Now that there is no legal guideline in India as of today. Discuss that whenever I talk about. But it's important to know that when you sign up for an EHS, you have taken a non-disclosure from them. Because if there is a breach tomorrow, to answer it. Let me tell you, even if you take a non-disclosure, they are selling it to the farmer. That is a ground reality. To be on the safe side before you sign up and pay money. That you collect a knowledge and keep yourselves. And like Dr. Tarak said very rightly, there are two concerns and implied. So when I walk into your clinic for a consultation, there is no need to take a written. When you want to intervene on something, what is an implied concern? Asking questions and trying to understand what I'm going through. You're not interfering with my metabolism. The moment you start doing a procedure or something, it has to be personalized. I'll just finish in 1 second. So just as you talk of precision medicine, why RG Stone landed up in trouble is because a lot of us have that pre-printed consent forms. It is not legally valid. It has to be individualized for that patient. It has to be in the language of the patient. Patients are there who say कि we do not understand English. The doctors have lost. It has to be in the language of the patient. You're not comfortable. About that case, that surgery, that intervention which is to that patient. Unless it is specific, you would land up in trouble. That is a level that the law protects the. Very nice to get. I will.
Those are the
I always ask this question. The law, still people don't. Video recording considered have a video is meant for your protection. I know you cannot record in the OT. Better not to use a camera. Other areas recording should be done if you. The Medical Legal Council of AIM, who are in Bombay, no. Recently, there was a case 2 weeks back where a doctor has been taken action on for misbehaving with a patient. The only mistake he made was he inserted the thermometer in the axle of the patient. The room just went out to get them. And this is a live case which we are helping the doctor. The question being asked is very simple: why the nurse? Your wife in the room is not a. It has to be a nurse or a female receptionist. Your wife in the room does not give you any legal information.
Last
be very clear about it. This is the law. So there are a lot of simple rules which protect a patient. Getting aware makes a lot of difference.
Press consent or it's verbal.
Actually, right? Right consent via action. Or ask you right consent. Less consent. Right means via action. Can be work. Yes. Clarification. Then doesn't necessarily give. That's
pre-test counseling has to before signing the patient, undergo PPT. Then only you ask him for, okay, are you okay with it? Qualified personnel taking that counsel cannot be your somebody who's sitting there. It's a different context altogether.
To illustrate your question, the live example happened there in our gynecologist was her personal entered said very casually कपड़े उतारो लेट जाओ बस मेरा बहुत रश so he said very good news का डब्बा पहले मेरे घर पे पहुंचा fine so he was pregnant he happy and पहले मेरे घर पे childhood birth happened met her husband क्या हो गया डब्बा क्यों नहीं आया what डब्बा sent the medicine shocked was shocked and दोनों का झगड़ा हो गया but the shock of his life after 3 months the wife how can she file a case on ended up in the truth was And this is a true case. I'm very serious. Something important. Was out of filed for divorce. The court for taking the law. This is a real.
Interesting stories. I think we will take this offline. I'm sure we'll need one full more session on this. Thank you so much, panel. So may I request Dr. Sachin to without further ado, next session is diabetes 2, type 1 diabetes. And for the same, may I request the chairpersons, Dr. Yu and Dr. Nina, come on stage.
Good evening, everyone. May I request all the esteemed, please, can you please come forward, please? Please come forward, occupy the seat, please. Speakers have requested that they is attractive. So, requesting you again, those who are sitting in the back, please, you can come forward. There is enough space here. Please, ma'am. Ladies and gentlemen, please. There is enough space here. Occupy the front seat. So after a very informative session, diving into realities. We're moving forward to a very interesting session, very good, dealing with different types of type 1. I invite Dr. Manisha Gupta, consultant, Kanpur, faculty in course, of power type 1 community, including the vote you, ma'am.
So much, chairpersons, for this warm introduction. Since my topic will be very interactive, so I really want the audience to take participation in this, and I will be going case-wise. So just for the clarity of the subject, because every child is not type 1 or every diagnosis is not type 1. So this is all about. I will be starting the case studies and how to approach discussion and further. So here comes the first case. 20-year-old male, polyuria, blood sugar 440, HbA1c 10, ketones 2.2. DKA on insulin, obviously DKA, because the ketones itself says like, and 20-year-old male, which is very unusual diagnosis. BMI is 27, not usually. Type 2 in family history, metformin was initiated, insulin was stopped. DK after 1 year later. So what did we miss here? Yeah, ketones was positive, 2.2. Yes, GAD antibodies, you were right. Antibodies were not done. So type 1 can be present at any stage. So here is a 22-year-old with a family history of diabetes, which is very unusual in type 1 history. Come second case. 17 years. Ma'am, 20-year-old child, type 2, family history of diabetes, BMI 27. Yes. Insulin was initiated, but subsequently it was stopped. Would have gone somewhere, got it diagnosed, हम तुम्हारा दवाई बंद कर देंगे, हम आयुर्वेदिक को ये सब, a lot of things. Yeah. These are just the cases we came across. 17-year-old female, polyuria, blood sugar 280, HbA1c 8%, ketone 0.7, BMI 16, no acanthosis. So, diagnosed was, type 1 was diagnosed. She started with insulin and she had recurrent hypoglycemia because insulin was initiated. Probably the insulin dose titration was not done perfectly fine. So she was undergoing recurrent hypoglycemia. GAD was negative. This could be MODY. Yeah, no acanthosis. Yeah, it could be, yes. No family history was, yeah, MODY usually have the very strong family history, but there could be different variants in the MODY itself. 8-year-old boy, polyuria, HbA1c 14, ketones 4, clear-cut diagnosis of type 1. Severe DKA, cerebral edema, started with insulin, BMI 21, type 2 in the family. Insulin was initiated and he had this hypoglycemia after 1 year. And hypoglycemia one event does not justify, but he had this recurrent hypoglycemia. So why hypoglycemia? Probably dose not correctly titrated, carb counting wasn't explained or something like that. So or it is something else. This child, ETG needs to be done just to rule out whether he's suffering from another autoimmune disorder. So we need to do ETG ideally and thyroid disorder just to rule out whether any other autoimmune has been associated. I started on gluten-free diet, covered. 28-year-old male, polyuria, weight loss 6 kgs, with polydipsia, HbA1c 12, ketone 5. DK management, 28-year-old, BMI 29, type 2 family history, and DK management was initiated because of ketones, that was 5. Ideally, that should have been done. Discharge on insulin with metformin and glimepiride. Considering he might be into HHS, he's having this. But off insulin 2 months later, admitted with DK again after 3 months. Is it type 1, type 2, LADA, or what is missing is C-peptide was low and another antibodies were positive, like anti-insulin antibodies was positive. So there is like 5 or 6 antibodies which are usually done, ZNT8, anti-ILSL antibodies, and if GAD is always not positive, even 2-3 patients of mine where anti-insulin antibodies are positive, with C-peptide low. So one antibody, usually GAD is a very strong indicator for diagnosis of type 1, but it is not applicable in all the cases. So if it all is after in insulin initiation, C-peptide is low, still you're not getting the diagnosis, get the another antibodies. 19-year-old girl, vaginal infection, blood sugar 200, HbA1c 9%, ketones negative. Lean phenotype, BMI 21, diabetes in family. And she was started with insulin. Hypoglycemia after 1 month. And she was getting hyperglycemia with metformin and sitagliptin. GAD antibodies was negative for type 1. So we are still discussing whether what is this type 1 or type 2, but she was eventually landed as MODY and with genetic analysis. 25-year-old female, routine investigation, fasting was 140, OGTT 126, HbA1c 6.8, lean phenotype, so there might be some glucokinase effect, and lifestyle modification is the MODY 2. 18-year-old female, recurrent skin inspection, PCOS. PCOS itself says there is somewhat insulin resistance is there with HbA1c 7.8. BMI is 37, family history of diabetes is positive. PCOS, insulin resistance, periods irregularity, acne, hirsutism, and lot of things. Ideal diagnosis with early type 2, I think. The ideal choice is a metformin, but recently, as per the guidelines, SGLT2 inhibitors has been recommended these days as first line of treatment, which has been recently, though RSSDI had suggested 2 years back, now they have approved, even the UK guidelines have come up with that. Yeah, even GLP-1 analogs are also the drug of choice in this case. 19-year-old male, fever 5 months, blood sugar 500, ketones are absent, no DKA, lean phenotype, severe acanthosis and insulin resistance. So this is very unusual, very unusual finding, because lean phenotype with severe acanthosis are very tough to find. And this was a patient. So it's not type 1 or type 2 or MODY. So this is known as lipodystrophy. And because his immunity was low, not properly, so recurrent fever. Sugars were high, and none of, like with lean patients, what do you usually do? But there was so much insulin resistance, they require very high dose, and you keep wondering why so much of insulin resistance, where are we going wrong? So this is the patient with lipodystrophy, very high SGP and triglycerides. 20-year-old newborn, blood sugar 300, DKA, failure to thrive, discharge on insulin, because 20-year-old, what else you can do with? Recurrent hypoglycemia. So the defect would be here, neonatal diabetes. Yes. So genetic test was done, potassium ATPase and defect, and neonatal diabetes, and the best drug for this is sulfonylureas. 17-year-old female, type 1, 17-year, diagnosed at 15 years of age. Insulin was 1 unit per kg per day. Visual complaints, retinopathy, optic disc atrophy. So she is fitting into Wolfram syndrome, that is RIDMOAD. Diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. Though rare to find, but so far I have seen like one patient in 14 years of practice. Oh, interesting. Wolframus. Yeah, that's, it's not very, oh, that's great. Interesting. Wolfram syndrome. Anybody has having these complaints, think about something else. So just cases over. So anything, I'll just summarizes. Before 6 months, it could be neonatal diabetes. After 6 months, decade presentation, insulin requirement IS, type 1, no insulin requirement, no obesity, go for another antibody. So get a C-peptide, that's a basic one. Recently, while I was coming here, I came across a girl, 23-year-old, and she was started with some drugs because family history of diabetes was positive. With this girl, she wasn't gaining weight. Her complaint was, I'm not gaining weight. Nobody was, C-peptide was not done. So simply got a C-peptide and it was 0.6 ng per dl. Then I told her simply get a ultrasound. And on her ultrasound, she was diagnosed with chronic calcification of pancreatitis. That was the concern, and simple ultrasound will make a lot of difference while making a diagnosis. So when to evaluate? Before 1 year, neonatal. Low insulin need, could be MODI. Antibodies negative, MODI. Strong family history of diabetes, MODI. No obesity, acanthosis, MODI or LADA, and get antibodies done. Early sulfonylurea failures could be LADA. Ketosis prone is LADA, and fat distribution which is inappropriate, it could be lipodystrophy. This is simply a classification of diabetes, and type 1 can occur at any stage. This was a patient I was talking about. Whatever I did, strong family history of diabetes, he has a like acanthosis nigricans, skin tags. He wasn't doing so good. And currently also, this guy is on 130 units of insulin every day. It's like that, so much of resistance. And with this, not all were negative. Insulin antibodies were positive. So this guy is 40 years old. So type 1 can occur at any stage. Be vigilant when you are making a diagnosis. Especially monogenic diabetes, so though we do not do so much of genetic analysis, but if you have a strong family history of diabetes, there is no signs of insulin resistance, think of genetic analysis. The child might simply need a lifestyle modification that will do the work. The key players are autoimmunity and beta cell reserve. So C-peptide and antibodies are the main players while making a diagnosis. And beta cell function, just to say, fasting, if you are doing a fasting, is 0.08 mmol. If it's stimulated, if patient has eaten something, or so beta cell will be stimulated if patient has especially consumed carbohydrate, it is type 1. If it's a fasting, it says 0.25, stimulated by 0.6, likely type 1, because more or less it's stimulated. It's more than 0.4 or more than nmol per liter of beta cell, that is C-peptide, that could be type 2 or MODI. There are various clinical features used to differentiate between type 1 and type 2, and this was a systematic view of the literature. Scenario is changing. Every child is not type 1, so I hope everybody would be convinced now why and what we can do just to see, because early considered as any children entering our OPD with ketones positive is not. So why not start with, anyway, ma'am has correctly said, initially start with the insulin. No, but no child should be deprived of if blood sugars are high. And then later you can investigate what it could be, what best you can do at your clinic. So diabetes is just a comprised chart. Take a picture of this. And we're recently talking about type 5 diabetes, that is malnutrition modulated diabetes. And usually I have seen one girl, she was like, insulin were on and on and on, and she was belonged to a poor social economic status. The onset is, this girl was around some 8-year-old. Now she has grown to 13. Rural origin, BMI usually 11 to 16. You simply take care of their diet, provide proper nutrition. These child recover, and we are recently talking about a lot of publications in this. So this is all about malnutrition modulated type diabetes, and this I was talking about pancreatic calculi, which is Aram, so you can see on an X-ray, plain abdominal X-ray can be done. You simply ask the history of steatoria, and then here's the result. You ask for the X-ray and see the stones in the abdomen. And monogenic diabetes syndrome, usually 5 pointers, negative autoantibodies, no signs of insulin resistance, no obesity, minimal or no defect in insulin action, and impaired insulin secretion. It could be any type. It could be HNF1, glucokinase mutation, or HNF1 beta 1 alpha. There are lots. So ideally get a genetic analysis. These are the few criteria for diagnostic MODY in case you come across any patients having very strong family history of diabetes. So dilemmas in diabetes care: low level of awareness, patient report having poor blood glucose control, patients struggle to remain fully compliant with their insulin regime, significant psychosocial impact is seen, insulin medicine doses are being missed, not taken as prescribed, patients and physicians are concerned about the hypoglycemia risk. So these are the dilemmas in diabetes care when we are dealing actually with type 1. Like I was talking about this girl, and when I said you have this pancreatitis, I started with insulin. C-peptide was low, and she was like, matlab zindagi khatam, life end. So I had to really, counsel her by start with AM, PM insulin, 30-70. Say you begin with this. At least we'll see, and then come after 1 week. So even entire family is about to come next week, just to counsel only about insulin, because she wasn't willing to start with insulin. So these are the treatment strategy you're coming across with patient with MODY. Start with sulfonylurea. Neonatal diabetes, best is glibenclamide. Mitochondrial diabetes is sulfonylurea. Type 2, oral tablets or drugs can be, like if the child is obese, can be started with SGLT or GLP-1 analogs. Type 1, only treatment is insulin. Basal bolus is the ideal regime. Fulminant diabetes is insulin, LADA, insulin, and depends on the choice, how the BMI and how much is the BMI of that patient is. Malnutrition, provide proper nutrition, insulin and oral tablets can be given. FCPD initially can be managed with drugs if there's little C-peptide is left, reserve is left, otherwise eventually they would need insulin. So these are my final tips and takeaway. Firm diagnosis with, we need to do few investigations, but that will strengthen your diagnosis. And all children, adolescents are not type 1. Initiate insulin at the starting if you're dealing with any young child. Proper blood sugar monitoring, carbation correction factor, these are the few pillars while dealing with type 1. So with this, I invite all of you present here who has a passion to treat type 1 to our national tie-up conference, which will be held in Kanpur on 5th, 6th and 7th. Thank you so much for patient hearing.
Today it's not the inspiring part of the talk about something which is interesting. However, since we are talking about Manisha, that was a covered topic, and I think that's a thought you have sowed head, that not every young diabetes age can also be type 1. So the whole spectrum. Now I'm going to talk about non-insulin drug users. Now this is again out of the box. I think the topics have been selected very well because beyond what we are typical. So very simple. Does insulin always meet all? And there are challenges. Plus we want to target insulin resistance, obesity. Today we have to talk about cardiovascular risk reduction, renal risk reduction in type 2, then no, exist maybe even more. So if you look at the pathophysiological rationale, why are we talking on insulin? Because it's not just insulin deficit. In fact, a lot of insulin resistance as well. cases, right? Insulin resistance, in fact, PCOS, very common. So double diabetes, very much. So glucagon dysregulation does exist with type 1 as well. Incretin impairment does, and renal glucose reabsorption, the way we are talking about in type 2 diabetes, GLT2, that also is a pathway in type 1. So when we are talking about these drugs, one thing which I have to emphasize is these are adjuncts. These are substitute insulin. Always adjunct, which complements, does not substitute. That thought in mind, because I don't want anyone to a great part, but as the adjunct. So first and foremost, the oldest and the most wonderful metformin. Very simple for this audience. Anyone understand this? Because I think insulin sensitive, like hepatic glucose out night time when you get the dawn phenomenon, fastings are high. Again, the HbA1c benefit per se is modest, but all the studies are Western because we have more good Indian context. But it's very useful in PCOD, insulin resistance, coexisting, especially if you see after adolescents with type 1 diabetes. By the time they're 18, 19 plus and overweight, even without PCOD, like a double diabetes presentation, and they do. So the limitations could be GI side effects and maybe limited effects. So I'd have used, I have at least 100 young people metformin along with it, and usually this is the age group. It has helped, and later on, once they have stabilized, especially this transition age from 17 to 22, 23, when they are less active, overweight, that is a time they did it. For some with PCOD who continuing to use. Best we have. So it does work. I think it's worth considering. Yes, GI, but in too tolerant. So think about it. SGLT2. Well, now this is off-label, not FDA approved. But if you think about it, we have them available. They work via the renal reabsorption. It's a great way to bring down blood sugar. So adults who are overweight and uncontrolled. So it does work. Again, I have used off-label use, but one has to be very, very careful. UTI, GTI, as in always, but in addition, euglycemic decay. That is something because osmosis, the diuresis that is happening, electrolytes, again, because of all this, and if they go into dehydration, all those aspects have to be trained. But with good training, with good education, a person with type 1 diabetes is empowered being with education of looking forward. It works, especially if you have people who are being a very, because see, it's a cycle. You're needing more than your body weight of insulin. Suppose a person is 60 kg, needing 80, 90 units of insulin. You're adding maybe metformin and SGLT2. The requirement is coming down. Weight is coming down. Insulin sensitivity increases the moment the insulin requirement. Again, that leads to even better utilization. Person exercises more. So it's a very positive cycle. Quite a lot of girls and boys that we have very good results. And of course, it needs very good education and warning. And again, it's Voglibos. Now, I've just chosen drugs which we use in our day-to-day practice rather than those molecules available all over the world and not available here. So Voglibos, normally it's not very well recommended or accepted internationally. Diet, but specifically to low resources. For example, I have children who are laborers, kids who have literally nothing but chutney roti to eat, right? No matter how much we teach them about proteins, even a simple matki is not affordable at times. So end up eating with only bhakri, chutney, bhakri, thetsa, all they eat. If that is a diet with that kind of carb content, even a carbos, because postprandial peaks and the requirement becomes very high. Because to fill up their tummy, they're eating like 4-5 chapati khali. That's all they have, because they don't have the protein for satiety, they don't have fiber to make their food process slowly. All those things don't exist, especially in those situations and also in others. So like type 2s use it like a party pill or a eating pill. So something like that for type 1s also. Why not give them? No, nothing wrong as such, pathway, not harmful in any way. Of course, we know it causes bloating and have diarrhea. Used it, well, those people who don't have choice but to have carbohydrate. Think about it, it will help. And we have seen that it has brought down significant result, reducing the insulin need. And it's not as if we want to reduce insulin, save insulin. It is because the more insulin they're using, it's also weight gain, it is also more insulin resistance, it's also all the other aspects. So, helps. Now, this is the, can't call it new, something we have down and very, very promising. And this is expensive. One day when all these go off patent and become available, then probably this will become a very important aspect of type 1 care. So, that because it suppresses the glucagon secretion, there is a reduction in the postprandial glycemia, slowing the gastric emptying, blunts the glucose spike. It has satiety, reduces appetite, weight loss, improves the insulin sensitivity, lowers the insulin requirements significantly, and variability time in. Because we all know the GI side effects, which are always there with GI. Third, hypoglycemia risk would be there because there's a reduction in requirement, so insulin has to be reduced, which is understood. Are living with type 1 diabetes, you're anyway monitoring and anyway you're adjusting your dose as per your blood sugar. Now the interesting part is that now we have the dual agonist. So is there a difference? GLP-1 versus GLP-1 and GI. So with tirzepatide on the block, so this acts with the dual mechanism. And here, because there's greater weight loss, again, it also works other than the sensitivity to weight loss is also the adipose metabolism effect. That is all. So in your overweight adult type 1, the criteria would be adult, be overweight, of course, because the main thing is working at adiposity level. Then a better CGM control, there are a lot of pilot which have shown very good outcomes. In fact, a lot of people are using off-label, they are microdosing, they are tweaking it across the world. Type 1s are known for their own creativity and innovation and taking their treatment into their own hands, justified so, because you can't always wait for some things, but it is. So of course the limitations are, because one more advantage is the CV and renal benefit. For patient with type and has CV or renal problems. Very high requirement and could be given GLP-1 or a dual agonist, shown better results, more weight loss. Of course, there would be a risk of hypoglycemia, which, as I said, needs monitoring in any case and needs studies. Everything is off-label, a lot of potential. I see this happening as a, not an adjunct, but probably a regular treatment once the studies are right. Comparing this, we don't have, so I'm not going to talk about it. Let's say glucose, but we don't. Yeah. So that was the drugs we have. The other agents we have is pioglitazone, weight gain, edema, so not really recommended. Hardly any. There's some insulin reserve. And so where would you like to use drugs? In a clinical application, always remember it's adjunct, never insulin. So metformin, if you have insulin resistance, PCOD, overweight, and think we're talking about adult patients, adolescents in this. SGLT2, adults with obesity, CV renal risk, and very good. That is something we have to keep. GLP-1 RAs, especially the dual, choose with people who have obesity and need very high dose insulin, who have CV concerns. Benefit for the dual. Pramlintide we do not have, but it's for postprandial control. Voglipose, people need higher doses of insulin to control that somewhere. This is how we can look at it. Future directions would be a combination of GLP-1 and SGLT2 for obese one, because more and more we used to have those lean type 1s, you know, that BMI, that has changed totally. Even the rural spectrum, where I see now the older ones especially quite bigger now. Of course, immunotherapy and adjuncts would be another thing. Phenotype driven therapy, because as we saw in Manisha's presentation also, different spectrum of phenotype. Personal medicine, best, as we are already hopeful, latest non-immunosuppressive requirement of that has been so wonderful. If that happens, islet cells without immune suppression, one case which has been successful, that happening. So to conclude, think of adjunct drugs, even if they are for the betterment in the selected. Let it be a shared decision. Has to be out of it. Called Dana, there's a company, and they have done the first islet cell transplant without requiring immunity. Till then date, we were not very excited about cure, because whatever transplant you did, whether it was pancreatic or islet cell, it needed immunosuppression. But they have now created hypoimmune islet cells, and they have managed, the person who received it is still off insulin, and I think it's been 2 months already. 12 weeks. Patient has already. So we are very hopeful that this could lead to cural.
We'll have this presentation can round out for that. Always one second.
Almost let me thank Dr. in DRS for inviting me. It's a pleasure to present here. Talking about type 1, this presentation was in a dilemma whether type 1 or type 2, but mine is confirmed type 1. So, but still there are challenges, and to overcome challenges we'll try to see. Type 1, as we all know, it's the disease where there is absolute deficiency, and it accounts for around 5 to 10% of the diabetes worldwide. I'll say little uncommon, but not so uncommon, and it's picking up, and globally also it is picking up, and in India I think it is around 3 lakh type 1, 9 lakhs. Not that uncommon. And from the first presentation, we learned that in the young age group, type 1 is accounting for around 40% of the cases. But early type 2 also accounts for around 40%. There are different types of diabetes which can be found in the young adults, but I'll be concentrating only on the type 1 patients. And you can see the onset is very fast and aggressive in the children's, but in adults it can be latent. Initially we think it to be type 2 diabetes or something. Initially we treat with oral medications, and when they fail and we do the antibodies and get positive, then we call it DADA. And that's again a kind of type 1 diabetes. In type 1, there are different stages. Why I'm putting the stages? Because you can screen for type 1 patients if they have family history. And the stage 1, stage 2, and stage 3. Stage 3 is where it's a confirmed diagnosis. They are symptomatic and antibodies will be positive, at least 2 antibodies if it is positive. That is a stage 3, which we get. But in the earlier stages also, there will be immunity, autoimmunity, which will be positive. And various genetic, mutations will be seen. Those will be positive in the earlier stages also. And in stage 2, they will be pre-symptomatic, or dysglycemia will start to happen along with the autoantibodies, but they are not overtly going to the diagnosis of diabetes till they are in this stage 2. But in stage 3, they are frank symptomatic with autoimmunity positive. So with that, we can know that if there is a family history of type 1 diabetes, maybe we can screen the other siblings for the autoantibodies also, and then we can get them prepared for treatment later on. At diagnosis, typically what we see is the HbA1c and the fasting and PP for diagnosis, but in type 1, again, since it is very acute onset, you may not get HbA1c above 6.5 always. If you get frank hyperglycemic symptoms, typical of type 1, more than 250 sugars, or ketones positive, and you check the antibodies, if it is positive, then definitely we'll rely it to be type 1 diabetes, in spite HbA1c being little less. Not mandatory that HbA1c has to be above 6.5 to label them as type 1. So targets will be a little different for different people, but ideally we try to keep the preprandial sugars around 180 to 130, and postprandial we target around less than 180. But HbA1c targets again differ depending on the different age group. We'll try to see what obstacles we can have or difficulties we can have in managing the type 1 patients. So HbA1c, I'll not say in all the patients it is not possible to keep the A1c less than 6.5 or less than 7. We may get in the young age group even 8% A1c is still a good A1c to be expected to be a good control. So in management, we have to rely on first the fundamentals of the nutrition, or simple carb counting. We have to, counsel the patient to have an idea how much insulin will be required for how much carb. At least that simple things we have to teach the patient, and importance of physical activity. Apart from that, sometimes I'll say most of the patients will require some psychological counseling too. And we know that type 1 management will be insulin, purely insulin, and that too, current guidelines say that it should be multiple dose injections or basal bolus therapy, not the premix insulins. And monitoring has to be there, structured monitoring and frequent monitoring of sugar, and to titrate the doses to keep the sugars well controlled. We have to prepare the patients for hyperglycemia management as well as the hypoglycemia management. Definitely, both the things will be expected when you treat a type 1 patient with insulin. DSME is one of the major points where they have to be taught about diabetes self-management. If we give a prescription and think that they will be able to just follow the prescription and keep the sugars controlled, it's not going to happen. We have to give them a structured way how to do their daily things while managing their sugars. Let me come to the challenges, what we can expect. In children's mostly, these are the challenging things. Lifestyle issues, variable routines may be there, exams, holidays, sports, etc. They avoid sugar testing frequent monitoring of sugar is little difficult, and frequent pricks the children may not allow. In adults, it is little more possible to, tell them to do and expect them to do frequent monitoring, but for children it's difficult. Daily injecting and monitoring in school also it's difficult. Non-physiological insulin preparations are used sometimes, like premix insulins, as I mentioned, it may not be very suitable for a type 1 diabetes management. And in fact, if we are using basal bolus therapy also, for snacking also you have to give bolus insulins. Majority of the times, 3 boluses, 3 major meals, and basal insulin is given 4 times. But sugars are not well controlled. Evening time they snack, and pre-dinner sugar is always 300, 350 like that. They are not going to ketoacidosis because they are taking the 4 doses regularly, so not going to ketoacidosis, but sugars are not well controlled. So snacking also requires bolus dose, and cost of therapy sometimes gets difficult for type 1 families who are from the resource restrained or not very affluent. They feel difficult to control, procure insulin and the glucometer strips, because frequent monitoring again will be requiring money to procure the strips. Those are little challenges, but that's an overview of the challenges what we can see. But these challenges again can be different with different age groups. Type 1 you can get commonly, age group is 5 to 7 years, or say pre-puberty you get the common age group children's, but you can get different age groups. I have one patient, his age is 4 years. Another type 1 patient, her age is 55 years. She had been type 1 for last 30 years. So different age group patients will be there, and they will have different management difficulties while managing their sugars daily. I'll go into little details about the different age groups. In the infant and the toddler age group, what obstacles you can see, or in the management from the patient perspective, is that they have limited cognitive capacity, poor communication skills, lack of cooperation, and autonomous behavior is there. So these are the very difficult patients to treat with insulin and to keep the sugars well controlled. As a caregivers, so parents and all, they will not be able to recognize hypoglycemia, because the toddlers, they will not be able to tell that they have, they're feeling low sugar or something, or palpitations. They will not appreciate, they will not understand that. And they do not follow a healthy eating habit. Whatever is fed by the parents, or they hear from the neighbors or family members, they will feed accordingly, not what a type 1 patient fed. So psychological distress and burnt out may be there as a caregiver. In this age group, mother will be injecting the insulin. And again, say feeding and all, everything, household chores will be there. So it's difficult for managing the sugars very effectively. And that may adversely affect the family as a whole. So how to have a solution to it? We should give a structured education, P1D education to the family, the parents. Here, the patient is not the receiver of the thing. And we have to integrate user-friendly technology solutions. We have to look into what kind of family background they are, and how much, they are savvy about the newer, technologies, and then we have to guide them accordingly. And again, counseling services will definitely be required in this group of patients and the family. If we move up to the next age group of preschool and early elementary children, we can see that limited language and cognitive function, ability to express symptoms are little difficult, and developmental behaviors tend to exhibit, and those sort of difficulties may be faced. And for the caregiver also, there are a lot of concerns about managing the diabetes in these settings. So we have to again implement behavioral interventions to address the indicators. Here will be dealing with the patient, because they are little now able to understand something. And we have to develop individualized diabetes management plans at the school also. We have started one NGO with a patient's mother. And we are trying to do school education programs to talk with the teachers, talk with the school children's. If someone is diabetic, we'll talk to them. And if someone is not diabetic also, we are talking to them. Create some awareness. If any, say, classmate is diabetic, what to observe. And then those sort of things can be done. A few pictures of where we do the programs, and we do that regularly. As the age group goes higher, the solution, the problems also become increasingly more complex. And again, we have to have solutions to it. I'll not go in details, to all the solutions. These are the practical points which will eventually manage the sugars effectively. Treatment is, we all know, insulin, and only insulin, with little adjunct therapies which Madam has quoted, but not a substitute. Insulin is the only treatment. There are advances also which gives little edge in treating diabetes, type 1 diabetes effectively. CGMs have come. There are different types of CGM we are using, and acceptance is increasing, and it's improving the diabetes care immensely, but we have to use the technology properly. Advances in treatment is also there. Insulin delivery devices have come, insulin pumps, closed loop pumps. I think she is using a closed loop pump, 780G. Yeah. So two of my patients are using 780G pumps, but most of the patients are not able to afford the insulin also. And that's why we started this NGO, and we are getting funds, and we are giving free insulin, free supplies of insulin and the strips on a regular basis. Help those kind of families. Some of them can afford, they are using pumps also. So these are little advances which will improve the type 1 care, but still the treatment is insulin. And Madam had already mentioned about the immunotherapy, which is an emerging thing, has recently happened, and maybe in near future, if cost comes down, which I don't think it will come down very soon, may have some cure or for type 1 diabetes. So different types of pumps are there. What is commonly available in India is the Medtronic pumps, which we are using, but there are different pumps which are expected to come. Roche is, I think, coming in India with an insulin pump, and the recent pumps are quite effective in controlling the sugar, because it is almost working as an artificial pancreas. So to summarize, type 1 diabetes commonly presence in the childhood or adolescence, and symptoms we all know: polydipsia, polyuria, polyphagia, weight loss, and fatigue will be there, and they will be requiring, say, insulin lifelong, and mostly the basal bolus therapy. And if someone is able to use an insulin pump, it is definitely having some benefit from the basal bolus therapy. But even if someone is using a pump, we have to keep the pens ready. Sometimes the pump may not work properly, or the catheter may kink, or issues may be there. So suggest that they keep a bolus insulin, at least the pen should be there available in case of sugars going high, and we can use that in a timely manner, prevent ketoacidosis. Apart from insulin, some adjunct therapies are also there, which is there, and maybe users will improve in the time to come. And technology definitely plays an important role in managing the type 1 diabetes. And just that the affordability part and the user friendliness of the technology has to be there to make it being used by a lot of type 1 patients. So thank you so much for the patient hearing, and over to Chairperson.
Right? Talking about emergencies. What we see. Second is glycemia. So my talk primary will be on K, because that is what we day-to-day practice, and my present will be a typical of practical tips what we are going to do in our clinical practice. K is basically stands for diabetes where blood glucose more than 200. K is for keto where there is a capillary or blood keto concentration more than 32, or there is a significant keto. And A stands for acidosis where bicarb concentration less than 15 or the venous pH is less than 7.3. By this, as a DKA, diagnosis wise, more or less a biochemical kind of diagnosis where we rely on more of these features of blood glucose, acidosis like bicarb, pH, and then ketones. But though there are clinical signs also like symptoms where polyuria, polydipsia, polyphagia, weight loss, breathlessness, signs of dehydration, cosmos with lethargy and drowsiness. But like we rely for diagnosis on biochemical parameters, and once we do that, because I won't go in detail of pathophysiology, but it is the basically it starts with the absolute efficiency or relative presence of stress, infection, where there is a surge of counter-regulating hormones which increases lipolysis, by which it increases the free fatty acid to the liver, and then there is a ketogenesis, increased ketones, just the alkali reservoir which produces acidosis. Overall, we have acidosis, dehydration, and hyperosmolality. These are the three areas what we need to manage properly. There are three management. First is dehydration, second is high glucose, and third electrolyte imbalance. And we have three weapons for this. First is fluids, second is insulin, third is potassium. When we are going practically about a patient where is admitted with a critical care unit, where the first hour, what we need to do first, once patient gets admitted to our center, where the initial lab work immediately after admission, take out the blood samples, point of care of blood glucose, where capillary glucose meters, random blood sugars, then blood glass analysis, preferably arterial, but venous also will do. Venous pH is also quite helpful in type 1 patients, type 1 DK, serum electrolytes, FTs, osmolarity, and then in deep strips for ketones. The first action what we need to do right in the beginning. Second is to assess the severity of decay, whether it is a mild decay, moderate decay, or severe decay. So these are the characteristics by which we can grade the severity of decay. First, we have collected a sample, and then secondly, we assess the severity. Thing is, the basics of any medical management is with A, B, yes. A is airway, B is breathing,
circulation, D is diabetes, E is for electrolytes, and S is for sensorium or search for infections. So right at the beginning, the first place, we need to put two separate lines. So now first for IV fluids, second for insulin. So that is the mandatory. Second thing is, after that, oxygen for shock and antibiotics in case of fever. Now, the protocol management for all sorts of DK patients where you should follow this. And in detail, the focus of the primary focus of the treatment will be like these 5 factors where fluids, potassium, insulin, monitoring, and transition. The way we approach our DK patients. First and foremost is fluids. Many times what happens, RMO or a duty doctor sees a value of 550, 400. He's stuck. Insulin. Insulin is not the first modality. It is the first. Is only fluid resuscitation is the cornerstone of diabetic decay management, and the fluid of choice is 0.9% normal saline. So first fluid is normal saline for first 2 hours. 1 to 1.5 liters per hour for the first hour. So that's got to be dictum. Any patients of DK, don't start immediately insulin. We need to give at least 1 to 1.5 liters for first hour. For pediatric use, more cautious approach, that is 10 to 20 ml per first hours is required. And our aim, replace approximately 50% of the estimated fluid loss in next first 8 to 12 hours. That should be our aim, to replenish all fluid within 8 to 12 hours. So monitoring is very key, where signs of fluid overload, especially the elderly or heart failure patients, we need to be little watchful. What sort of food? Because first you start with normal saline, and then there is question, half normal saline istemal karna hai, when to change the DNS. But dictum is, first few hours normal saline, and then, because according to the sodium, potassium, because we are doing it right in the first place at the time of diagnosis, second after 4 hours, and at the end of the 8 hours. So 3 electrolytes are mandatory for DK patients. At the end of 4 hours, you need to again repeat the sodium and see for the corrected sodium. If the corrected sodium is still on the lower side, continue with the 0.9% sodium. If corrected sodium is on the higher side, that means you switch over to the half normal saline. Once blood sugar gets below 200-250 range, then switch over to the dextrose containing fluid. That's a simple way of managing with normal saline or half normal saline or DNS. And second step, I have not started yet to insulin. Second critical step is about potassium, because potassium is the key factor, key management as far as DK is concerned. Where we should aware that we have large potassium deficit in DK. So overall, the management should based on the basics levels, like if potassium is less than 3.3, if it is between 3.3 to 5.2, or if it is more than 5.2. Suppose, because if overall at the time of admission, suppose the potassium is around 4, patient, even duty doctors or many consultants, they feel like, potassium to abhi acha hai, kyun dena hai? But that is not the dictum. Where even with the 3.3 to 5.2, there is a 40 milliequivalent per liter potassium has to be infused. And now this is the critical phase where the potassium is less than 3.3, don't start insulin. Insulin should be avoided, should be deferred at least for 2 hours. Repeat potassium once again and then start, because it is a criminal to start insulin drip when potassium is the less than 3 or 3.5, because it can cause arrhythmias and all those issues. Like if less than 3, don't start insulin. 0.3 to 5.2, you can give 40 milliequivalents per liter. That is the overall potassium management. And if the potassium is more than 5.5, then wait for kidney functions and urine output. So I hope this is the important management about potassium. Nowadays we are not using bicarbs anymore, because the bicarb use is recommended only for the severe acidosis where pH is less than 6.9 with severe hemodynamic instability. Phosphate also we are not using, we are not generally recommended. Step 3 is insulin management, where it is for the metabolic switch. You can start with the continuous IV insulin infusion at the rate of 0.5 units per kg per hour. And the critical rule we have just mentioned about potassium, should not start potassium, we should not start insulin when potassium is on the lower side. Once blood sugars are below 200 to 250 range, then switch over the dextrose containing fluids. As far as insulin is concerned, there is no role of IV boluses more. Don't use insulin for the first hour. That should be the management, only fluid for the first hour. Continuous IV infusion to the separate line. Because you maintain two lines, those we have already discussed. Regular insulin is what we are using continuously now, because that is the recommended insulin. And how long it should be continued insulin to be continued till the resolution of acidosis. Care to be taken when blood sugar goes below 200 or the dextrose containing points. Final step for safe discharge is when glucose is less than 200, bicarbs are more than 15, venous pH is more than 7.3, and anion gap is less than 12. The patients can be switched over to the subcutaneous insulin. And here point to be noted that the anion gap is the most reliable marker of decay resolution. Do not stop IV insulin until the anion gap closed and patient is ready for transition to the subcutaneous insulin. And what are the common complications of decay and pitfalls? Where hypoglycemia, because many of times young doctors are over enthusiastic. Is the reports blood sugar 400 hai 500 hai, took the insulin. So that kind of aggressiveness and should be avoided. Hypokalemia is another issue, because patients, many times clinicians also forget about potassium. They only focuses on glucose. So hypokalemia is a major threatful complication. Fluid overload is another one, and should be worried about cerebral edema, because it's a rare but a devastating, fearful complications. And whom to suspect cerebral edema is bradycardia with hypertension, changing neurological status with a severe headache, and these are the patients where severe decay patients where blood urea nitrogen is more than 20, pH is less than 7, PCO2 less than 21, age less than 5 years. So these are the patients of subset patients where we need to be more vigilant, because these are the cases where there is a likelihood of developing cerebral edema. In case of cerebral edema, keep mannitol ready, slow down fluid rate. Another emergency is HHS, where there is a dehydration emergency, what we call. So pathophysiology, it has a sufficient insulin to prevent ketosis, but not enough to prevent severe hyperglycemia. The diagnostic criteria is where glucose is more than 600, osmolarity is more than 320, pH is usually more than 7.3, bicarbs are more than 18. So there is enough insulin, but the dehydration is in HHS. And here the key differences between HHS and DK, where we see DK is at the younger age versus HSS at the older age. DK is a very rapid and HSS is a gradual mode of action, where plasma glucose is more than 600 or so in HHS, where it is like not that big, big 250, 300, that's all. pH less than 7.3 and pH is more than 7.3 in HHS. And osmolarity is the issue HHS, where you see osmolarity more than 320 in HHS. As far as management is concerned, here the key is aggressive fluid assistance, where the primary focus is just fluid replacement, where patient has a much larger fluid deficit to the tune of 8 to 12 liters than DK patients. So just push more fluids and start insulin drip at a lower rate. Should be like 0.05 units per kg per hour. That should be the rate for HHS. Here the mantra for HSS is only fluids first, and potassium management is more or less same as far as TK. The third emergency, it is very common in type 1 diabetes, is hypoglycemia, where blood glucose is less than 54. Have a tired definition for hypoglycemia, where level 1 is less than 70, level 2 is below 54, level 3 is a severe event with an altered physical or mental status. It is a more common emergency than DK hypoglycemia, but hypoglycemia, where golden minutes in hypoglycemia is very crucial. So every minute is crucial in hypoglycemia, where because you should not deprive brain of glucose. That should be dictum for all clinicians, so patients should not have any kind of hypoglycemia. That should be our primary aim. When in severe hypoglycemia, in case of conscious patients where 15 gram of fast-acting carbohydrates like glucose tablets, juices can be given. Unconscious patient, community-wise, glucagon administration can be taught to the patient's relatives, communities. Unconscious patients in hospital setting with IV 25 dextrose can be given. This is the management what we usually practices for hypoglycemia, and there is everyone is aware of the rule of 15 for hypoglycemia, where consume 15 gram of fast-acting carbohydrates, wait for 15 minutes. If blood sugars are still on the lower side, then again repeat the same. So the hypoglycemia management, as we have discussed, and the final takeaways. My presentation in diabetic emergencies are of three parts: DK, HSS, and hypoglycemia. As far as DK is concerned, fluids first, fix the potassium, and then the insulin. That should be the flow for our management. Don't run for glucose first. Wait for hydrate properly, and then start insulin and adjust potassium accordingly. HSS, no, the fluids are top priority, but here lower insulin dose. That's the key for HSS. More fluids, less insulin. And hypoglycemia, recognize early, treat fast. Prevention is of paramount importance. To summarize, overall, I have seen that now we have to follow the protocol-based system rather than individual instincts. We should forget all individual instincts and go with the protocol-driven system. Because now with the DK and overall, if you see, the protocols are very clear. First sample, then monitoring 4-hourly, 8-hourly, 12-hourly. Ideally, one should be able to resolve DK within 24 to 48 hours, because insulin being a ultrasonic mimic action where it causes more of potassium losses. So now our aim is to cut short transit from IV insulin to subcutaneous as early as possible. So that should be our motive, and that's a protocol-driven system is the key. But never forget the clinical context. Thank you so much for your patient listening.
Thank you for the very informative answer. Quick time. Thank you, sir. This is about the psychosocial effects of type 1 diabetes. Pathologist, co-founder Beyond Injections, State Insulin Pump Clinic. Over to you, ma'am.
Thank you for the kind introduction. So none of the management that Dr. Rupam taught us will work if the mental health of a person with type 1 diabetes is not taken care of. Nice slide. So the reason why I've put sir's photo is because today I really want to salute this man, because he realized the importance of mental health in people living with type 1 diabetes from the beginning. He was one of the few people who involved a psychiatrist for treatment of type 1 diabetes from day one. Not a single education camp has happened without a psychiatrist in his organization. So I believe that living with type 1 diabetes is a journey of acceptance. It starts at diagnosis and then it never ends. At different phases of life, you're faced with different kinds of challenges, and you have to accept and re-accept living with type 1 diabetes. So these are two very different scenarios. One, we have a young 4-year-old girl or 5-year-old girl, and in the other case, you have an adult or a young adult or an 18-year-old male, female, whatever. The gender is not important here. The reaction in both the cases will be very different. Of course, the initial shock, I think we've heard it multiple times, that at diagnosis there is an initial shock, and then you go through a teething phase, and once you learn to accept. But in the girl's case, It is not the girl who needs to accept, it is her parents who need to accept. But in the young adult or the, you know, slightly older adolescent, young adult person, it is the person with diabetes who needs to accept. And I always believe that if you've lived to remember a life without type 1 diabetes, it's probably twice as more difficult to accept because you know a life without it. And then now you're going to have to do all of these things, you know, but a carefree person, you know, just you move out of the house with only your phone and your wallet. Nowadays, not even that because you have GPay. Now you have type 1 diabetes and everything in your life has to be planned. So generally the diagnosis comes with lots and lots of anxiety for parents, and in the case of an older person, for themselves. They have anxiety related to longevity. How long will my daughter live? Will she die early? Will she able to live normally? Will she able to fit in the society? Will she be able to make friends? Will she or he be able to make friends? Will she or he be able to have a career? Will they be able to get married? Will they be able to have children? How will society perceive them? Will they be subjects of discrimination? Will they be stigmatized? Because no parent wants to see their child go through that. The impact is something that comes later on. And I think in India, I've repeatedly heard it, that there is a huge impact on finance. There is an impact in relationship. So the relationship between the parents, psychosocial health of the parent is equally important. The diagnosis of the child significantly impacts the relationship between the two parents. If they don't work as a team together, they start blaming each other. The impact it has on their attitude toward their child. You know, restricting playtime, not allowing to play more than 1 hour, half an hour, repeatedly going down, trying to feed them, prevent hypoglycemia. So that is actually also a reflection of the psychosocial aspect. It's a reflection of the anxiety that the parent is facing. Forcing the child to study, you know, that you need to have a career, you need to do well in life, you need to get good marks so that you can compensate for your type 1. The emotional well-being of the child as they are growing up, the emotional well-being of the parent, and of course, the biggest impact that the psychosocial health will eventually have is the physical. Type 1 diabetes is unlike any other chronic disease where you require constant management. You need to constantly think about what you're doing, what you're eating, what your sugar is, how much insulin, how much to take, how much not to take, how much to reduce. And if your mind is not right, you're not going to be able. It requires significant cognitive involvement. It requires you to be in a stable state of mind to be able to take a well-informed, maybe as close as accurate decision as possible. So if your mental health is not okay, the first thing to get affected is your glycemic control. And if that poor mental health stays for longer periods of time, it is going to eventually affect your physical health. And you may, by the age of 25, 30, develop severe complications, which is going to worsen the mental. So this is the cycle of acceptance. Whenever you get diagnosed, the first thing that any person goes through is denial. They'll deny. हमको तो है ही नहीं. हम नहीं देंगे insulin. Okay? Then comes anger and aggression. So they will be angry at. Who will they be angry at? The doctor. आपको हमको इंसुलिन पे डालना है. They don't know कहाँ हम एक्सप्रेस करें. They'll be angry at the doctor. They'll be angry at the educator telling them कि आपको 6 बार दिन में sugars check करने हैं. They'll be, angry at whoever they can find. They'll be angry at
another peer who's trying to support them. The child will be angry at the parents that it's because of you that I have this condition. After anger comes depression. Okay. And after depression comes bargaining. This is the stage when they will start bargaining. They'll go to all kinds of quacks. कि हाँ थोड़ा सा इंसुलिन कम कर देते, हम ये डाइट करते हैं, इंसुलिन कम हो जाएगा, धीरे धीरे शायद बंद हो जाएगा. So this is the most dangerous stage. And then finally, they'll accept it. Now, it is not necessary that they will go to the stage of acceptance. They remain in the stage of denial for years together. And then later go into the stage of acceptance. What will get affected? Physical health. They'll start developing complications. Height will be. And then it's next to impossible to accept. They may remain angry. This is very true with teenagers. They are so angry. They are so angry. You try everything. And that teenager becomes an adult. And then he comes and shows you his A1C and he tells you, doctor, now I want to bring my sugar. Okay, but those 5 years of damage, once he was double digit, is not going to be. Depression, luckily, can be treated. We have medications. We don't have any medication for anger. And bargaining is where all the quacks take. Now this girl or person with type 1 diabetes has grown up. Now they've become an adolescent. They've accepted their diabetes. She's living well with it. She's doing everything she has to do. But now she faces new challenges. All of her peers are worrying about boys. They are worrying about how they are growing. They are worrying about how they look. They are learning makeup technique. But this person is struggling with deciding what to eat, what not to eat. Can I go out alone with my friends? How do I take injection in front of other people? How can I make an excuse so that I have some privacy to go and take injection? How do I tell my friends that I cannot make extempo plans with you guys? I need to plan my out according to my diabetes. This is the time when they are at a very high risk of developing any kind of psychiatric issues, especially depression, and they are at a very high risk of developing eating disorder. There's significant diabetes related distress, and I think teenage anyways is a very, very difficult age. It also impacts your blood sugar control. And if you mix in poor psychosocial health, that will be even worse. Especially if their relationship within the family is affected, can have a huge impact. This is the age when they start realizing that I am different from society. Till now they were protected by parents, protected by family, but now they've started thinking about themselves. They've started becoming a person of their own. And they again need to go through the cycle. Now it is not necessarily that they will reach acceptance. They may remain in anger, may remain in depression for years to come. Finally, she grows up. Now they're entering adulthood. And young adulthood is a very, very challenging time because this is the time when you're looking out for your career, or looking out for a partner in marriage. And when you are repeatedly rejected by society, your own acceptance dwindles. So there are times you may have to accept your condition multiple times in a year. January, had a proposal rejected. March, you went for a job interview, rejected. And every time you face a rejection, it may not be because of the diabetes. But somewhere at the back of your mind, always wonder, is it because of this? Am I not enough? Everything that I've worked towards in my life is just not enough because of this one condition. This boils down to this, is that what it is? And then you start, then at this age, you start realizing about the impact diabetes may have on your health. So you start worrying about complications. Because you've seen older peers, they've started developing issues, and you start worrying about your own health. So you start developing anxiety. And a lot of double diabetes that we see around this age, when you start working, you have no time to look after your health, you're working 12 hours at a job, food is all over the place. One of the most challenging periods, where most of the times they develop double diabetes or metabolic health issue. Okay, you get married, you have a family. Motherhood brings new challenges, motherhood or fatherhood, because now you're not only responsible for yourself, you're also responsible for the child. But I think motherhood is, I'm being a little gender biased here, but motherhood is much more difficult because you have to care for the child as along with your own blood sugars, and there's always a tussle कि मैं उसका पहले देखूं कि अपना पहले देखूं. And postpartum depression is very, very common in this group. And that is why constant touch, constant peer support is very important. Of course, you again worry about your finances. You again worry about your relationship with your husband, because your husband or your spouse needs to understand your condition. You again worry about because your leisure activities change, your career goals change, and your emotional well-being is also affected. So you again go through the cycle of acceptance. And then comes middle age and old age. This age is where you may be facing burden of complications. This is the age where you see some of your colleagues, diabetic or non-diabetic, developing health issues. So you're really, really worried about your own health, and it comes with its own set of anxiety. Of course, you age a little faster considering the metabolic impact of type 1 diabetes. But now you've lived for type 1 diabetes for say 25-30 years, and now you start developing something called as hypo-unawareness. And hypo-unawareness is extremely scary to live with, because it significantly impacts your glycemic control. And every time you try to achieve a good control, you get your hypoglycemia. So luckily we have a lot of devices now, we have a lot of technology in place, not everyone unfortunately can afford it. So fear of hypoglycemia, I think, is one of the most difficult to address psychosocial aspect of type 1 diabetes. Only 2 episodes of severe hypoglycemia or 1 episode of severe hypoglycemia can impair or prevent you from achieving glycemic control. I've seen patients who wouldn't allow their sugar to go below 200 because they were so scared of hypoglycemia. Bedtime sugars, we let it be high. If my sugar is 150, I eat a snack. I don't want to get a nocturnal hypoglycemia. So again, you go through a cycle of acceptance. As I said, living with type 1 diabetes is all about accepting, reaccepting, and reaccepting your diabetes and the new challenges you face at every stage. So when I was preparing for this talk, I asked a few of my peers that, is this what you go through? Tell me what you are experiencing. And one of them said, and I'm going to quote her, that I don't think I would have any anxiety in my life if I did not have type 1 diabetes. So I think anxiety is one of the commonest psychiatric issues that a lot of people with type 1 diabetes face. It may not always require treatment, but it does require counseling, and it does require a little help. So what are the solutions? And what research, evidence, and experience has shown is empowering the patient can make a huge impact in terms of their mental health. So empowerment, empowerment, empowerment is the solution. Okay. Family support, unfortunately, is not in our control. Try to educate the family, but if they come from a broken family, there's nothing much that you can do. Social support in terms of community. So We have a lot of people who come from different communities. Communities have different approaches. Peer support is something that is being talked about, and we are seeing a lot of support groups happening all over the country. And peer support, I think, is one of the most foolproof ways to deal with psychosocial health in people with type 1 diabetes. And one thing which has really improved or helped psychosocial health is that the person is themselves involved in their own management. So active involvement in your own diabetes management can make a lot of difference. That is why even in children, we always encourage that you involve them as early as possible, so they start learning how to take care of their diabetes, and that actually has a positive impact on the mental health of the child. Right, so this is one of our camps. Then this is our mental health team. We have Vaishali here, who's our counselor, and we have Dr. Manoj, who's our psychiatrist. So that's it. Thank you.
What I want. She herself is a type 1 diabetic. Actually was question I please. The last session.
So much, ma'am. See the law.
Thank you, chairpersons, and I'll be quick because this is my last. LADA. Everybody spoke about type 1. LADA, we are going to see a case-based discussion, but before we go to the cases, I'll just tell a brief introduction about LADA. LADA is the same as type 1. It's an autoimmune disease, but begins in adulthood. LADA, by definition itself, is a disease of adults. What does WHO define LADA as? It is a slowly evolving immune-related diabetes. Type 1, the presentation is very dramatic, but the poor LADA patients, they are misdiagnosed as type 2, they go doctor to doctor, and then finally we reach a diagnosis after many years of hyperglycemia. So what is the criteria for diagnosis of LADA? The Immunology for Diabetes Society says 3 criteria: age more than 30, positive autoantibodies to islet beta cells, insulin independence for at least the initial 6 months. But in practice, friends, even after 6 years after developing diabetes, they are not on insulin. They are mostly on multiple OADs, and they roam around with very poor glycemic control. That is the real picture for our LADA patients. So LADA is also called a type 1.5 diabetes because it shares genetic, immunological, and metabolic features with both the diabetes. So let's see how does it differ from type 1 and type 2. Type 1, of course, very dramatic presentation. C-peptide will be hardly there. The antibody titer is high, and basal bolus insulin is the treatment. They will be having a family history of autoimmune disease. LADA comes somewhere in between. That is why most of the LADA patients get treated as type 2 diabetes, at least in the first 7 to 8 years of their diagnosis. So LADA here, I've given 30 to 50 years, but there is no upper limit of diagnosing LADA. Last year, I diagnosed a 75-year-old gentleman with LADA, and he's doing very well with basal bolus insulin. So don't think LADA is only for 30 to 50. You must keep your eyes and ears open to pick up LADA in any age group more than 30 years. So it is a heterogeneous disease characterized by less intensive autoimmune process. The autoimmune process is dramatic in type 1. Here it is slowly evolving beta cell loss, and that's why the insulin therapy, unfortunately, is started very, very late in this patient. So here the C-peptide levels decrease very, very slowly, and this marker is used to stage the LADA patients, and according to the residual beta cell functions, we give the insulin. So let me tell you, this is a consensus statement from an international expert panel. C-peptide, when you check for your patient, LADA patient, suspected LADA patient, if less than 0.3, basal bolus, just like type 1. C-peptide more than 0.3 but less than 0.7, they say give insulin plus you can use drugs. But in practice, friends, even when the patient comes with 0.3 to 0.7, they respond very dramatically to basal bolus insulin therapy. C-peptide above 0.7 is what the expert consensus say you treat it as type 2. But here also, in my practice, a BD dose of glargine will make a lot of difference in the quality of life of these patients. So this is the consensus statement. If you see, C-peptide very low, basal bolus 0.3 to 0.7, you can use basal insulin plus some drugs. And more than 0.7, they are saying type 2, but in practice, I use a lot of insulin in my patients with even 0.7 to 0.9. And patients are very willing, because once you start the basal insulin, the sugar starts coming down and they start, feeling much better. They will have all the signs and symptoms of type 1. They will have polyuria, they will have excessive thirst. I had a patient from Rajasthan. He had come and he had a big bottle of ice water in his hand, and every half an hour he had to use the washroom. That was his symptoms. That much severe were his symptoms of LADA. So, importance of insulin, friends. LADA is a gradual insulin dependent progression characteristics. So, insulin is deemed necessary, according to me, even during the clinical non-insulin independent state also they will need. If you're clever enough, you just suspect LADA in a young patient and do the C-peptide, and if it's just 0.7 or 0.9, just give them metformin and 2 times glargine, he recovers dramatically. So research indicates that insulin therapy effectively preserves the residual beta cell functions and reduces the severity of insulitis. I have many LADA patients without bolus insulin, just 2 times glargine and some sensitizers. So this was the study I presented in Vellore Endocrinology International Congress this January, and this was done in my clinic. So it was a retrospective cohort study, 15 patients. They were all enrolled between 2020 to 2023. Let me tell you the characteristics of these patients. The age were more than age more than 30 years, high HbA1c. All of them had very, very high HbA1c. The one from Rajasthan had around 17% HbA1c. History of weight loss. Average duration of diabetes, they were all not newly diagnosed. They already had diabetes for 10 to 12 years, been to various doctors. Most of the time I was the 7th or 8th doctor. So the current treatment regimen, you'll be surprised, most of them were on 3 OADs, which included sulfonylurea, and they were on premix insulin. Believe me, they were on premix insulin, and mostly they had high doses of premix insulin. You may be wondering, then why did the patient, they don't respond to premix. Just like your type 1, there was a lot of advocacy yesterday about basal bolus for type 1s. There should be basal bolus for LADAs also, because they respond very dramatically. So here I did the fasting C-peptide level, GAD65 antibody. I got a grant from Lupin Metabolics, so we did GAD65 for all these patients. All 15 patients had very, very low C-peptide levels. 14 out of 15 tested positive for GAD65 antibody, and 10 out of 15 had other autoimmune diseases like hypothyroidism. 1% had Graves. So here what was the treatment given? All OADs were stopped. Premix insulin was stopped. Basal bolus insulin therapy was started. And it was easy to convince these patients, because already 10 years they've been living with high diabetes. They've gone to doctor onto doctor. So when I tell, bar have insulin lagao, your sugar will come down, they are very happy, and it's easy to convince them. And regular self-monitoring of blood glucose was done for these patients. Some of them were put on CMs. I taught them carbohydrate counting just like the type 1 children, because the family members, when they think isko bahut zyada hai, they were giving them only karela ka sabji and some chapati, one chapati, just like a type 2. So here, when you teach carbohydrate counting, their life becomes easier. So they were taught to count the carbohydrates, and believe me, even elderly patients, 60 plus, 65 plus patients, learn very enthusiastically the carbohydrate. Don't think it's only the children. Even they have that, zest for living. They learn the carbohydrate counting and they take their basal bolus accordingly. So clinical improvements in all these 15 patients: dramatic improvement, HbA1c reduction, weight gain, improved quality of life. Of course, after 6 or 7 months, they become, the doses, the boluses will increase. So I had to put them on metformin, and some of them for the post-meal peaks, they are on acarbose after 6 months. After 6 months, they become healthy. So this is the demographics of my study. If you see, the HbA1c was 14.8 plus or minus 1.2 when they presented. With basal bolus, it came down to 8.8. Less than 0.3, 6 of them had less than 0.3 C-peptide, 6 of them had 0.3 to 0.7, and 3 of them had 0.7. And 14 out of 15 were GAD antibody. So, when should you clinically suspect LADA? Age above 30 years, getting treated as type 2 diabetes, poor glycemic control in spite of 3 OADs, which will include a SU and premix insulin. And all these 15 patients in my study were on very high doses of premix insulin, but they had very high HbA1c levels. So do a C-peptide fasting when you suspect LADA and GAD65 antibody testing. Treatment, when they come to you with a C-peptide of less than 0.3, please stop all OADs, stop the premix, put them on basal bolus. And as I told you, they would have suffered for many years. So they easily, accepted, okay, 4 bar insulin lena hai, I will do it. And limitations, of course, it was only 15 patients. This was from 2020 till 20 to 23. So after that, I have a lot of data which I have to publish. So clinical trials and cohort studies are still required to get this point across that even LADA patients need basal bolus. Summary, friends, LADA, it is an autoimmune disease since in adulthood, requires insulin, not in the first 6 months, they say, but many years they are roam around without insulin. Early recognition is paramount because we have strategies to delay the beta cell destruction. Clinicians should consider screening for LADA in patients with type 2 who do not respond to 3 OADs and premix. Fasting, post-meal C-peptide and GAD65 antibody have to do. Personal experience, this is open to the forum. No upper age limit beyond which you cannot say 50 हो गया 50 के बाद लाड़ा नहीं हो सकता है. You can. I told you, 75-year-old I recently diagnosed. He's on basal bolus, doing excellently well. Learned carbohydrate counting. He's so sincere. And I find, this is a question for the panelists. I find glargine twice a day in all my type 1 patients as well as LADA patients. Basal insulin, I find glargine twice a day better than the long-acting analogs. I feel the fine-tuning can be done properly, and somehow I feel glargine BD is better than the long-acting analog. Of course, I'll leave it to the panelists. Thank you.
So much, ma'am.
always.
And if you
That case, get their part was everything. Judgment. Absolutely. Exactly. I'm
using
cautious. Checking everything.
right by the time, and if
Yes. Chairperson, sir, and Purvi ma'am for inviting me here. I'll be talking about very important topic of improving compliance and adherence in diabetes. Very neglected topic, but we need to discuss. First question. So why we are treating diabetes? Question for treating diabetes is optimal long term. Fortunately, what happens? Science challenge our practice. Many following also lifestyle. That's why we are talking this. So what is adherence? There are different definitions. People think patient taking medications, patient is following diet and exercise. This is what we call the FDA, US medication adherence or taking correctly extent as prescribed by the doctors, false factors understand their direction. What WHO also specifies that extent to which a person's behavior of taking medication, following diet and or executing lifestyle corresponds to agreed recommendation. Here the word is agreed for the said from a healthcare provider. These are the simple definition and for adherence. Outcome is adherence outcome and overall health economics studies in type 2 diabetes 10% adherence 5.4 if you keep at least hypoglycemia for patient 30% procurement of days total days cover if person is a 5-year mortality by 7% is again and procurement increased by 10%. Annual cost on health reduce up to 9%. So these are big number achieved, and the reality is different. Insurance is overestimated. Yeah, where we think poor from our side, but already very overestimated. Very high index of non-adherence because it leads and 3 lakhs preventable deaths, more than 300 billion avoidable costs, and around 70% medication related hospital avoided. There are different methods on adherence. Couple points. First and foremost, blood sugar. So, always remember FB compliance. HB sometimes helps. Sometimes people with or good relations take extension, or you give and themselves said they tell about traveling. This is when you sometimes we
cartridges for insulin. Relatives, again, very, very important. Purchase. Relatives tell from themselves. Many of the lifestyle compliance or not. Ask the relatives to monitor their SAP count or your team, healthcare, diabetes, and monitor them virtually also regarding the step counting file or smartwatch for the exercise compliance also. So there are 5 components: patient-related factors, health-related factors, habit factors, and very important social factors. Lack of time and not going till 700 factors, non-adherence also. Again, there are modifiable factors, factors. There are enablers for adherence, enablers for adherence. I won't be going to detail. What I'll be discussing about my practical point. I have learned OPD last 10. What I have learned from research, various papers and guidelines, I'll be discussing those practical points. We have 9 minutes. First and foremost, adherence starts from proper prescription. I know we are all expert in writing prescription, but there are many things which leads to proper adherence or poor adherence. First step is make that decision making writing prescription. That decision making means to involve your patient, diabetes of those, to involve them. Not only you are the best doctor, what you write is best treatment. Yes, we all follow guidelines. All want to give our patient the best treatment. But patient's involvement in writing prescription is very important. Social factors also, age, marital status, pregnancy, planning also, educational status of the patient, very important. Job types also, job timings also for prescribing the tablets, where the patient take medicine. Elderly, very important, how family support is going to give, is going to remember the medication, check the drugs, insulin or GLP-1. These are again very crucial factors, the family support and care. In India, what makes point economics also. Right, the best treatment available in USA, but launched and marketed, many of the patients in my practices won't take it. Cost, economics, writing a cost. Okay, it's likely, and if there are so many corporate people for our patient, corporate of those patients pay for them for writing cost, because cost of the country. So, about side effects, very important thing to explain your proactively. What means do it from yourself. Secondly, yourself, side effect profiles must be addressed from the beginning. All the possible side effects. Explain side effect work also. What going benefit the side effect depending upon that patient's job status and education. On serious of them for discontinuation and or tablets or prevention of side effect also hypoglycemia. Again, a very, very key description. Very simple example. That patient and the next week goes into and you have not said anything compliant of those very poor. Definitely of the sometimes going to change you also. Our duty proactively explain them of possibility of hypoglycemia, how to prevent hypoglycemia. Once it has occurred, how to recognize hypoglycemia, what and how to self-treat hypoglycemia. Our duty. Once you do that, compliance with that medicine, sulfonylurea or insulin, definitely longer. Our duty, but very important, actively, our side we have to do. Medication, again very, very important. Complex regimens, our patients, they don't properly. All words. जो लिखा है वो करेंगे नहीं लेंगे. That's where he allows fixed dose. Very, very, or the best method. Our people did medicines. Yeah, allows fixed diabetes. And now we have combination anti-diabetic and hypertensive also come. We are aware about dapagliflozin, the beta-glucan, that is coming into already available. So India allows fixed combination, and that's where give those combinations really, twice really, science improve. Sometimes avoid or they don't lunch tablet. Work professional. Sometimes for insulin also. They don't want coffees, don't want of other. Sometimes don't want to take time medicine. याद नहीं रहता, भूल जाता, ज़्यादातर वो क्या ही नहीं है खाने के. Very common alpha glucose. Tablets are time dependent tablets. Take at a proper time, otherwise the effect won't be there. Also, very crucial to explain about the physiology of diabetes. Again comes, but very critical for newly diagnosed people. Diagnosed people come to your relieved from the better. We are not explaining whatever my teachers they have taught us about the people counseling. People language, a little bit of serious, but very promising. वाला नहीं, जीवन भर का साथी है और साथ में आएगा ताकि जल्दी ले वर्ड एंड इट इज रियलिटी. घबराने का मान सम्मान खाना खा सब अच्छा. The simple thing, pathophysiology, explain diabetes, adherence, very simple for only new diagnosed people. Psychosocial support, again, I heard just talk in type 1 diabetes, for our always motivate the patient to treat what 5 or 10 have. Provide your work with educators also, dietitian. Always address these perceived barriers of the patient. Ask them problem है, नहीं ले जा रही है. Ask them. Another, you have to actively search for. And another term called diabetes. Many of those have to counsel them. If required, you can have to involve first. Always, ideally, you should call them, all the patients, their family members. Call them in them because you cannot watch them in your clinic. You have to take pediatrics. Family members have them, and motivators or critics of them. But very important, always ask the family member, not only ask them. We do from our ask them and work well. A small motive, very important. What our teacher have told, what our teacher is also practicing right now. What I am practicing, direct contact with the patient. One important thing which your treatment. So very important. Side
one
effect.
more.
Yes, yes. Definitely there will be more compliance. I prescribe. I only call my patient. Doubting both phone counts, and usually if your appointment get any appointment, reminders, calls, we all are doing, minimize the wait, diverting the time, theaters, dietitian, or showing recording, or some dietary calls also. Video consult, again, part, technology part, but what I have gone through, current application of technology, diabetes, right now, all these AI at GPT, that GPT says, just say, AI is just a bubble now. And I don't think current major right now for future, but CM data is very critical. Real-time CG, again a very excellent educational tool for the adherence for the there. Important aspect, what currently very of health professional, dietitian, I wouldn't, but patient definitely diet recalls also, diet photos also, step counting also. They are calling the or they are messaging. Last part is your body language. Very important thing. Doctors also, your body language. How to all smile bigger. Thank you very much.
Amit, I'm
Thank you.
sticking to the time.
Thank you.
Thank you very much.
I'd like to thank DRS for work on people with diabetes are actually technology. Travel is structure, traveling planning greatly help in diabetes. Why this matters? Travel has become a integral part of our manage of increasing prevalence of diabetes and primary care physicians have very little knowledge of travelers, diabetes, and proper preparation can and What are the challenges traveler face? Travel with the change in the diet levels, also the climatic variations like the blood sugar and impacts the glucose monitoring. The diabetes itself is a travel itself result in traveling to remote areas, access different regions. The modern diabetes technology like of CGMs, smart insulin, transform travel diabetes. Patients are able to now maintain more blood glucose in time with drug episode hypoglycemia, greater flexibility in devices have come for the low glucose, and the patient can need it, but thing comes for free. Challenges with that the extra care is required for the devices, availability of supplies. Devices are expensive. Get these devices all the time. Challenges associated with the pre-travel evaluation. Ideally, it should be done at least 3 months before travel to medical assessment, comprehensive and physical exam, laboratory investigation. Also, and is fit to travel or not. If not fit, appropriate measures fit to travel. Preparation required immunizations, post control, identifying contraindication, travel. Pushing the lifestyle is like diet at the nation available. Post monitoring during travel is option at destination. Safer disposal price and early. Knowledge of differences in the prevent dosage is IU per few destination. Dosing errors and panic will occur. However, the essential documents, physician letter, medical ID, and medical ID regarding the medical alert, resource list, pharmacy, emergency service, travel checklist can be kept in your climate change. Again, the effect of climate, cold weather, warm weather has ecological risk, hydration. Also, the blood group cycle gives ability to dissipate heat through faster absorption rates, dilatation, and higher risk of heat related medication and device concerns in high temperatures, sensors, ultraviolets and other devices carry in lower temperature. Cold weather, in HbA tends to increase physical activity higher. Practical concerns was constriction, gastrics, increased risk of frost, People with diabetes, comorbidities, precautions, challenges at high altitude, hypoglycemia might be high altitude, malfunction, results, high UV can cause health in diabetic, low humidity, dehydration, and low oxygen. High altitude and slow trekking, higher catecholamine, higher blood glucose, insulin and ascend. Again at high altitude, hypoxia complex. Traveling by meter glucose at part of the journey, less glucose, very healthy, warm up and essentials. Alice, carry an extra pair of shoes. Wear proper shoes at the weight is distributed equally. Wear absorb. While driving by road, driving with diabetes requires balancing the right to drive is 18% health condition, glycemia, and risk. Modern technology like CGM that can provide early and can having dashboard display. Driving guidelines, follow all the local driving law. Check your glucose levels before starting the drive. Keep your blood glucose level. Take frequent breaks and take rest. Diabetes. Store in full bags. Travel with hands or diabetes. While traveling by rail, can carry extra supplies. Trains lack special meals. Advisable to carry. Meal delays. Limited access to pharmacies. Air conditioning. Train manager. Traveling with lack of pharmacy. Serious food. Take advantages of rising up. Take precautions against traveling with air requires special conditions. Air pressure change, duties check, travel zone. Challenges are dehydration, stress factors, glucose level, battery change, delays, cabin pressure change. Always carry medication in hand luggage rather. Regarding the devices, most of the devices are not safe to get damaged by the right, but in air. Freestyle lip brake can be placed, but it Sense 3 turntable right, or again if electronic pump slim will help preventing hyper and hypo happens. Always have a physician letter explaining the need for these devices and section with add down screen. Managing time zone, crossing multiple time zones, more than 5 times, and taking again having the travel east shorter day is shortened by the risk of insulin high, typically requires reduction of dose, need to reduce, monitor more frequently. Traveling towards the west of insulin deficiency may require additional dose of bolus dose. Again, you have to be having 2 duration. Practical approaches in pump users is the arrival, multi-drug injection, switching basal bolus from online insulin dosage calculation. Of insulin pump, travel and flight. Flight-related hypoglycemia has been reported in diabetic individuals. Although the ambient pressure at sea level is 700 to 560, decrease in the ambient pressure lead to the release of, and while coming down again, rate increase. Then rises, then pressure decrease. Pulse in the with increase in the release. And the plane begins to land, air pressure rises again, fuel dissolves in the increase in the insulin release can lead to used to be considered during flight in people who use pumps. The cartridge should contain only 1.5 ml. Pump must be disconnected before and takeoff. At the height of the flight, the cartridge must be all the existing. After landing, the pump must be disconnected, filled up to. Pump should be connected. In case of flight emergencies, in traveling in special sense like traveling to remote areas, wilderness, again where the supplies or healthcare access is limited, you have to be well prepared. There are guidelines by Wilderness Society, and nomads who travel in caravans, they are well prepared for the diabetes man. And now with the available of electronic health device, travelers can have travelers to remote locations have access to the Wild Society guide. Tips while traveling with insulin: carry your insulin in a cool pouch, keep it in your handbags, carry at least twice the insulin required as travel days and dose, carry non-perishable and manage, carry needles, syringe, the prescribed medicines, meters, handsets and glucometer along with the insulin. Carry your prescription along with do not forget diabetes identity card, and while traveling, store the insulin pen in the heated cooling or Frito wallets at the temperature. While traveling by air, insulin should not be packed with exposure. Guys, pre-travel preparation is essential. Documentation saves life. Pack smart. Monitor your sugar levels. Always have a backup plan. Remember, traveling with diabetes requires thoughtful planning, but it opens the door to extraordinary adventures. Stay informed, prepared, positives, can explore the world safely and confidently with glucose. Safe travels and safe journeys to.
Good evening, all. So, my topic here is premix insulin in type 2 diabetes in insulin naive patients. So, while initiating the discussion, I will just tell you that currently is an era of health check packages. We have every patient coming with a bunch of reports, and when you skim through it, you see that fasting sugar is there, but post-food sugar is never. And the simple reason is that healthcare package does not afford that for the cost efficiency, because it involves one more visit and one more test. So that test is always bypassed, and patient does not ever understand the importance of post-meal sugar, and ultimately ends up in complications. So here, importance of post-meal sugar has to be reiterated to the patient and the laboratory also, if possible. First of all, we must understand that insulin is required for every diabetic at some point in life. Very few are exceptions. Very few escape the insulin, but most of diabetics need insulin, and that is the time we should understand the reason for initiation of insulin is mostly glucotoxicity. A newly detected diabetes comes with 400, 500 sugar. His pancreas has gone numb, and we need to have injection in place. And that is the time when we can tell patients that this is a temporary insulin. We can control the sugar and then taper it off. Wherever other conditions are there where rapid control of sugar is required, pre-operative fitness, or where SMBG scenarios have shown very high sugar, we need to bring it down. Early effective control lowers the microvascular risk. We have to reiterate this to the patient. So when we have seen the things, we have mostly heard that basal insulin is very simple to start, easy to remain with. But most important thing is that it takes care of only fasting sugar, but leaves postprandial peaks unattended. And in high carb eating society like ours, we have PPG derived A1C more often seen, and hence PPG excursions are linked to endothelial dysfunction and CV risk. This has to be treated first. So basal insulin leads to slower reduction of A1C when PPG is contributing more. This leads to treatment inertia and false sense of security and more complications. Indian reality, we know that we are high carb eating society and with big PPG peak, and where PPG is always ignored. Even patients who are coming from SMBG, they bring only fasting sugar, if at all they bring. And that is very frustrating when we see the sugar chart. ICMR NIN dietary data shows that cereals contribute 51% in urban population to 65% in rural population as daily energy source. Protective foods like pulses, dairy, vegetables, fruits are often not in enough amount that is required. So addressing meals and educating patients about their carb eating is very pragmatic while initiating insulin. When we talk of comparison between basal and premix insulin, we must know their action potential. So slow onset of basal insulin is a good thing for avoiding hypoglycemia, but when it comes to sugar control, it has got a flat or no peak profile, and hence it does not control the post-meal sugar as much as it controls fasting sugar. As compared to that, premix or co-formulations, they have dual action. One rapid component to take care of the meal, and the another one long-acting component gives basal coverage. It starts producing effect in 10 to 20 minutes, peaks in 1 to 3 hours. Intermediate tail covers the intermeal and fasting sugar. So dosed with major meals in BID or TID when required, it targets PPG very early and achieves HbA1c reduction very early in the course of treatment. What is the evidence to support the premix usage in postprandial control? Initiate the RCT which compared bias 70-30 compared to glargine once a day. In insulin naive patients on OADs, it was a trial which was conducted for 28 weeks and algorithmic titration was applied. So at the end of 28 weeks, premix produced HbA1c of 6.91 compared to 7.41 of basal. So there was a 0.43 difference in HbA1c. So HbA1c was achieved by more number of people compared to basal, and there was a higher incidence of minor hypoglycemia and weight gain in premix users. So whenever there is HbA1c more contributed by prandial sugar, starting premix or co-formulation is a very pragmatic solution. Another trial, 4T, treat to target in type 2 diabetes trial, premix versus prandial versus basal was compared. 708 patients were randomized who were on metformin and sulfonylurea. They were given either premix BID, prandial TID or basal detamir. So 1 year data was very encouraging for premix. So A1C was 7.3 for premix, 7.2 for prandial and 7.6 for basal. So hypoglycemia and weight, again if ignored, then A1C was better controlled with premix and prandial. Further to that, in 3 years, after intensification as needed, proportion at 6.5 was lower with biphasic compared to basal and prandial. So as you go on with the duration of treatment, the picture may look different, but ultimately the game is about titration and adjustment of the dose. So if you educate the patient, you can get good result with premix in fasting and postprandial sugar both. So further to this evidence, several RCTs initiation with premix can reduce A1C more than basal only when PPG is dominant. So hence the checkup of PPG sugar is very important. Meta-analysis show overall similar A1C with premix versus multi-dose regimens. Differing profile of FPG and hypoglycemia is of course to be considered. Clinical choice should reflect dietary pattern of the patient, cultural pattern of the patient, baseline A1C, hypoglycemia risk, patient's preference and choices, and capacity and affordability. So all these factors guide us in choosing the insulin. So who will benefit from premix while starting in insulin naive patients? So people who have got high baseline A1C more than 8.5 with marked PPG excursion are likely to benefit most. Who have predictable lifestyle, predictable mealtime and predictable diet, they are the fit people for receiving premix because they have predictability in their all the aspects. High carb dietary pattern typically in India encourages us to use premix more compared to basal. This is a condition, like this is a slide for people who have never used bias, but I think our crowd is always using premix, so this we can bypass. This is the comparison between premix and basal on multiple virtues. HbA1c, for example, is better controlled with premix compared to basal. PPG control, of course, is better with premix. Fasting control as a primary effect is better with basal insulin compared to premix. Hypoglycemia is higher in premix group compared to basal. Weight gain is higher in premix group compared to basal. Number of injections, premix has 2, basal has 1. But with time, basal is always insufficient and we need to have boluses added to that. That ultimately becomes more number of pricks, which is less preferred by the patient. Basal insulin gives flexibility to the patient compared to premix. Again, this is a slide reflecting initiate and 4T trial where it was shown that people like HbA1c was better reduced with premix compared to basal. These are the essential guidance points to the patient. Educate on hypoglycemia, recognition, management, review SMBG and CGM patterns and guide them. Meal regularity is very important while prescribing premix. You should ask them to be predictable as far as calorie contents are concerned. Increase more lower GI food and fiber. Injection technique has to be inspected for all, but more so with premix, site rotation has to be advised. Take home message is that high PPG excursion patients need premix right from the outset. That leads to better HbA1c and less complications in future. Thank you very much.
Before time.
It is not right time to talk on all. Actually, alcohol guidelines say that you can consume this much, you can consume this much, this is safe, this is unsafe. There are so many guidelines. But actually, WHO recommends that you should not drink alcohol. And that is the take-home message of all this. Depending on there is a global context. There are a lot of people consume alcohol. There are cultural differences, big differences, region-wise also. This is also a status symbol now. Alcohol consumption has become a status symbol. हम क्या एक पार्टी में ही जाते हैं, बाकी तो नहीं करते हैं. ऐसा बोल के people used to take alcohol almost every day in a week. Suppose if you ask the patient how many days do you take alcohol, he always say no, I will take only one peg in a week or like this. If he says one, he must be consuming 3. That is very sure. And the percentage of alcohol which has been recommended scientifically, if you want to take it safely, is 25 to 30 grams of alcohol. So what is the 25 to 30 grams of alcohol? It is hard drinks. They contain 40% of alcohol. It is a 40%. That means you can have maximum 70 ml. It is a 2 drinks. For male, it is 2 to 3 drinks. And for females, maximum 1 drink. It is allowed. That is 30 ml. So there is a gender difference also. So you have to be very cautious in telling the patient, because patient will definitely ask you, "Arey doctor sahab, bahut studies aaye. It is supposed that alcohol is very safe, and particularly red wine le lo, red wine se kuch." Basically, we try to compare ourselves with the Western culture. When you are comparing ourselves with the Western culture, Western people, what they do, they sit there for hours together. They will consume a glass of wine for 2-3 hours. But here, wine also people used to consume like anything. They are drinking it like a water. So that becomes a problem. And because there is no, people always think that there is some literature, it also comes in the newspaper and all these things. So people will go according to that. So there are worldwide alcohol use remains widespread across. I will not go much detail. I will try to complete in next 10 minutes. These are the dietary guidelines from America. This is nutrition communication. Adults of legal drinking age, that means the age more than 18, choose not to drink or to drink in moderation by limiting intake. 2 drinks. 2 drinks means 30 ml, 2 drinks. 1 drink is supposed to be 30. It is not 60. So maximum you can have 60 ml, so it becomes less than 30 grams if you count percentage wise. And for men, and 1 drink or less means, if less means that you should not drink, females particularly. But if you want to take 1 drink is allowed to take for females. And there are certain positive effects. It is said to be the cardiovascular effect, then it is mental satisfaction also. It is said that it gives a social drinking, we call it as. So you can have maximum 1 to 2 drinks for male and less than 1 or 1 drink to the females. Drinking less is better for health than drinking more. There are some adults who should not drink alcohol at all, particularly the patients who are diabetic. There are chances of getting high hypoglycemia very much. So you have to be, so this is the low risk alcohol drinking guidelines, 2 standard drinks per day for females. And what happens now in our culture, suppose somebody is taking a drinks, he will ask, अरे डॉक्टर साहब ने 8 दिन तो कुछ नहीं लिया, तो 8 दिन का एकदम लिया तो चलेगा. That becomes a common question which will be asked by the patients. So if he takes, it is a binge drinking, and binge drinking is worse. It is not allowed. So if the patient asks you, you are allowing me to 1 or 2 drinks, so I will drink 10 pegs in a day. It is a binge drinking. Binge drinking is bad. WHO recommends no alcohol. Level of alcohol consumption is safe for any type of patients, male or female one. This is a positive health view. There are different studies which suggest that alcohol is little safe. It prevents cardiovascular morbidity and mortality and all these things. But it is these studies. So these are the controversies. I have been asked to talk on controversies. There are certain positive things, certain negative things, but maximum are negative things. So you have to keep it in mind. Advise adults with diabetes and those at risk for diabetes who consume alcohol not to exceed the recommended daily limits. Advise abstainers to not to start drinking alcohol even in moderation. Educate people with diabetes about the signs and symptoms of hypoglycemia, because these patients are likely to go for hypoglycemia. This is about percentage of alcohol. How much beer contains is almost 5%. It is about the hard drinks, and it is almost 40% if you all other drinks. And wine, it is almost 12% of alcohol. So foreigners, they drink 200 ml of alcohol, wine. 200 of ml of alcohol, it becomes a 24 grams of alcohol. So maximum amount of alcohol you can drink is 25 to 30 grams. So alcohol metabolism, all of us know that alcohol gets metabolized in the liver, so I will not go into the details of this. What are the potential benefits of moderate drinking? There are different studies which say that you can have a moderate drinking. Or moderate drinking means how much it is? It is 1 to 2 drinks for a male and 0 to 1 drinks for a female. More studies say that improved insulin sensitivity with the wine. Moderate drinkers may show reduced cardiovascular risk. Light alcohol intake sometimes linked to longevity. Wine with meals shows beneficial metabolic outcomes. And red wine back there was a plant is going to increase. If the patient is diabetic and if you do his sonography, you are going to get fatty liver disease. The fatty liver disease there and you are alcoholic, there are chances of getting liver transplant in particular people are very high. So relationship between alcohol consumption, it is a J-shaped one. There is epidemiological evidence that prospective cohort studies offer mixed conclusions. So risk reduction only seen in select subgroup of patients. There are not all patients who are, their risk is reduced. So you have to be very cautious in that. Impact on glycemic control, alcohol impairs gluconeogenesis. We know that liver is the factory of gluconeogenesis and it is going to affect there. So there is no gluconeogenesis, the chances of getting hypoglycemia are high and these patients are likely to go for hypoglycemia. The risk is especially high with insulin therapy and particularly the patients who are on sulfonylureas. Insulin secretagogues. These patients are more likely to hypoglycemia if you are consuming large amount of alcohols and because of alcoholic liver disease. The association of habitual alcohol intake with risk of cardiovascular disease. Alcohol consumption at all levels was associated with increased cardiovascular risk. Clinical and public health guidance around habitual alcohol use should account for the considerable differences in cardiovascular across different levels of alcohol consumption, even those within current guidelines. What are the cardiovascular effects of the alcohol? A light alcohol use once linked with lower cardiovascular risk. But there are so many controversies. Some studies say that it reduces the incidence of cardiovascular risk is increased. Another few suggest that because of obesity and all these things, there are chances of getting more cardiovascular risk. Alcohol contributes to hypertension and endothelial dysfunction. Many patients, if you take the history of patient who is hypertensive, if he consumes alcohol almost every day, there are chances of getting uncontrolled hypertension are very high. The dose-response relationship appears to be non-linear and complex. Moderate drinkers often are healthier due to lifestyle modification. Basically, these patients have a guilty feeling. And if you go on the go for a jogging or swimming, half of the people who are drink yesterday night, they are there for a swimming. Because they have got some guilty conscience. Then overall cardiovascular risk increases at higher consumption of alcohol. So this is another study, alcohol consumption and cardiovascular risk. Possible that this is observational studies may overestimate the benefits of alcohol for cardiovascular disease outcomes. Moderate wine consumption is probably associated with low cardiovascular events. It is a probability. There are many co-founding factors, in particular lifestyle, genetic and socio-economic associations with wine drinking, which likely explain much of the association with wine and reduce cardiovascular events. So this is about the alcohol use and cardiovascular diseases, scientific statement from the American Heart Association. If how much alcohol you are consuming, the effect on blood pressure, effect on coronary disease, effect on stroke and atrial fibrillation. You can see here, the randomized controlled trials, heavy alcohol increases the incidence of atrial fibrillation. Observation it exceeds more than 1 drink per day, the chances of getting atrial fibrillation are comparatively high. Even sudden death, these are randomized control. These are the different studies which already I spoke, so I will not go into detail of that. This sudden death, if you consume 1 drink per day, there is chance of sudden death is less. But if heavy consumption is there, the chances of sudden death are high, because patients are likely not only for atrial fibrillation, the patient may go for arrhythmias, different type of arrhythmias. This is controversial. Mechanism of insulin resistance, moderate alcohol improves adiponectin sensitivity in some studies. Chronic intake increases the insulin resistance via hepatic effects. NADH accumulation alters hepatic insulin signaling pathways. This time, visceral adiposity worsens with prolonged alcohol consumption. So patient may go for obesity and other metabolic syndromes like dyslipidemia and hypertension. And the mechanism, intermittent binge drinking disrupts glucose insulin dynamics. So there are chances of getting hypoglycemia in this and uncontrolled diabetes as well. The mechanistic findings differ between rodents and. This is a liver-brain axis of neurodegeneration hypothesis. You know that ethanol acts on liver, then there is a steatohepatitis, it causes insulin resistance, then there is a release of cytokines causing insulin resistance and inflammation and neurodegeneration, and there is a direct neurotoxic and metabolic effects which lead to insulin resistance, and ultimately it leads to the neurodegeneration. So this is the liver-brain axis of alcohol-related disorders. Effect of alcohol on cardiovascular risk factors, which already I have spoken in details. Mostly moderate intake causes decreased oxidative stress, reduction in blood pressure, increased HDL cholesterol. Excess intake causes increasing glutathione, excessive intake causes other hypertension and increased triglyceride levels. Mechanisms, lipids and inflammation, HDL increase seen with modest alcohol intake. Inflammatory cytokines are elevated with chronic use. Alcohol disrupts lipid particle size and function. Acetaldehyde contributes to endothelial inflammation. Oxidative stress burden increase in metabolic tissues. Impact on liver health, all of us know that these patients are likely to go for cirrhosis and hepatocellular carcinoma if not stopped at earliest. The relations between alcohol consumption, BMI and type 2 diabetes, you can see the conclusion here. Potential predictive effect of alcohol use against type 2 diabetes seems to be specific to women in general and women with BMI above 25. The implication that BMI and alcohol are both involved in development of type 2 diabetes. The sex difference, we know already, I spoke of that. The youth and adolescents, early alcohol exposure alters metabolic set points. Adolescent drinking linked to adult obesity. So take the history of adults, people who are obese, they give a history of alcoholism. Elderly and alcohol use, we know that elderly people, if they consume excess of alcohol, they go for hypoglycemia. There are chances of getting fractures and they become serious also. The binge drinking, I already spoke to you about this. Interactions with anti-diabetic drugs. This is an important slide. Alcohol interacts with sulfonylureas and chances of increasing hypoglycemic risk. So patients who are on sulfonylureas and insulin, the chances of hypoglycemia are very high if they consume alcohol and they doesn't eat much. SGLT2 inhibitors with alcohol may increase ketoacidosis. GLP-1 receptor agonist plus alcohol may impair gastric motility. Patient must be warned about pharmacological interactions. The personalized advice is crucial based on treatment risk. Obesity and alcohol, we know that if you consume excess of alcohol, there are alcoholic fatty liver diseases and chances of metabolic syndrome are high. Genetic variability, already I spoke to you. Cultural, religious perspectives, I will not go in detail. The clinical recommendations are important. Abstinence remains the safest choice for patient with metabolic disorder. If drinking, it should always be with food. Patients should avoid binge or episodic heavy drinking. Women face greater risk at lower alcohol exposure, and people with diabetes require tailored clinical counseling strategies. Discussion must include risk of hypoglycemia and weight gain. Guidelines changes. The global bodies increasingly recommend lower use of alcohol. Canada now advises 2 drinks per week maximum. So they are changing guidelines continuously. WHO wants no safe level of alcohol. They say don't drink alcohol. Guidelines shift driven by cancer and CVD data. US dietary guidelines under periodic expert review and shift towards more conservative alcohol thresholds globally. What are how you are going to counseling these patients? Ask patient directly about alcohol consumption. Encourage monitoring of glucose continuously after drinking. Warn about interaction between alcohol and medications which are taking. So many patients are on sulfonylureas or insulin, so you have to warn them about chances of getting hypoglycemia. You have to warn them about getting hypertension and obesity, and advocate these patients about avoidance of drinking on empty stomach, and document discussion regarding alcohol use in medical records. Thank you very much.
Very much, sir. I call all the speakers to come on stage. Alcohol adherence during travel.
Good evening, all of you. Yes, thank God. We 5 of us on the stage and 5 of us in the audience side. Yeah, and we appreciate the previous speakers who are waiting to listen to us. Thank you. And 4 audiovisual people are there. So it is very nice. We thought we can have a roundtable discussion, but luckily there are some people in there. Anyway, kudos to this organizing committee, Dr. Manoj, Purvi, Bansi and the entire team for this wonderful conference. Welcome to our panel discussion on in-hospital diabetes management. So we have an esteemed panel of experts with us, Dr. Vinod, Dr. Seema, Dr. Sonali, Dr. Reshma, and Nadia. Welcome to our panel discussion. And the audience expect your expert insights and experiences on managing the diabetes in the in-hospital setting. So all of us will agree that diabetes is a common comorbidity among the hospitalized patients. It affects around 40% of the inpatients. So in-hospital diabetes management is crucial to prevent adverse outcomes such as hypoglycemia, hyperglycemia, the increased length of stay. But diabetes management in the hospital setting can be challenging due to factors like variable oral intake, medication changes, and stress-induced hyperglycemia. Yes, ADA says there are concerns in managing the hyperglycemia, the hospital setting. That is, the hospital, both the hyperglycemia and hypoglycemia, they are associated with the adverse outcomes, including death. Admission. On admission, if the blood sugar is more than 200 milligram percentage, there is a higher risk of complications and death, even in the non-ICU setting. And diabetes and the complications. Diabetic patients are associated with the complications, most of them. These complications, severity increase the hospitalization and increase the treatment cost. So, critically ill patients, they are associated with higher rate of mortality. So, there is a twofold. The severity of the blood glucose increases, there is a higher risk of mortality, twofold, threefold, and fourfold. Yes, hyperglycemia is very common in the critically ill patients, and glycemic targets, many guidelines they are accepted. Fasting and the pre-meal less than 140 milligram percentage, random blood sugar less than 180. So what is the mantra when you want to treat a patient, inpatient with the diabetes management? One mantra is either no hypoglycemia or minimal hypoglycemia. So we need to choose the therapy, choose the insulin, probably modern insulin, analog insulins, to minimize the risk of hypoglycemia, because even a single episode of hypoglycemia associated with lot of cardiovascular outcomes, adverse outcomes, and there is a risk of mortality within the 1 year of the discharge, and also the risk of hypoglycemia, one episode of hypoglycemia is the hospital stay and everything. So let us move on to there are a lot of questions in the patient management, diabetes management. Actually, this topic will need minimum of 1.5 to 2 hours, concise to 30 minutes. So let us take up some 10 questions, important challenges. Each one of the experts, they will take up 2 questions. At the end of the all 10 questions, if there are any question, we can take up. To Dr. Seema, yes, all the patients on admission, we used to do a random blood sugar. This is a quite common thing. Do you want to stick on to only random blood sugar, or you want to add HbA1c on admission?
It's a very practical question that HbA1c testing recommend ADA and society, although it is not compulsory. So I will divide my question as 2 and why should we. HbA1c should be done all patients who are diabetic and who have not done blood sugar in last 3 months. Second category of the patient would shows 40 blood sugar on admission. Third category, those patients who have, morbidity, factors, metabolic syndrome, obesity, and who come with the acute. So in all those patients, we must do HbA1c. Now, why should we do? Number one is all diabetic patient. It will show that whether your diabetes was under control or not. So those, and secondly, whether patient has developed high blood sugar now in the hospital or whether patient was prior to that. So it will differentiate between a diagnosed diabetic patient and a stress hyperglycemia. Secondly, this will also tell you, the HbA1c will tell you in a diabetic patient that patient's blood sugar was under control or not. If it remains high, that means it was, it was very high, uncontrolled, and patient will intensify. We have to intensify. And it will also decide the line of treatment. Patient may need HAs or insulin for a longer time, get the better out.
Exactly. Well explained. One more thing, undiagnosed diabetes also, because many of our patients, they don't do any test at all. They may be a diabetic, undiagnosed. On admission, when you do it, you can detect the undiagnosed people also.
So basically, if we check the sugar, it is high, but HbA1c is normal. Yeah. So that will tell you it is a stress hyperglycemia.
Exactly.
So if the HbA1c is high and sugars are also high, that will tell you the chronic glycemic status of the patient. That patient is a diabetic and it was not under control.
Absolutely, ma'am. Absolutely. Yes, we are talking about blood sugar and we are talking about HbA1c. Now the latest metric is CGM. Yes, all of us agree that CGM is very, very useful in the outpatient setup and well documented. What about the role of CGM, the inpatient management? Dr. Nadia.
Thank you, sir. Thank you for your. So I think in today's world, CGM continues very important, especially in a hospital. It can be different for the ICU. So let's start with the wards. So firstly, we need time and every 1 to 5 up to like. So gives our patient multiple, like if our patient comes in that is one. Second thing, save the staff stress of continuous. Most of our patients are not us. Show us the alert. There is a hypoglycemia. It shows us trends. There are multiple benefits. Yes, at this critical can have a lag of such case of our patient sepsis. That and that time we.
Yeah, you are absolutely right, ma'am. For the outpatient setup, it is well established. It is documented according to all the guidelines. But no guidelines support the use of CGMs, the acute illness, ICU patients and surgical patients. So, future it may come at us on date. That is the use of the CGMs for the acute patients is not advisable. But you can use for the stable patient who are eating regularly a non-ICU setup, whereas it does not replace point of care glucometers. With the CGMs, now then we can cross-check with the glucometers. To Dr. Vinod, Yeah, now it is era of using the GLP-1 receptor agonist, and nowadays we are using the tirzepatide as well as semaglutide, everything. This type of patient, when you come to your nursing home and you get admitted for acute illness, how will you manage? How will you, what is your approach?
Is going to face for a patient. Well, again, basically first important thing to know the problem I mean for surgery will need anything medical condition guy reason will the patient is ICU, so mostly most of them need to stop. Then any patients with their problem, vomiting, kind of people. Only patients who are stable, not have any GI problem. But again, it has to be with strict monitoring so that whom we stop GLP-1 and we have to learn about it just.
Yeah, you have beautifully covered all the points. Wonderful, because it is a era of higher use of GLP-1 RAs. So we have to educate our even our the primary care physician. To Dr. Reshma, yeah, we are talking about the hypoglycemia. Hypoglycemia, a common issue with the insulin, everything, and so we need to prevent it. We need to manage it. How you are going to educate your patient and staff nurses, and how you are going to prevent and manage.
So hyperglycemia has many adverse outcomes. The hospital stay, mortality, so also hypoglycemia. You really need to identify it and prevent it. In fact, you showed a very interesting slide, sir. One episode of hypoglycemia is going to mortality to the tune of 64% and overall mortality in future to a great extent. So it's really imperative on our part as well as way we educate our RMOs, nursing staff and the patient attendant also. So primarily we need to identify what are the causes of hypoglycemia. And I think iatrogenic hypoglycemia is an important cause for inpatient hypoglycemia since patient is on insulin. And there are other causes like it could be patient factors, severely ill patient or a patient with multi-organ failure or a patient with renal or hepatic disorders for that matter. We all know that they are prone to more hypoglycemia. Overzealous treatment with insulin. We have this binding on us, in hospital setup to give a good glycemic control to the patient. So that also causes overzealous treatment which can lead propensity for hypoglycemias. It has adverse outcomes. It can lead to cardiac arrhythmias and seizures and brain damage, and these all cause mortality for that matter. So how you are going to prevent the hypoglycemia? And another thing is chronic diabetic patients may also have hypoglycemia unawareness, because of which the symptoms could be masked and the patient can fall a prey to an episode of severe hypoglycemia. So I think good monitoring strategies, instruction to the staff basically to monitor the pre-meal glucose levels and only then to give the shot of insulin is very imperative. I suppose the patient's attendance needs to be educated thoroughly, and of course CGM should come in handy especially in a non-critical care setup to prevent episodes of hypoglycemia. In fact, what I found was when we are giving the basal bolus regimen, the addition of basal insulin, for that matter glargine, can also lead to episodes of hypoglycemia, which I have seen practically. So we need to taper and titrate the doses of the shock-acting insulin in a proper way to manage.
Exactly. So we need to educate our staff nurses. It is very, very important, and documentation is very, very important. Sometimes double the dose, that happens, so many things. The analog insulins like Tresiba, everything, double dosing doesn't make much impact. Whereas with Dedimer and Glargine, everything, double dosing causes a risk of hypoglycemia. So we have to educate our patients about the signs and symptoms of hypoglycemia, and our staff members, they should be well versed identifying and managing the hypoglycemia. Wonderful, man. Dr. Sonali. So, inpatient management, there are a lot of regimens. Some of the patients, most of the patients in India, they are very fond of premixed insulins. One talk was there with the premixed insulin. Most of the doctors, they prefer premixed insulin both in the outpatient and the inpatient setup, and they land up in a lot of hypoglycemia. What is a regimen you prefer, and what type of patients? Wonderful. Sometimes when the patient is on enteral feeding, continuous enteral feeding, for those patients we can go for only long-acting basal insulins. Sometimes in intermittent feeding, we need to go for basal bolus. So depending upon the situation, depending upon the patient needs, you are absolutely right. We can decide whether basal only or basal bolus with the correctional. Thank you, ma'am. Dr. Sima. Yes, the role of the OHAs and the insulin. Many of the patients on steroids, corticosteroids, they develop hyperglycemia. We are in the outpatient, we are using for mild hyperglycemia with the steroids, we use glycoside, etc. For the inpatients, when they develop steroid-induced hyperglycemia, will you prefer OHA or OHA plus basal bolus? What is your opinion, ma'am?
Steroid-induced hyperglycemia very commonly seen in patients, especially with the glucocorticoids like prednisone, dexamethasone, alprazolam. So we have to make sure that the blood sugars are maintained between 180. So hypoglycemia. Then we have to plan the strategy if the blood sugar is high. Now we have to decide whether the patient prescribed or insulin. So in the hospital setting, generally oral hypoglycemic reason being that they have delayed onset. In the hospital setting, we need to control. It is unpredictable with the OHAs. Also, some patients, we don't know the intake of patient whether. So, depending upon that, if we give oral or glycemic agent, patient may go hypoglycemia. Also, certain drugs, you have to be choosing hypoglycemia. Thing like metformin, we generally don't give in hospital setting if the patient has underlying hepatic impairment. Secondly, with SGLT2 inhibitors, patient can have dehydration, ketosis, genital urinary infection. Sulfonylurea can cause hypoglycemia, especially when patients. These three, maybe DPP4 inhibitors can be given in those patients where stay is short in the. So DPP4 inhibitor are still preferred. Coming to the insulin part, preferred therapy, steroid induced. And again, it will depend on type of and the time of steroid. Now, suppose if the patient is on shorter acting, like prednisolone, which if we give in time can cause, action. Generally, we give action NPH insulin. That put the action and matches, and we can. If the patient is on longer acting insulin, like pentyl prednisone, then in such patients, generally basal insulin and to cover hyperprandial add bolus insulin. Generally, therapy is preferred.
Yeah, well explained, ma'am. Some of the stable patients, clinical condition is very good. Eating is good. Then for those patients, you can go for once daily prednisolone 5 milligram. For those patients, we can very well use glycoside 40 milligram. That matches pharmacokinetic effects. As you rightly pointed out, for other patients, patient is not taking food properly or high hyperglycemia, all those things, then it is ideal to go for basal and bolus insulin. Recently, there is one study from the European Institute of that is Internal Medicine. They have shown that patients are taking steroid induced hyperglycemia, poor glycemic control with basal bolus insulin. For those patients, instead of increasing the dose of the basal bolus, they can go for this NPH insulin. Yeah, that insulin. This is a recent report. But whatever may be, whether we are using basal bolus and adding the NPH over and above, we need to have a go for a regular monitoring. That is very important. Thank you, ma'am. Yeah, Dr. Nadia, yeah, patient with heart failure and hyperglycemia, inpatient setting. Outpatient setting, you used to give SGLT, DAPA or EMPA for the cardiovascular benefits and the prevention of the, that is heart failure, hospitalization, everything. The same patient, acute heart failure, when it admitted with hyperglycemia, what is your takeaway? Whether you will continue the DAPA or EMPA or initiate or withhold? What is your opinion?
At the edge. Yeah, you're right.
Yes, ma'am, you are absolutely right. But only one thing I would like to add on it. In patients, acute heart failure, acute illness,
we avoid.
yeah, we have to avoid because there is a high risk of diabetic ketoacidosis, all those things. So outpatient setup, okay. Inpatient, we have to monitor. Once acute crisis is over, the patient becomes stable, then we can initiate the DAPA or EMPA at the time of discharge for the long-term benefits. Thank you, ma'am. Yeah. Dr. Vinod, yeah, stress hyperglycemia, and what is it? How will you define? How will you manage?
Stress, hypoglycemia, and increase. By the stress hormones. The discussion. HBO. HbA1c can help to hyperglycemia. Even with stress hypoglycemia, targets which to what blood sugar, heading hyper. Mostly would that I and finally our last point was that the reassessing at the time of discharge. In many cases they come back to normal after reassessing them and then giving prior to discharge.
Yeah, well covered. Carry your message is on admission, doing the HbA1c is very important to differentiate between this and that. But Reshma, most of the nursing homes, even today in our part of the country, they use sliding scale insulin regimens, and many patients they land in hypoglycemia, lot of risk, everything. So we need to educate. What is your opinion between the sliding scale insulin and basal bolus insulin?
Well, sliding scale technique, I think it's akin to a Hindi scene where the police come after everything is over.
Exactly.
Yeah. So once the damage is done, there's hardly any point in, intervention. So it's like a retrospective.
Reactive.
It's retrospective, but we need to be proactive and prospectively prevent hyperglycemia for that matter. It is obsolete. No guidelines recommend it, but unfortunately, in most of the even international hospitals all over the world, I mean, sliding scale technique is still used by the resident, by the physician, by the consultant. Like a knee-jerk reaction, sugar बढ़ गया तो फूको insulin literally, sir. The 20 units, 25 units, 30 units, and then the patient lands into hypo. So there is always a fluctuation between hypos and hypers. There is never a smooth control. Most of the studies show that it is ineffective. So it is obsolete. It needs to be abandoned. Basal bolus technique or the regimen is any day implemented. But most of the residents or the staff, I feel, is for the fear of hypoglycemia that they are implementing this technique. In a person with no prior history of diabetes or stress hyperglycemia for that matter, where we are not sure about the insulin requirement, I think a low dose bolus regimen should be started, and it should be titrated likewise, and so that even hypo and hyper can be prevented in a more efficient way.
You quoted a cinema movie also, very nice of it. It is actually for many of the staff members, nursing staff, this sliding scale is easy for them. That is the only advantage. Otherwise, it's not physiological. And also it is a reactive one. Our basal bolus is a proactive one. We have to prevent the hypoglycemia. So we have to educate our staff members. That Sonali is a final one. So adjusting the insulin doses based on the blood glucose fluctuation during the patient set. And how do we ensure medication safety and prevent the mistakes in the insulin injections during the hospital?
Whatever.
Wonderful. Mostly nowadays, previously in India, only U40 vials are available. Recently, we have U40 as well as U100. So matching U40 vial plus the U100 syringe. Many of the friends in the abroad, when they come out, they bring some U100 syringes. Patient will be using the U40 vial. That is a mismatching is a problem. And selection of the site rotation, needle multiple use, so many things are there. Some of our patients during the inpatient setup, outpatient, they give the injection through the clothing, all those things. So a lot of things are happening. So we have to sit with the patient, educate our staff nurses and tell everything. Then only we can overcome all these issues. Thank you.
I think, sir, for preventing any kind of medication error, it is important that we follow the 5 R's of giving a medication. That is the right patient, right medication, right dose, right route. I think if this is implemented properly, most of the errors can really be prevented.
Exactly. When the doctor is willing to spend some 10 minutes with the patient, is more than enough. And our staff nurses should be very, very sincere to the patient, then it is okay. Thank you all the expert panelists for the wonderful deliberation. Thanks a lot.
Thank you to the audience too.